right. Good morning. I'm calling this performance oversight hearing to order. I'm at-large Councilmember Christina Henderson, Chair of the Committee on Health. Today is Monday, February 3rd, 2025, and the time is 10 a.m. Today is part one of the Department of Behavioral Health's performance oversight hearing. We will only hear from public witnesses today. Dr. Bazran, who is the director of the Department of Behavioral Health, will be before the committee on Wednesday, February 5th at 9:30 a.m. Dr. Bazran is here and her team is watching and listening, and I'm sure they'll try to respond to the concerns and issues that are raised today. The Department of Behavioral Health, or DBH, provides prevention, intervention, and treatment services and supports to children, youth, and adults with mental and or substance abuse disorders, including emergency psychiatric care and community-based outpatient residential services. DBH serves eligible adults, children, and youth and their families through a network of community-based providers and government services. DBH manages the district's school-based behavioral health programs and also operates St. Elizabeth's Hospital, the district's public inpatient psychiatric facility. DBH engages in important and challenging work grounded in conviction that the district can recover from mental and substance abuse disorders. DBH strives to help them lead healthy, happy, and successful lives. The committee sent written pre-hearing questions to DBH, and we'll reference those materials. We may reference those materials today. Certainly we'll reference them on Wednesday. For anyone who would like to see those materials, they can be found on the council's hearing management website, dccouncil.gov/hearings. I don't see any of my colleagues who are here, but I'll turn to them as they arrive. Given our witness list today, all witnesses are going to have 3 minutes to testify. Now, again, that is not because we don't find whatever you have to say to be important or lovely, but if you've seen the witness list today, I've got nearly 90 people who want to share things, and I would like to go home at a reasonable hour, as I'm sure all of you would as well. So I'll give you a nudge when your time has expired. If you have signed up to testify virtually and you're here in person, please check in with Ashley, just so that we can know. One of the things that I'm going to have to do today to keep it moving is if I call on you and I miss you, I won't be able to add you to the next panel. I will give you an opportunity to speak at the very end. So I hope everybody can just stay focused with us on today. I have 4 seats here, and so we're going to call the first panel of witnesses. Carrie Savage from Senior Director of Policy and Advocacy at PAVE, Chris Gamble, Behavioral Health Policy Analyst at Children's Law Center, Jacqueline Werner, Supervising Attorney at Disability Rights DC at University Legal Services, and Justin Palmer, VP of Public Policy and External Affairs for DC Hospital Association. Good morning to you all. Okay. Carrie, when you're ready.
Good morning, Chairperson Henderson, members of the Committee on Health and committee staff. My name is Carrie Savage, and I'm the Senior Director of Policy and Advocacy at PAVE. PAVE is a member of the Strengthening Families Through Behavioral Health Coalition, a coalition committed to ensuring that DC children, youth, and families have access to a fully integrated behavioral health care system that meets the needs of the whole child. That last part, meeting the needs of the whole child, is what I want to emphasize today. We are in extremely challenging times, and the only way we are able to move forward as a city that should be a state is if we take care of our kids. Their future and the future of the district depends on it. First, I truly want to celebrate DBH's work to expand access to mental and behavioral health supports for our kids. Most recently, Dr. Bazran was immediately responsive to ensure that students at Learn had access to behavioral health supports available, as their school sits less than a mile from the site of the most recent devastating plane crash. That type of responsive leadership is something we desperately need in these challenging times. I also want to thank the DBH team for always being open and willing to have conversations with families about their needs, concerns, and ideas. You will hear from a few PAVE parent leaders today, either in written testimony or live throughout the hearing. And I just really I was reading their testimonies in advance of this, and the need for this is so real. The way that they have fear for their kids traveling to and from school, the way that they have fear accessing behavioral health supports at the school now, not sure how the billing process is going to work, what's going to end up, what conversations are going to be communicated, at risk of sharing confidential or private information about students who are navigating their own personal identities, whether it be LGBTQ, worries about what's coming down from the federal administration. The fear is real. And I think that the supports that from the Department of Behavioral Health can provide are so essential. And I hope that we will continue to stay in conversation to make sure that those connection points get made. Going off the cuff from my testimony, and I'll send the full one later. I just can't emphasize enough how much these conversations about true information sharing with families and making sure it gets to them is so important. I think there's a wide, disparate spectrum of families' knowledge and understanding of how they can access mental health supports from their schools. There's some schools that do it extremely well. And then there's some where there's frustration around billing, around availability, around who can see a clinician and who cannot. In these moments where kids, it is literally a life or death moment for them to be able to access those supports or not, more often than not. And I hope that we bulldoze through those barriers or challenges to make sure that kids are able to get the support that they need. So thank you.
Thank you. Mr. Campbell.
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Chris Gamble. I'm a behavioral health policy analyst at Children's Law Center, a Ward 5 resident, and a licensed professional counselor with experience providing behavioral health care to children, teens, and families in DC. Thank you for the opportunity to testify today about DBH's performance over the past year. Children's Law Center's team of guardians ad litem represent over half the kids in DC's foster care system. Over a quarter of the children our GALs represented last year were diagnosed with behavioral health conditions. We want our clients and all children in DC to receive the services best fit for their needs, but in the past year, services overseen by DBH have not expanded in the ways necessary, with some even shrinking in availability. For instance, community-based intervention, or CBI, which is a time-limited intensive service intended for children with significant behavioral health needs, is reaching fewer of those children. According to DBH's own service utilization dashboard, 198 children received CBI services in FY24, a 19% decrease from the previous fiscal year. Decreases have occurred year after year since FY20, when 500 children received the service. Further, the number of organizations providing CBI services has also decreased, from 7 providers in FY23 to 5 in FY25. This diminished capacity tracks with the experiences of our clients who in the past 2 years have waited months to access CBI services or have not received the service once enrolled with a core service agency. However, DBH states that there are no reports of waitlists or service gaps with CBI. We asked the committee to seek clarity from DBH regarding how the agency collects data on CBI availability. We also have concerns about the state of the behavioral health workforce due to almost a tenth of our GAL clients experiencing care access issues due to staff turnover in the past year. DC Health's FY23 data shows that there are over 10,000 behavioral health professionals licensed in DC. But because we don't know where these professionals work or what they do, we don't have a clear picture of the extent to which they are fulfilling the needs of our public system. There's potential that the problem DC's public system faces is not simply an issue with the supply of behavioral health professionals, but also their distribution in the job market. We ask that DBH collaborate with DC Health in using the workforce survey data collected when health professionals renew their licenses to better inform workforce development actions. My written testimony includes additional points about lacking services in the continuum of care, concerns related to child crisis services, and DBH's strategic plan for children's services. Thank you for the opportunity to testify today, and I welcome any questions the committee may have.
Thank you. Ms. Werner.
Good morning, Chairperson Henderson and committee members. Thank you for this opportunity to testify. My name is Jacqueline Werner, and I'm a supervising attorney at Disability Rights DC at University Legal Services, the designated protection and advocacy program for people with disabilities in DC. Pursuant to our federal mandate, DRDC advocates on behalf of hundreds of DC residents with mental illness each year. My testimony today is focused on 3 areas that I will touch on briefly and that are discussed in more detail in our written testimony. First, DRDC notes that DBH appears to be significantly understaffed and that this is being felt by the public. It is DRDC's understanding that DBH has had reductions in force over the past year, including DBH's entire claims auditing team. It's clear that these staffing reductions are placing a strain on DBH internally, as well as impacting staff's ability to timely address consumer concerns externally. I know this isn't unique to DBH, and I know this is performance oversight and not budget. However, especially given current events, this is not the time for the department that is tasked with providing mental health and substance abuse services to thousands of DC residents to be this strained. As we progress into budget season, we simply note that these concerns need to be thought about. Second, given that DBH itself has been sounding the alarm on extensive provider Medicaid fraud in recent years, DRDC urges the council to ensure that DBH provides more detailed and accessible public information on provider performance measures. Currently, when a consumer needs to connect to a DBH certified provider, generally the most accessible information that's publicly available to consumers is just a list of the names of each organization, their office addresses, and whether they provide child and youth services. There's no other easily understandable and recently available public data that a consumer can refer to in order to assess the quality of services that each provider offers, nor is there a way to determine in what specific areas each provider most excels or most underperforms. DRDC recommends that DBH work to publish more easily consumable and accessible information for the public. Finally, DRDC urges the council to ensure that DBH addresses ongoing concerns with children and youth services. One area of concern is that we continue to experience and hear from youth and their families about the long wait between service enrollment and service delivery, reflecting an ongoing capacity concern. For example, DBH shared in last month's Children's Roundtable that currently the district is serving 103 families through intensive care coordination, which is the highest level of community-based youth mental health services, while the two current ICC providers reported approximately 60 open slots. It's concerning that with a district population of roughly 126,000 youth, only 103 children, which is less than 1%, are receiving these services. Preventing unnecessary institutionalization for children and youth will only be possible if DBH can provide the appropriate capacity of services for youth and do so with fidelity. Thank you again for this opportunity to testify, and I welcome any questions.
Thank you. Mr. Palmer?
Good morning, Chairperson Henderson and members of the Committee on Health. My name is Justin Palmer, and I'm the Vice President for Public Policy and External Affairs at the District of Columbia Hospital Association. I appreciate the opportunity to present testimony at the Department of Behavioral Health's FY25 Performance Oversight hearing. A comprehensive behavioral health system requires residents to have access to critical resources that ensures every person in the district is able to thrive. Having mental health and substance use services accessible to individuals requires having them available at the right time and location. DCHA and our members have partnered with DBH on several initiatives. One of the longest standing programs being the screening, brief intervention, and referral to treatment model to address opioid use. Since the beginning of the SBIRT and hospital-based peer support initiative in June of 2019, over 1.2 million screenings have occurred with 56,641 brief interventions and over 16,000 referrals to treatment. Our hospitals have reported 6,733 linkages to treatment. The program has expanded to include not only the emergency rooms, but inpatient units as well. Last year, MedStar National Rehabilitation Hospital began naloxone distribution, and Children's National Hospital is establishing a universal screening for patients 12 to 21, as well as hiring a peer recovery coach. As we continue to grow this program, the availability of peers continues to be a challenge. This is mostly because these individuals with lived experience are in very high demand, and existing peers are advancing in their careers to new positions and opportunities. At the beginning of my testimony, I noted the importance of ensuring access to treatment at the right time and right place. This is especially true as we seek to link patients to care. The more organizations that conduct assessments at their site rather than requiring referrals to the ARC streamlines the process. Moreover, we have to look at options for referrals outside traditional hours to ensure more convenient linkages to care. The opening of the DC Stabilization Center continues to have a positive effect on our members, but more importantly, the people it serves. This resource provides individuals with proper level of care and needed supports without unnecessary trips to the hospital. We look forward to the second Stabilization Center opening to build on this great work. Our ultimate hope is still that the stabilization centers will eventually evolve into combined crisis emergency services centers to provide stabilization for residents, whether they're in need of substance use support or emergency psychiatric treatment. Speaking of behavioral health capacity, we are grateful for the department has reopened all the beds at St. Elizabeth's. We are concerned that a growing number of admissions into St. Elizabeth are being reserved for forensic admissions, limiting the hospital's ability to take civilly committed patients. To be clear, this is not the fault of the hospital, but it is a symptom of that the capacity at St. Elizabeth's may be too small for the community need. In DC, we continue to see a growing need for intermediate level care for children and adolescents in an effort to avoid admission to a higher level of care when they can be cared for out of the inpatient environment. It is clear from the adolescent patients hospitals are seeing that additional community and residential providers are needed to appropriately care for them and avoid hospitalization. Thank you for letting me testify today, and I'm happy to answer any questions.
Thank you. Thank you to all the witnesses for your testimony. I'm going to put my own self on a clock just to keep things moving. Mr. Gamble, thanks for being here. I wanted to ask if you all have run the numbers in terms of how, like, the average length that your clients have been waiting to get in for CBI?
I would have to refer back. So our GAL team does what they call a deep dive into the data with their clients over the past year. So I would have to have those numbers in front of me to give you any specifics, but I can get back to you with that.
Okay, that would be helpful to know. I understand a reduction in going from 7 providers to 5 providers can be big, but also wanting to understand just how long some folks have been waiting, especially given that particular population where going through this type of service with CBI is part of their court-ordered, right? Like, they can't get to the resolution until they finish this piece. And if it's taking months to finish this piece, then it's taking a longer time for family reunification. Ms. Werner will obviously ask some questions about staffing. I do have some concerns. Not specifically about the claims audit team. That's interesting. We'll dig into that a little bit more, but just sort of overall. But thank you so much for being here. Ms. Savage, I look forward to the testimony from the PAVE parents. I'm curious in terms of, access to support. You mentioned billing, availability, and these types of things. Are you finding differences more from LEA to LEA or school to school, which is a little bit different?
Yeah, thanks for the question. I would say it's both, honestly. But I think, and I say both specifically for DCPS in terms of information sharing, that still varies widely school to school. I think policy and procedures vary more differently from LEA to LEA. But like, I will highlight as a bright spot, Tubman Elementary has always done a fantastic job of information sharing with their families. I've consistently heard that people understand the supports, what supports are available, who to go to and how to access. And there's essentially a no wrong door information channel where folks feel like they can get connected to supports, but that isn't true everywhere.
Okay. Well, I'm also curious, is there a difference in age band? So, right, I look at the end of my witness list, I have a lot of high school students who are coming to testify.
Yeah.
I know that what they might say might be very different than a parent in an elementary school setting, and who, the parent is more driving it in the earlier years, where in the later years, it is the young person who's more driving it and needing to sort of get this information, if you will.
Yeah. I mean, I think there's a tension, and particularly as students get older, to your point, where high schoolers might be interested in accessing the supports, but not having that same communication with their parents. And there might be reasons for that, right? Like, they might be asking for support that they're not yet ready to discuss with their parents. And so the dynamic there is very difficult. And I think that's especially true. I brought up the insurance piece. We have just heard across the board about how confusing it is. Who's eligible for what the end bill is going to look like, how that's going to result for parents. And happy to follow up with more specific examples based on parents' anecdotes specifically. But to me, it's hard to even give you here's what I see as the main problem in the fix, because it spiders out in so many different directions based on school, LEA, grade band, the nature of the request for behavioral health support just goes in a lot of different directions.
Okay. Thank you. And Mr. Palmer, thank you so much for being here to represent the hospitals. Everything you said is things that they've said to us as well, particularly about St. Elizabeth's capacity. We've heard that largely from PIW and some of the others who have a larger behavioral health unit. And so we'll ask some questions about that. But I don't have any further questions today. Please, if you haven't submitted your written testimony for the record, just go online and upload it. Thank you so much. All right, we're going to go on to the next panel. Scott Goldstein from Empower Ed, Johnny Howard, Patricia Quinn, and Leah Caslis. Okay, great. All right, Scott, when you're ready.
Thank you. Good morning. My name is Scott Goldstein. I'm the Executive Director of the DC teacher organization Empower Ed. Empower Ed is a member of the Strengthening Families Coalition. And every day Empower Ed is working to support DC schools with the well-being and retention of their staff. We fundamentally believe that educator well-being and supports student well-being, and student well-being supports educator well-being. This vital connection is also why we believe it's important for DBH to continue to support staff well-being and to play more of a role in coordinating the approaches that schools are taking to student and staff mental health and wellness. Empowered is also a member of the DC Coalition for Mental and Behavioral Health in Schools, DC COMS at GW, where I am co-chairing a pilot group aimed at considering how we communicate about mental health and wellness in the district. DC COMS has brought together the key actors in this space across organizations, service providers, advocates, policy experts, and more. We all know that the crisis we face with clinical staffing shortages. That's why I believe it's essential that we employ a two-part strategy of both strengthening the pipeline and bolstering non-clinical supports in schools, like wellness coordinators. As we do so, we must consider student and staff well-being as part of the same initiative. In too many schools, these efforts are treated separately, which has the effect of duplicating teams, siloing mental health and wellness staff, and failing to coalesce around an approach that goes beyond putting the bodies in the school and truly integrating holistic services, policies, and practices. For example, in schools we work with the wellness approach for staff, it can include things like strengthening emergency communications and ensuring a durable response for traumatic events that goes beyond the 24 to 48 hours after the event. This approach isn't just for staff. It has to be a cohesive one with the approach for students. That means staff wellness plans established through partnerships like Empower Ed have to sync with the comprehensive school plans and school strengthening plans. It also means staff members providing mental and behavioral health services cannot be so isolated. This fall, at the invitation of the Momentum Residency, we hosted a conversation between Momentum residents and current teachers. It was clear in the conversation, as it is in our daily school interactions, how a lack of intentional inclusion of these staff and the full staff can cause friction and harm our ability to better serve students. We would love to do more of this work to bring cohesion to a staff and student wellness approach and further integrate behavioral health staff into the culture and fabric of the full staff. So we hope DBH will consider investing in this type of work and approach. One direct thing we should do is to provide a minimum $1,500 compensation per school year for the school-based behavioral health coordinator role at 254 schools. We should also consider other non-clinical roles. And while DBH's educator wellness programming is very valuable, these events and communications don't always reach the farthest possible audience, and perhaps more focusing on supporting organizations to go into schools, coordinating an approach between behavioral health staff and the full staff would have more of an immediate impact. These efforts should be coordinated with efforts across the government to support a whole school, whole educator, and whole child approach, like efforts at OSSI and within DCPS. I'm grateful for DBH's work in this space, but hopeful we can continue to build towards a more integrated, holistic approach in the year to come. Thank you.
Thank you. Mr. Howard.
Good morning, Ms. Henderson.
Good morning.
First and foremost, I'd like to thank God of my understanding for me being here. And as you know, I advocate for those that are in the criminal justice system with mental health and addiction. We seem to have a problem of understanding. And I'm finding that because mental health don't know addiction, or addiction don't know justice, it's not coming together as it should to work for the betterment of the residents here in DC. I think at this moment, let me say to Dr. Bazaron that I have fully funded, because when you talk to Dr. Bazaron, her first question, how you gonna fund it? With Dr. Bazaron, I can tell you that if you implement the sequential intercept model, if you allow the forensic peer specialists to take their place in public safety, it can look a lot better. It can look a lot better. And so far, we haven't been able to use our workforce development of those that come from the criminal justice system in the Department of Behavioral Health. Dr. Bazaron, I took the certification. To offer me a job on a temp company, it's not right, Dr. Bazaron. It's supposed to be supportive employment. All these years, that what's been going on in the past, I would ask you to look at it and correct it. And but you got a doctorate degree. I'm a non-clinician. I understand my role. I am competent enough to implement the sequential intercept model in accordance with the Department of Behavioral Health, if you like to. Look, I took my medicine this morning. I think I did good. I didn't cuss or fuss. So let me be quiet. Thank you, man.
Thank you, Mr. Howard. Ms. Quinn.
Good morning. Patricia Quinn, Vice President of Policy and Partnerships at the DC Primary Care Association. Thank you for the opportunity to provide testimony on the oversight of the Department of Behavioral Health. DCPCA and our member health centers confront an unprecedented federal regulatory environment. DCPCA redoubles our commitment to ensuring that the district's community health centers can continue their life-saving work to provide the highest quality, comprehensive primary care to every patient who crosses their thresholds. Every person in our city deserves access to the individualized, high-quality health care, regardless of their background or circumstances. DCPCA seeks to ensure that every health center patient with behavioral health needs can get the appropriate level of quality treatment across the continuum of care. As previously reported, our providers need a system that supports tailored referrals to patients with higher acuity needs that cannot be met within all community health centers. A return to the robust and well-staffed Access Helpline is a key element to that continuum of care. We understand that the helpline is just one of the staff functions at DBH, decommissioned when MCO carve-in was expected, that need to be restored. The uncertainty of federal funding adds to the need for staffing flexibility in order to maintain access. DBH should review the regulatory staffing requirements under its control and consider where allowances for mixed licensed and unlicensed teams and scaled staffing ratios could improve access while maintaining high-quality behavioral health care. DCPCA provided a letter of support for DBH's application for Certified Community Behavioral Health Center Planning Grant. The award of the planning grant to the district should allow providers to partner with DBH and the Department of Healthcare Finance to develop a model of payment and care delivery that meets the needs of DC. As a member of the Opioid Abatement Advisory Commission, DCPCA is invested in pursuing evidence-based innovation and securing resources for infrastructure using opioid settlement funds. We continue to advocate that the OAAC invest in housing for unsheltered residents with SUD. We also urge implementation of a planned contingency management pilot. Robust research shows contingency management efficacy in increasing adherence to and retention in treatment and reducing reuse. Thank you.
Thank you. Leah.
Good morning, Councilmember Henderson. My name is Leah Kaslas. I'm a senior policy attorney at Children's Law Center, a resident of the district, and the co-chair of the Strengthening Families Coalition. I'm testifying today on behalf of Children's Law Center. The district has made a strong commitment to ensure every DC public and public charter student has access to the full range of behavioral health services through a multi-tier system of supports model. Broadly speaking, school-based behavioral health programming is executed through two avenues. First, directly by DBH school-based programming, which includes the expansion program clinicians, DBH clinicians, and DBH clinical specialists. And second, at the individual school level, as determined by school leadership and their own financing. The investments across all of school-based programming have been critical, and we are starting to see them pay off. The Youth Risk Behavioral Survey shows improvements. For example, the percentage of high school students who made a plan about how to attempt suicide or who actually attempted suicide decreased in the last 4 years. Middle school students also experienced a similar positive decrease. However, we still know there is some way to go given continuing behavioral health needs. The most recent Child Trends data shared 50% of high school students, 52% of middle school students, and 44% of elementary school students reported having a behavioral health challenge or need. With growing improvements but continued need, we want to ensure these investments continue. DBH has been proactive in recruitment and retention of school-based behavioral health professionals, including offering free supervision, partnering with OSSI's Aero Grant, and engaging in pipeline development. We know, however, we are still not meeting our goal. While there are many reasons for this, we have, in partnership with DBH, identified some main areas of focus for improving DBH's expansion program. First, we must assess the true amount a CBO is able to bill and compare that with the current funding model for the expansion program. Second, we must understand the expansion program in the larger landscape of school-based behavioral health services. We appreciate that DBH has shared in their pre-hearing responses to more openly share the billing data from CBOs, recognizing that this level of reporting will inform any necessary shifts or revisions to funding structure for the expansion program. We ask that this committee support DBH in their ongoing efforts to assess the funding model and to ensure it is done expeditiously and with transparency. Finally, we ask that in partnership with all the relevant school-based behavioral health stakeholders, that they work together to establish a tool to consistently and systematically track the behavioral health services being offered in schools to better understand where the district is meeting students' needs with access to the 3 tiers and where there are gaps. We have made some significant progress already, and together we can continue to ensure every public and public charter student can access the multi-tiered services of support. Thank you for the opportunity to testify. I welcome any questions.
Thank you. Thank you to this panel of witnesses. I want to follow up, Ms. Casals. We've had conversations about the funding model for school-based behavioral health. And something that Ms. Savage brought up earlier is things that we've heard, right? The billing pieces, how do folks get access, and all of these different things. I'm curious if you've had any follow-up conversations with the department about retooling this program such that it can work more effectively than this sort of farce where we say we've got school-based behavioral health programs in every school, when in fact we don't have clinicians in every school.
Exactly. And I think we have had some really great conversations with DBH in that. And I know in their pre-hearing responses and in our conversations, they are really open to really understanding what the billing has been, because right now the model, right, relies on CBOs, I think, to minimally bill 30% to cover the costs, right? So the grant covers part of it, and then they need to bill to make up for that. But we know that they are still struggling to actually meet at cost of what that is. So CBOs are choosing to leave the program, or they are not, or they're reducing the number of schools they're in and whatnot. We also know that different schools have different billing needs. And so can we build in some more flexibility? And so they have been open to those conversations, which we really appreciate. And I think the other piece to that is also understanding this broader school-based behavioral health landscape, right? So DBH is one of the key players in this, But schools and LEAs also have a role to play because they are also bringing in their own behavioral health professionals. And so they are also engaging in an environmental scan right now of what tiers are happening in each school. And I think that will really help us inform where the gaps are. And so we can figure out what programming we need to actually meet those gaps.
Okay, what's the timeline on all of this stuff? Because I mean, we could
Yeah.
be paying for something for another 2 years while an assessment is taking place.
Exactly. So I will definitely turn it to DBH to share their exact timeline, but our understanding is sooner rather than later. So one of the things we do talk about in our written testimony, which I will submit shortly, is that in the next year, we probably won't have all this information. That's, just the reality of the timeline. And so raising the minimum grant amounts for the time being of the schools that we are in for the expansion program could be very helpful. And then minimally, maximally, or whatever the right word is, by FY 2027, really having it set in place what a better funding model for this program would be.
Okay. Ms. Quinn, I think for the primary care providers, they can name any number of things for which grievances around the system, right? Whether it's not enough providers, licensing, reimbursement rates, et cetera. When it comes to the Department of Behavioral Health, though, what would you say is the top 1 or 2 things that performance-wise can be done to help improve the work for the frontline staff in the primary care field?
I think it is the continuum of care. Not all community health centers can have the appropriate treatments for people with severe and persistent mental illness, be they young people, children, adults. So our providers really need to know the rest of the system is accessible and that they have clear pathways for how to get their patients into that care. And that the helpline used to be a very important resource for that and seems to be less available in terms of the kind of tailored referrals that health centers used to be able to find.
Yeah, but we asked DBH, they said nothing has changed about the Access Helpline.
I just know from the provider end what providers have told me that they don't feel like they have the same kind of robust information coming out of that referral line that they used to have.
Okay, thank you. Mr. Howard, thank you for being here. The silos that you discussed around mental health addiction in the justice system, I think is spot on, and it's something that we have been trying to address in terms of who's talking to whom or not, right? To the extent that DC Health, DBH, DOC, CSOSA, all of these various agencies are having conversations with one another to address the co-occurring issues. I think what you raised is right. Spot on. That wasn't a question. It was just you were right. Thank you for your testimony, for being here. And Mr. Goldstein, thank you for your testimony and for your continued advocacy on both the student and staff well-being. This is not a budget hearing, but I took note of your specific budget ask. But thank you all. I don't have any further questions. If you could make sure you have your testimony for the record. All right. Irma Washington, Teresa Washington, Charlotte Simpson, and Rachel White. Sure. No. Good morning. No. Okay, I know that's Rachel. What's your name, ma'am? You're Irma. Okay. And your name, ma'am? Okay, Charlotte Simpson. Okay, so Teresa Washington is not, she's not here? Okay. All right, is Rachel Hollander here? All right. All right, Kristen Ewing? Okay, Ms. Washington, when you're ready, just hit the button in front of you.
Good morning to the DC Council and the Behavioral Health Oversight Board. My name is Irma Washington. I'm coming to speak on behalf of my grandson, Jacob Washington. Jacob is 2 years old, and he lives in the District of Columbia with his mother, Teresa Washington. Teresa lives at 5320 East Street, Southeast. Miss Wash, I'm kind of like gonna add it in so I do this all the time in Montgomery County, so when I get nervous, I'm sorry. Okay, so I'm here because Teresa Washington is diagnosed with an intellectual disability and schizoaffective disorder. She's the mother of Jacob, and she has been, let me see. Okay, and she's the mother of Jacob, and I adopted her out of the DC system about 27 years ago, 28 years ago. On April the 20th of last year, Teresa also received services from New Living Behavioral Health Services. On April the 27th last year, Mr. Hines and Mr. William Grayson Sr. and Miss Angela Grayson entered Miss Washington's home and took her son, Jacob, from her house with no explanation and told her that she wasn't going to get him back. Mr. Grayson is Teresa's original biological father. His rights was terminated 28 years ago due to severe behavioral neglect and behavior and violence and domestic. Mr. Grayson is also a registered child sex offender. He lives in Baltimore. When I called Mr. Hines and asked him why would he give Jacob to the Graysons and not call CPS, he pretty much told me to mind my business. I asked him what was the reason that he was taken from the home. He would not answer, even though I am Teresa Washington's immediate contact. Ms. Washington doesn't have any kind of help. She doesn't have any legal help. Now they have taken her to court. They want her to pay child support. Even though there is not an open CPS case against Ms. Washington, they're treating it like it is. If I'm rambling on, ma'am, it's just because I don't need to. Okay, and so at that time, after I got involved, they decided to discharge Ms. Washington. I started to ask about her, why wasn't there some things put in place like mommy programs, things like that to help her so that she could be a better learned mother. When you're a mother and you're suffering from mental health, it could be very bad. But if you're a mother, you're suffering from mental health and you're in a behavioral health service, it could be good, depending on the people who want to give you or let you help you with the services. I started to ask Mr. Hines from New Living, what happened? Really nothing. Okay, what happened was Mr. Grayson and Teresa tried to reunify each other. When they saw her son, his wife and him decided that she wasn't a fit mother and took her child from her. This was in cooperation with New Living and also the guardian ad litem that they end up getting for Jacob. They end up discharging Miss Washington, and now she's with Community Connections. The person that she sees is Miss Princess Brown. Miss Princess Brown has missed 2 scheduled appointments that she scheduled for Teresa Washington. I'm here today to talk because I'm notified of Ms. Nicole Brown with the Department of Health and Human Services. She's been helping me trying to get Teresa some legal help to go to her courts. I've gotten so many programs for her, the mommy program. I've connected with Consumer Network. They're willing to take her Wednesday to help her. All these programs that I did in 2 months, I couldn't understand why it couldn't have been done by the behavioral health services that are put in place to be done for her. I was really, really disappointed. The reason why my daughter's not here today, and I'm gonna make it, because she went to court on the 29th. And if I wasn't there, she was by herself. She has an intellectual disability. She can't process. It takes time for her to process. She can't read the packets. And then they look at that as being, she's still inefficient to take care of her son. Even though when they took her son, the police was there and there's no police record that there was abuse or neglect, anything wrong. They went at night, in the middle of the night, to grab him out of his crib. There is no records of any kind of, there's no open case. So I'm asking you today, that CPS be involved, if possible. I'm asking that you investigate why the behavioral health services that she was getting took it upon themselves to take Teresa's son out of her house. What is the protocol when it is a neglect case? What do? Do they just step over DC and run over to Baltimore and say, here, I'm gonna give you a kid, and then I'm gonna give you a name? I wanna know why the contractors feel that they don't have to follow the same procedures and everything that everyone else, even the police, have to. So I'm gonna be finished, I know.
Yeah, Ms. Washington, I'll let you go on, because I think this is important. So, a couple of things, and we're gonna get to the rest of the witnesses. Someone from my team is coming upstairs. They'll talk to you after that. Dr. Bazaron's sitting right here, but her staff is right there. They're gonna follow up with you as well. If, at the very least, we're gonna make sure you get connected with legal aid before you leave, so that your daughter can get some representation at Superior Court. Okay? All right. Just hang on. They're coming.
Thank you.
All right. All right. Ms. Simpson? Oh, Ms. Simpson, I just need you to hit the button right. Okay.
Sorry.
There you go.
Good afternoon, Chair Henderson and committee. I'm Charlotte Simpson, a 58-year DC resident living in Ward 5 and a constituent member of Fair Budget Coalition. Thank you for allowing me to address you today with my ask regarding DC's behavioral health services or lack of adequate service for the residents burdened with such illnesses and the lack of adequate readily available help. This past July 3rd through the 5th, 2024, I personally went through a real hell. I had a family member who lives with me in a drug and mental health crisis. I called the case manager from his community behavioral health service provider who did not know what to do because no needed service for that situation existed as an impending holiday was approaching hour by hour. As you can clearly see that I am totally disabled and helpless. We cannot get the person admitted into a proper facility for care because it does not exist in DC at holiday time. That is why I'm here before you today. The person nor I should have been left in that crisis with no available resolution, none. It should never happen again in DC. This cannot be allowed. These persons are human beings. The civil, human, and social rights of people should dictate that we have services to provide for such issues 24 hours, 365 days a year, no matter what else is going on in the domain called Washington, D.C. It reeks of disenfranchisement, negligence, and irresponsibility. It looks like, feels almost criminal, and like unjust punishment that's totally unacceptable. Your constituents expect trust and depend heavily on you to correct this crucial situation. Please don't dismiss this possible life and death service. It's far from a joke. I repeat, my ask is that DVH, make it a priority to establish, provide for, and implement the necessary provisions to fully develop staff and employ the required actions to activate the needed service. There has to be distinguished designated facilities, certified, trained medical and behavioral staff, open 24/7, 365, required long-term psych therapy treatment and follow-up to help deter recidivism, possibly linked to their Medicaid and SSD benefits, required participation as a resident, 24-hour coverage for intake workers to just start. More beds in psychiatric care facilities needed. Better training for caseworkers in the community behavioral health centers and oversight of the assigned psychiatrist diagnoses and treatment plan. Warehousing not acceptable. More support for people with dual diagnosis, addiction and mental diagnosis is required. Such improvements will require substantial funding, but we need it desperately. If you can't find the funding at this time, I urge you to increase taxes on wealth, which can supply what is required to sustain this healthcare service. We need all communities to be contributing their fair share to the well-being of residents with behavioral health needs. I thank you for your time, for your sincere consideration of service expansion.
Thank you. Thank you. Ms. White.
Good morning, Chair Member Henderson, and members of the Committee on Health. Thank you for the opportunity to testify today. My name is Rachel White, Deputy Director of Youth Advocacy at DC Action, and I'm here to highlight the barriers to mental health services for youth experiencing homelessness and advocate for the Department of Behavioral Health to provide co-located behavioral health services at youth homelessness service sites. Youth experiencing homelessness have unmet behavioral health needs. DBH pre-hearing oversight responses report that they served 81 youth under the age of 21 who self-identified as homeless in fiscal year 24. However, this vastly understates the true scope of the need among youth facing housing instability. Many young people experiencing homelessness do not disclose their housing status due to stigma, fear of systems involvement, or the limitation of intake assessments. DBH relies on the annual point-in-time count in conjunction with DHS and the Interagency Council on Homelessness to develop the engagement and outreach strategies. However, the point-in-time count only provides a one-night snapshot and does not fully capture the transient nature of youth homelessness. But based on the PIC count alone, there were 583 youth ages 18 through 24 who were experiencing homelessness in January of 2024. We know that homelessness and mental health challenges are bidirectional and that youth experiencing homelessness have significantly higher rates of suicide, depression, anxiety, and substance use disorder than our unhoused peers. 49% of DC's unaccompanied youth experiencing homelessness report impaired mental health. Despite these alarming numbers, youth remain underserved and disconnected from the district's behavioral health system. While DBH has initiated an informal partnership with DC Doors, the only 24-hour youth homelessness drop-in center in DC, to provide initial assessments and linkages to community agencies offering behavioral health services, this approach should be extended to all youth homelessness providers. Currently, the partnership consists of a two-person team visiting the drop-in center twice per week to conduct brief assessments and connect youth to external services. But there are key shortcomings of the current approach. Limited availability of DBH staff, and youth who receive referrals must still travel offsite to receive continuous therapeutic services. However, even a pilot expansion will not go far enough. To truly meet the needs of people experiencing homelessness and housing instability, DBH must ensure that regular co-located therapeutic services are available on site at all youth homelessness programs, providing immediate, consistent care where youth are already seeking support. Co-located referral service has already shown success based on personal counts of participants at DC Doors and DBH team where they provide the brief mental health assessments and connection, but expanding this model into a permanent citywide framework that meets the full mental health needs of youth experiencing homelessness would allow for immediate access to trauma-informed health, increased engagement by embedding mental health in services where youth congregate, and lastly, better coordination of services between DBH and youth homelessness providers. By bringing behavioral health services directly where youth experiencing homelessness are at, DBH can remove critical barriers to care and ensure young people receive the mental health support they need to transition. Thank you for your time, and I welcome any questions.
Thank you. Ms. Ewing.
Good morning, Chairwoman Henderson and staff. My name is Kristen Ewing, and I am Policy Counsel at the DC Appleseed Center for Law and Justice. Much of my work focuses on health equity and working toward a more equitable, just, and thriving city for all district residents. As part of my work, I am a co-chair for the Strengthening Families Through Behavioral Health Coalition. My testimony today will center around youth behavioral health, including school-based behavioral health. Behavioral health services provided at district schools are crucial for prevention, intervention, and treatment, as well as for lessening the disparities in access to care. We know that behavioral health support is vital to district youth, especially as we have seen increases in suicide, substance use, depression, and anxiety in juveniles in the last several years, with behavioral health conditions exacerbated by issues such as public safety, gun violence, socioeconomic forces, and residual impacts from the pandemic. We are grateful we have seen some improvements in certain behavioral health areas related to youth, a testament to the district's prior investments in youth behavioral health. However, pediatric mental health continues to be a top concern for healthcare providers, families, educators, and the youth themselves. School-based behavioral health can play a vital role in meeting students where they are to provide necessary care to address the myriad issues facing our youth today. The Strengthening Families Coalition believes that every school should be able to offer multi-tiered systems of support to all students to meet their ongoing needs at all levels. However, only roughly 59% of DC schools have a dedicated clinician, and that clinician often cannot provide all the services and supports we know our students need and deserve. Therefore, the district must continue strengthening school-based behavioral health by supporting and retaining clinicians and other staff who provide all levels of services in district schools and prioritizing filling vacant positions. Given the anticipated pressures of the district's budget for the coming year, DBH should focus on matching clinicians into schools with the greatest need. We are grateful that DBH is prioritizing understanding the current behavioral health landscape in schools. Conducting a holistic landscape analysis of the current behavioral health care offered and utilized in each school will assist the district in identifying service gaps and prioritizing clinicians and programming for the schools that have the greatest need. We encourage DBH to continue this work and hope that OSSI, DCPS, and charter schools will partner with DBH to ensure a timely and accurate understanding of the current behavioral health services offered. We also know each school's behavioral health coordinator is integral to the school-based behavioral health ecosystem. Coordinators help students, families, and educators effectively navigate the behavioral health resources in their school building. We appreciate the work DBH is doing to support these roles, and we urge DBH, as well as OSSI, DCBS, and charter schools, to continue supporting the staff performing the coordinator function, as it is key to a robust, efficient, and easily accessible school-based behavioral health system. While we want to continue and increase the logistical, procedural, and moral support of these roles, as a preview to our budget asks, we also want to ensure the staff performing these currently unpaid roles are compensated for the extra effort and time these roles require. Thank you for your time. I'm happy to answer any questions, and my written testimony will be uploaded shortly.
Thank you. Thank you to this panel of witnesses. I want to just ask a couple of follow-up questions. Ms. Simpson, when you were experiencing the situation with your family member, you called the case manager and not crisis response or another entity?
Thank you. My family member is an adult. My family member is not always cooperative. And I'm not in any position to throw anybody on the floor, holding them down to keep them from hurting themselves or me. So what I did, because I know of the case manager, I've met him, and he seems to be a reasonable person. So I called him immediately for help. And I don't mean to be disparaging about him and his credentials, but he seemed to have known not very much more about a situation like this than myself.
I see.
And rather than call the police and have it become a police monitored handled situation, I thought I was doing the right thing because he goes to preventive measures. And I am less than thrilled with what I have observed, knowing this young man since he was a baby. And before they realized it wasn't just ADHD, that it was finally developing into full-blown bipolar. And he likes marijuana, but he decided he'd go for crack. And that's when everything went to hell and back. And I did not have any other thoughts or means of what to do other than let me get his case manager. Surely he knows what to do.
No, I mean, I think that, for folks who don't want to involve the police, that might be an option for them. We do have other services. And so I feel like on our end, we failed in terms of making it known to you of other places that you can call that don't involve the police, but can help in terms of de-escalating a situation. And so, I think the further part, the recommendations of your testimony around the need for more facilities, 100% agree with you. We held a hearing specifically on that in the fall and continue to push that conversation in terms of, how do we provide residents support in the whole continuum of care, right? They may not need to be at St. Elizabeth's, but may need partial day hospitalization or some other type of thing to help support families. And I don't think we've necessarily done our best job of making sure that there's a full continuum of service options that are available. But thank you for testifying today and bringing your story forward. Before you leave, though, let us give you a number of if this occurs again, so that you can call someone. 988 is also available as well, and they could help direct as needed, but also call crisis response too.
May I just add a kudos to some. I tutored for them or reentering citizens some years ago, but I did call them and their director had her staff working past their hours of work, trying to help find a place where we could get him taken to right away. So I'd just like to say she did all she could to help me, even though he's not a part of their program. So there are some people who take it to heart.
Thank you. Ms. White, thank you so much for testifying and for your continued advocacy on behalf of youth experiencing homelessness, but also needing services as well. I think I mentioned this before. I think we have a good model for this in what we do for the Pathways program, which is, it's not individuals who are experiencing homelessness, but nonetheless, they're part of the Pathways program, and we have a provider who comes directly to them, to their location. And I feel like perhaps that could be a way for us to sort of work that forward. Let's keep talking more on that. Ms. Ewing, thank you so much for the work of DC Appleseed and for being here. If everyone could make sure you submit your written testimony for the record. Ms. Washington, I haven't forgotten about you. Where's Anna? Right over there. That's my Director of Constituent Services. She'll help get you connected with legal aid to get some additional support for your daughter. No one should have to go to court alone, especially when there are programs that are available. All right. So, she'll come around and connect with you over here. Okay, awesome. Thank you so much to this panel. Thank you. Yep. And Ms. Simpson, there you go. Dr. Basner is right there. She's gonna give you a card. Oh, no, I thought it. Okay. Then we'll do it on the next one. Okay. All right. Nene Taylor, Executive Director of Harriet's Wildest Dreams. Frankie Seaborn. Jillian Buford. All right. So Rachel is going to read Rachel Hollander's testimony. Apologies. And then we'll go on from there. Okay, Rachel, whenever you're ready.
Hello, my name is Dr. Rachel Hollander, and I'm a pediatrician based in Washington, D.C., and a current policy fellow with DC Action. I'm here to reiterate the bidirectional relationship between housing security and mental health. Youth homelessness is a crisis. It is deeply rooted in structural, systemic, and policy failures. During 2024, 1,516 DC youth were serviced by the DC DHS homelessness system, which equates to approximately 63 classrooms full of children who, instead of having safe and secure housing, at some point experienced the trauma of homelessness in the last year. Childhood is a time for growth and development, for establishing and strengthening connections in the brain that foster how children grow into adults. Studies consistently show that toxic stress and trauma included by experiencing homelessness can permanently alter those connections in the brain. As a pediatrician, I see the impact of homelessness on my patients. I have seen an adolescent in the emergency room who was physically assaulted while living in the tent on the side of the road. I've seen a child with complex medical needs who could not be discharged from the hospital because the ventilator they required to breathe could not be safely supported in a shelter. I saw a teenager in my clinic who attempted suicide because they did not have a safe place to live, and so many more people with unique experiences of their own, highlighting the detrimental effects of homelessness has on their health. My 17-year-old patient with her 1-year-old child, both living in a shelter, told me of her dreams for her child. She wished for her child to live a life where he would know that he had a bed of his own. She wished her child would always have food to fill his belly. She wished that she could have a lock on their door to make sure the violence she experienced would never come for her child. She wished he could graduate from high school. She had so much hope for her child's future, but she also could not help but feel that this hope was unattainable. I diagnosed her with major depressive disorder that day, a diagnosis all too common among people experiencing homelessness. Although I could offer her support, a shoulder to cry on, a discussion of medication, initiation, and the benefits of therapy, I could not guarantee her comprehensive mental health services. Again, another system had failed her. Homelessness is an epidemic. The effect of homelessness has on mental health impacts each individual in unique ways. We must act to support youth experiencing homelessness and reduce barriers to provide them with access to safe, consistent, and culturally competent therapeutic services in the location where they congregate, which is why I support DBH establishing co-located behavioral health units for youth experiencing homelessness. With this program, we can provide one more layer of hope and support that youth experiencing homelessness all deserve. Thank you for your time and your support of DC Youth Experiencing Homelessness.
Thanks, Rachel, for uplifting Dr. Hollander's testimony. All right, so we're going to ask Jasmine if she wants to join the table. Is Jasmine here? There she is. Okay. All right. When you're ready, Ms. Taylor, you just got to hit the button. There you go.
Councilman Henderson, thank you for the opportunity to address the DC Council today. My name is Nene Teller, Executive Director of Oversight Streams and a DC native. I'm testifying about the need for the city to overhaul the current mental health crisis response system and prioritize the health and safety of DC residents. Our current response system increases the likelihood of engagement with law enforcement for our neighbors in their most vulnerable moments. Mental health crisis should be approached as a matter of public health, not a judiciary matter. Community engagement in crisis response can make all the difference for a community member in need because we keep us safe. Hearst Riders Dreams is a Black-led abolitionist community defense hub centering all Black lives at risk for safe sanctioned violence in the greater Washington area. Our work includes legal empowerment, political and civic engagement, mass protesting, organizing campaigns, and community care that builds alternatives to oppressive systems. Our work is guided by our ancestors and centers on holistic healing and transformative justice. As an alternative to police being a first responder in our communities, I'm sorry.
Yeah, if everyone can silence their cell phones, thank you. We'll make sure you have extra time, Nene. Go ahead.
Okay. As an alternative to police being the first responder in our communities, our DC Safety Squad has trained over 60 community members, including DC youth in first aid mental health response, all of which has received their 3-year national certification. A first aid mental health responder is someone trained to provide initial support to individuals experiencing mental health crisis or distress. They are trained to recognize signs of mental distress, identifying symptoms of conditions like anxiety, depression, panic attacks, and suicidal thoughts or substance abuse. They offer a non-judgmental, calm, and supportive presence, de-escalate situations using active listening and crisis intervention skills to help reduce the stress while respecting boundaries and their privacy. The mental health responder promotes self-help strategies by the community member that consist of coping mechanism and self-care techniques. While encouraging professional help, guiding individuals to seek professional support, such as therapists, counselors, or crisis services. I want to say that again, we have trained over 60 community members to be mental health responders who are nationally certified. The mental health, I have personally witnessed so many situations that I feel could have had more of a successful outcome than death or a cage when the community member was experiencing a mental health crisis. Clifford Brooks should still be here. If DC implemented a comprehensive mental health crisis response system that prioritized community safety, on the morning of January 24th, 2024, 41-year-old DC resident Clifton Brooks was shot and killed by MPD officer Claude Jackson during transit to Washington Hospital Center from the Carver Livingston neighborhood Northeast. MPD made a life-ending decision when they felt it was not necessary to receive support from the Department of Behavioral Health because a trained crisis intervention officer was present. A crisis response trained cop is still a cop. Police officers are intended to be the solution to crime, not a mental health crisis. By prioritizing mental health professionals and trained community members as first response, we are interrupting engagement with a system that has contributed to generational harm. National Alliance of Mental Health reports that people suffering from serious mental illnesses are over 10 times more likely to experience use of force interaction with police than those without. This disproportionately impact is often due to officers misinterpreting the scene. Bottom line, people suffering from mental illnesses deserve compassion and care, not bullets. I'm glad that one day Jay Brown and myself was able to respond to a scene that never made the news as mental health responders. There was a man who was being pursued by MPD. The man made the decision to abandon the vehicle he was in and ran to the Intercosta River and placed a gun to his head. The man was surrounded by other men with guns who had a license to kill. After watching from afar for hours and being aware that DPH was not present, me having personal contact with some of the DBH professionals, because I actually be in the rooms when the family go to get told that they're not going to charge the cop. So, you know, we have to go down to DBH. So I'm familiar with some of the DBH people and have their cards. So I made the decision to use that card that day and ask why wasn't DBH at this scene. DBH showed up within an hour. But mind you, this man was in the river with a gun to his head and DBH wasn't there. Me making that phone call actually made it happen that a Black man made it home that day. I don't know what the outcome was. I don't know what the situation happened after that because it never was told and it wasn't none of my business. But I do know that a man survived that day. In less than an hour after DBH came, the situation was de-escalated in less than an hour. In closing, your constituents and their families are impacted daily by the harm police center, safety solutions, and police brutality and criminalization. It's past time for DC to invest in crisis and stabilization options that are distributed throughout the city to expand access to residents and give them more options regarding their care as opposed to state-sanctioned violence. Thank you.
Thank you. Ms. Sebron.
Councilmember Henderson and the members of the Committee on Health, thank you for the opportunity to address the DC Council today. My name is Frankie Sebron. I'm the program manager at Harriet's Wildest Dreams. I'm a third-generation Washingtonian, a mother of two, and a formal special education teacher. DC must prioritize mental health as a public health issue, not a law enforcement issue. Currently, the city continues to rely on MPD as first responders to behavioral health crises, despite the fact that MPD officers lack the necessary training to provide trauma-informed care. For example, in 2022, MPD was dispatched to over 36,000 mental health-related 911 calls, while the Department of Behavioral Health crisis response teams handle only a fraction of that number. The failure to divert these calls to mental health professionals has led to tragic outcomes, including the killings of Antoine Gilmore and Justin Robinson, both of whom were met with guns while asleep in their respective cars and fatally shot by police. We can also look at national stories like that of Sonia Massey, who, while she was going through a mental health crisis, was killed by police in her own home. More than 1 in 5 people fatally shot by police have mental illness. DC can make a different choice. We must. In light of the current administration and the recent pardons, MPD now has a license to kill without consequence. We must reduce our community's exposure to police, and this is especially true for those experiencing crises. Instead of criminalizing mental illness, DC must fully fund and expand non-police crisis response programs like the CRT, ensuring that behavioral health specialists, not armed officers, are the default responders. Otherwise, we will continue to perpetuate a system where mental illness is treated with punishment rather than care. Some of the key things that we can do: we can divert mental health crisis calls from 911 to appropriate care providers. We can train and dispatch mental health professionals as primary responders. We must establish a crisis care facilities as alternatives to emergency departments. And most of all, we have to improve the public awareness of the mental health resources like 988. 988 is drastically underutilized. Thank you for your time today.
Thank you. Jillian.
Good morning, Councilman Henderson. Councilmember, I'm sorry. Thank you for the opportunity to address you here today. My name is Jillian Burford, and I'm the policy organizer at Harriet's Wildest Dreams. I'm a Black-led abolitionist community defense hub working to improve the material conditions of Black residents across the DC area. I'm also a second-generation DC native and an MSW student at the Howard University School of Social Work with a concentration in community administration and policy practice. Today, I am here to urge the DC Council to adopt the People's Response Act to improve the city's current mental health crisis response system and strengthen DBH's relationships and trust within DC residents. Our current mental health crisis response system increases the likelihood of engagement with law enforcement for our neighbors at their most vulnerable moments. Mental health crisis should be addressed as a public health matter, not a judicial matter. According to the Washington Post Fatal Force Tracker, 10,429 people have been shot and killed by the police from 2015 to 2024, backing up hard truths that we are all too familiar with. Black Americans are killed by police at a rate that is more than twice the rate of white Americans, while only representing a measly 14% of the population. When breaking down the nearly decade's worth of data by filter, the data reveals that 20% of incidents involved a mental health crisis. Out of the 2,053 victims of poor crisis response with law enforcement, one name brings us back home to our own crisis in the district, 41-year-old Clifford Brooks. On January 24th, 2024, Mr. Brooks's life was cut short by MPD officer Claude Jackson, a 31-year veteran and crisis intervention officer, while in transit to Washington Hospital Center. After 2 hours of cajoling, Officer Jackson managed to get Mr. Brooks to agree to transport for treatment. What is unclear is how the event escalated into Mr. Brooks bursting out of the ambulance and Officer Jackson shooting and killing him on North Capitol Street, down the street from my family's home. What is unclear is that MPD's choice left Mr. Brooks's family fractured even further, shortly after losing 2 family members within 10 days of each other earlier that month. Mr. Brooks's sister, Denise Jefferson, asked questions that I myself have also wondered. How many attempts, if any, were made to provide him with sufficient resources ahead of engagement with law enforcement and the inevitable shooting? Why didn't MPD contact DBH for added support? While I do recognize that CIOs are a step in the right direction to ensure that DC residents in crisis receive support in intense moments, it is my responsibility to remind you all that a crisis-trained cop is still a cop and will respond as a cop. Someone in the midst of crisis will unlikely have the capacity to process and comply with an officer's commands, which leads to escalation. The National Alliance on Mental Illness reported that people with mental illnesses are more than 10 times more likely to experience excessive use of force during engagement with law enforcement. The Treatment Advocacy Center reported that people with mental illnesses are 16 times more likely to die as a result of these interactions. Through the People's Response Act, we can work towards building a comprehensive mental health crisis response system centered on community engagement. I am nearly at my time. My submitted testimony will provide deeper dive into the full benefits of the People's Response Act. Thank you for your time and your consideration.
Thank you. Jasmine?
Councilmember Henderson and members of the Committee on Health, thank you for the opportunity to address the DC Council today. I am reading a testimony on behalf of a fellow member of Harriet's Wildest Dreams, Catherine Constantinidis, who is a resident of Ward 2. I'm testifying about the need for the city to overhaul the current mental health crisis response system and prioritize the health and safety of DC residents. Our current response system increases the likelihood of engagement with law enforcement for our neighbors in their most vulnerable moments. Mental health crises should be approached as a matter of public health, not a judicial matter. Community engagement in crisis response can make all the difference for a community member in need because we keep us safe. I am a member/supporter of Harriet's Wildest Dreams and fight to demand safety for DC. I am a part of this work because as a resident of DC for the past several years, I want better for our city. I have encouraged fellow residents many times that we're in crisis, desperately needing mental health services, and I have no idea how to help them. That feeling of powerlessness due to a lack of access to comprehensive community services that focus on harm prevention instead of punishment has driven me to seek out organizations such as Harriet's Wildest Dreams to advocate for a safer and healthier DC community. DC must publicize the 988 crisis line and the services offered in public spaces, as well as medical and mental health facilities. According to a 2024 report by the National Alliance of Mental Illness, only 3% of Americans said that they or a loved one contacted the 988 crisis line when they were having a mental health, substance use, or suicide crisis. 82% say that they trust that they would receive help from 988 if they needed to call. By publicizing 988 or ensuring that callers will receive adequate support, DC residents' faith and trust in the district government would improve exponentially. Statistically, most Americans support the funding of 988 regardless of political affiliation. DC must also provide adequate training and staffing to 988 call centers, will give staff the ability to make referrals to outpatient facilities for a warm handoff with a follow-up within 72 hours, better ensuring that callers' immediate and long-term needs are met. Allow 988 to geolocate callers to determine whether they are in DC to provide services and dispatch mobile crisis response teams. Also train and retrain dispatchers at the Office of Unified Communications, OUC, to be able to identify mental health crises calls and ensure that they route the calls to the appropriate entities. Currently, OUC largely directs mental health crises calls to MPD. Also, increase integration between 988 and 911 to ensure DC residents are getting access to the proper channels for assistance. Thank you for your time and consideration.
Thank you. Thank you so much to this panel. You guys might know we ask for a lot of data before these hearings to sort of ground some of the conversation. And we specifically asked some questions, given our conversations, about 911 diversion and CRT response. And I want to say some of the data out loud, just because I know some of the members of the public aren't going to go look through the hundreds of pages of information. So we have a 911 diversion program. It was in pilot form for a little bit of time, and then there was funding that provided it permanently. So in FY23, which is not the fiscal year that we're talking about right now, we're talking about FY24, but I want to give you context. So in FY23, 911 diverted 28 calls to DBH. In FY24, it was 12. Now, so that's a conversation that we're going to have with the Office of Unified Communications at their hearing. That's an entirely different agency and hearing. That's in Judiciary and Public Safety. But I think that that's important, right? So if somebody is calling 911, clearly the number of MPD calls that are behavioral health in nature, but for whatever reason, dispatch or whoever is taking that call at OUC is not comfortable with making the diversions. I mean, we're not even in the triple digits, right? 12, that's yeah. In terms of crisis response team in FY23, now the crisis response team handled 7,038 calls for, some of this is with CHAMPS, which deals specifically with children. But in FY24, that number went down to 5,671. And so we'll ask some questions on Wednesday in terms of what happened there. But I do want to mention this for those who might say, why are folks bringing this up? This isn't really a big deal or issue, but the numbers show that something is amiss, right? Clearly, we're trying to do the right thing, right? We've set up this diversion program. There has been trainings that have been provided, and then something's not happening. And I think one of the concerns when I read about other jurisdictions who've done these types of crisis response or diversion, they say the biggest thing is that for the community, they want to know when they call, someone is going to show up and it not take, I think, Ms. Taylor, you said for the situation with the person at Anacostia River, it took about an hour. for someone to get there.
Yeah, because they didn't get the original call. So when they did get the call and they made the arrangements, whatever way, I don't know how it was made. I know that the situation was done in less than an hour after making the call. We were there forever. I don't know, do you recall that situation? It didn't make the news.
I think I do. I was on last council period. I was on the Judiciary Committee. So
Right,
sometimes we
yeah,
get
it didn't
recount
make the
on these things.
news, but DBH did come and the scene was over. I don't know what they done back there, but the fact that DBH wasn't there, and it doesn't take a rocket scientist for somebody to think that a person is there in their right head, right mind, to be standing in the river with a gun to his head. That's not, I mean, they don't take a, I'm not, like we said, mental health responders, we are not doctors or therapists, but some things like, I'm gonna think that he's having a crisis. This is a crisis situation.
Well, yeah, I mean, I think what you have described, the natural thought is, why didn't someone from MPD call?
Yeah.
Why did you have to call as opposed to someone?
The crisis intervention people, which, I mean, I look at them the same way as I look at us, but we don't have a gun. You understand, the certification of what we have to be able to, try to see and de-escalate the situation, if it's a drug overdose, if it's drugs, if it's suicidal. And with what's going on right now and who's at the helm of the United States, we're going to experience a whole lot more mental crisis. As me, I'm mentally stressed out, you know what I mean? And no, we don't need police to be encountering and showing up the way they are, because it's going, like somebody like me, I can end up in a cage because I'm stressed out trying to deal with a situation, and we come with MPD with guns. I don't have time for that. And so it's a very stressful time. So it's very important that we get the people in place to be able to help the people in DC before more people end up in cages or dead.
So one of the things that you all recommended was around the need for us to promote 988.
Yes.
How familiar do you think the community is with?
They're not. It's not something that you all actually push out there. And today's youth, me, myself, I literally, when I'm with the youth, I actually let them use weed in front of me because they having mental problems. They are depressed. Our youth are depressed.
Now, I will say, from the numbers, people are calling 988. Now, I don't know how many of these are duplicative. So let's see, from October to December of 2024. So that's 3 months. Oh, let me do math. Hold on, let me do math and look. Okay,
It's
2 years. This is how many people. Okay. I mean, there were roughly 800 people who call each month.
And how many call 911?
Yeah. Well, that's a whole different.
Exactly. So 800 is not even
ball of data.
It's less than probably 1% of the calls.
Yeah, I mean, I feel like this is, again, something that Mr. Howard was kind of talking about earlier around the need of more coordination amongst the two, right?
And education.
And education on that front. If we were to do something on the education front, what do you feel like is the best way for people to learn about 988?
I feel like 988 needs to be publicized, right? It has to be on billboards. We have the Metro, we have signage and things. Propagandize 988. If we don't want police showing up at the scene, and we know police aren't actually capable of handling these types of cases, we have to give people an alternative and put it in their faces. And so I think what it is that folks need somewhere to call, they need somewhere to go, and they need somebody to talk to. And so 988 could be that thing. But I'm also curious just about where exactly is that disconnect happening where each year those phone calls are getting less and less from that diversion program? And would it be useful for us to also track what's happening at the OUC?
Yes, that's what I was saying. I mean, some of this is a question for what's happening at OUC in terms of those numbers. I don't know when that hearing is, but I know it's on my calendar, so we're gonna figure it out. But this is always the sort of not the joy, is just like the tension of different committees sort of doing different things on different issues, right? I feel like crisis response should actually be a conversation between the Judiciary Committee and the Committee on Health, because they're combined in some ways. But we'll ask some further questions on the DBH side, and then we'll ask some questions on OUC side as well, because I know that there has been trainings. So I'm trying to, now we got to understand what's the disconnect that's happening on the floor over at OUC. But I don't have any further questions for you all. Thanks so much for your testimony, for being here today. Ms. Bellard, thank you for presenting the testimony of the witness who couldn't be here today. Thank you. Okay. Caroline Pryor. Ashley Ruff is switching to virtual, so Elizabeth Davis from Children's National. Alexis Ford. Jubilee Jumpstart. And Edward Dana. Okay. All right. Caroline?
Good afternoon, Chairperson Henderson. My name is Caroline Pryor, and I'm the lead organizer at Empower Ed, a teacher voice organization dedicated to bringing educator solutions to the decision-making table. I'm testifying today as well as a member of the Strengthening Families Through Behavioral Health Coalition and a member of the Fair Budget Coalition, where I serve as the co-chair of the education group. Today, I'd like to speak specifically to the school-based behavioral health coordinator role. DBH's school-based behavioral health program is critical to the ecosystem of the school, both as a way to offer appropriate and necessary care for students and to reduce burdens on staff societally expected to fill student gaps without resources or training. As is clear in agency and CBO data, schools with functioning behavioral health teams see high success serving and engaging students. And as we expand those services, one of the most important investments was ensuring every school had a coordinator. These school members are tasked with coordinating the work of the clinician and other members of the school's behavioral health team, overseeing the school strengthening tool and work plan to identify each school's unique needs, and guiding behavioral health services, resources, and programs. School-based behavioral health coordinators are keystones in the landscape of available behavioral health programming at schools. In our work with schools, Empower Ed hears routinely from school staff about the need for a major thoughtful investment in student behavioral health through a coordinated, emphasis added approach. As the city, we profess a desire to support the whole child. Our teacher fellows and our FBC education members know that wraparound services are critical to accomplish this goal. And we know too that schools are uniquely situated to provide those critical services, including behavioral health services, to students who spend more waking hours in school than anywhere else. But in a quick informal poll of our teacher fellows, about 7 in 10 couldn't identify their school's coordinator. Why? Because we've created the position without investing in its people power. Although the role may seem like a full-time job, it's not. Currently, the school-based behavioral health coordinator role is an unpaid position without sufficient visibility or support. Coordinators can be social workers, behavioral techs, heads of SPED, deans of wellness, non-exhaustive list. But those staff members nonetheless stack their coordinator duties on top of the responsibilities of their primary job. And they do this without compensation, without sufficient visibility in their school or in the city landscape, and with unstandardized, inconsistent levels of guidance. It's a recipe for unsustainability. Ongoing technical support and compensation are very easy ways to ensure that these coordinators can balance their primary roles while providing complex coordination support. When we do this, we can ensure that families and students actually are able to access the resources that we have funded. Without this floor, we continue to fail in our support of the coordinators who are DBH's boots on the ground. Thank you for your time.
Thank you. Ms. Davis.
Good morning, Chairperson Henderson and members of the committee. My name is Elizabeth Davis, and I am the Government Affairs Manager at Children's National Hospital. Thank you for the opportunity to provide testimony on the FY 2024-2025 performance of the Department of Behavioral Health. As a top children's hospital in the nation, Children's National is deeply invested in the mental health and well-being of children, youth, and families in the District of Columbia. Children's National is proud to partner with DBH on several initiatives, including expanding access to substance use disorder services for children and adolescents in the District of Columbia. The grant funding provided by DBH in March of 2024 has been essential in advancing our efforts to provide comprehensive, evidence-based care for young people struggling with SUD. In FY 2024, our addictions clinic served over 57 youth, providing medication management for substance use disorders, along with treatment for co-occurring psychiatric conditions. The funding also supported the hiring of a psychiatric nurse practitioner, which allowed us to increase our clinic's capacity from 3 to 5 days per week. In addition to expanding our addictions clinic capacity, we have also used DBH's funding to pilot naloxone distribution and hire peer recovery support specialists in our emergency department. Despite navigating some early challenges related to the novelty of these projects, we have successfully launched a universal substance use screening and a nasal naloxone distribution protocol in our emergency department. We're pleased to report that within the next few weeks, we will be hiring 3 peer recovery support specialists. We also commend DBH in partnership with DHCF for including new codes on the Medicaid fee schedule in the last fiscal year to facilitate integrated care. In particular, the collaborative care service codes facilitate critical continued advancement of primary care providers and trained care teams to support, where appropriate, the mental health needs of youth. Bolstering integrated care is a priority for Children's National, and we are in the early stages of planning a pilot with these service codes. While we are encouraged by the progress we have made in SUD, we recognize that there is still work to be done to strengthen the full continuum of care for children and adolescents. As mentioned during the roundtable last fall, we continue to see the growing need for intermediate levels of care, as well as the continued need to connect children and families to high-quality, community-based care in a timely fashion. It is crucial that our city has more options available that can help children and adolescents before they reach a level of severity that requires admission to inpatient care. We appreciate Dr. Bazran's openness to hearing directly from our pediatric clinicians who provide frontline care to district youth with mental health conditions. These initial conversations between her team and our staff have given us a platform to share real-world challenges and experience of our providers when trying to access community-based services and offer ideas to remedy the identified issues. We look forward to collaborating with DBH to advance solutions to better serve our youth and to improve their behavioral health outcomes. We are excited to hear about the ongoing development of the strategic plan, as this is a critical step toward creating a more coordinated system, and we look forward to further engagement with DBH on the plan. I appreciate the opportunity to testify and would be happy to answer any questions you or the committee may have.
Thank you. Alexis?
Good morning, Chair Henderson. I'm sorry. And members of the Committee on Health. My name is Alexis Ford, and I'm a lead teacher at Jubilee Jumpstart and Early Education Center in Ward 1. I am here to testify about the benefits of the Healthy Futures program to children and families. I have worked at Jubilee Jumpstart for 5 years, and our partnership with Healthy Futures has been incredibly beneficial. Over the years, we've seen positive changes in individual children and overall classroom dynamics. Challenging behaviors in even one child can impact the entire group. In one instance, our Healthy Futures clinician, Dr. Anais, introduced a stuffed turtle to help a child struggling with social emotional skills. This activity not only supported that child, but also benefited the whole class by encouraging sharing, taking turns, and practicing patience. Lessons like these are essential in helping children develop self-regulation skills. Having a Healthy Futures clinician as a partner provides valuable strategies for coping, making it easier to solve problems and boosting confidence in handling new situations. Thanks to Dr. Anais' interventions, we've seen noticeable improvements in anxiety levels, aggression, and transition difficulties. One child in particular struggled with tantrums during transitions. Dr. Anais helped us implement techniques to support the child before the tantrums began. With her guidance, the child started using a breathing technique, which significantly improved behavior and a true game changer. Dr. Anais support our children's developmental and emotional needs while providing valuable strategies to both teachers and parents. Last year, I had a child in my class who struggled with hitting, a concern the parents had also noticed. Instead of punishing the child, we worked together, parents, teachers, and Dr. Anais, to find ways to help. She suggested strategies for both home and school, such as redirecting behavior by saying, "We don't use our hands to hit, we use our hands to build blocks. We use our hands to build with blocks instead. We reinforce positive behavior through repetition, asking, what do we use our hands for? Drinking and eating and waving hello." We also taught emotional regulation by labeling emotions and guiding children on appropriate responses. For example, when we feel mad, what do? We talk to a teacher. By consistently using these strategies, we saw a significant decrease in hitting, leading to a more positive classroom environment. Clinicians help us understand the root causes of challenging behaviors and how to address them proactively. Having access to effective strategies reduces stress and boosts educators' confidence in handling complex situations. Since COVID, children's development has changed, requiring constant adaptation. Dr. Anais' support has been invaluable in helping us navigate these shifts. What we see in children this year will differ from what we see next year, and so on and so on. And she equips us with tools to meet each new challenge, allowing us to continue being the best educators we can be. Thank you for allowing me to speak today.
Thank you. Edward.
Good morning, Chairperson Henderson and members of the Committee of Health. Thank you for the opportunity to testify today. My name is Edward Dana. I am a resident of Ward 4, and I'm also a member of Project Action, an organization advocating for the rights and dignity of people with disabilities. I am here today to share my experience with the Department of Behavioral Health and failures I encountered when seeking mental health services during a crisis. In January 2021, I had an appointment with my psychiatrist at Community Connections. I had been waiting there for over 3 months for this appointment, and it was critical for my care. I also needed my provider to sign an important paperwork so that my emotional support animal, Jasper, could be trained as a service animal to help manage my anxiety. Before the appointment, I called ahead to confirm that I could bring Jasper, but I was told no. Despite this, I proceeded to the appointment without Jasper because I needed the care immediately. I called ahead to let them know that I was running late because of the trains were delayed and single tracking. But when I arrived, they refused to see me and they asked me to reschedule. I was already in distress, and this sudden denial of care escalated my crisis. Instead of offering me support, they asked me to leave. But when I became visibly upset, they misinterpreted my distress as aggression. Instead of de-escalating the situation or providing any mental health support, they immediately threatened to call the police. Despite having been a patient at Community Connection since 2014, I was treated as a threat rather than a person of needed of care. The police arrived and detained me in handcuffs in front of everyone and forced me to apologize to the staff before letting me go. This was not about resolving the issues. It was about asserting power over me. After this humiliating experiences, I never returned to Community Connections and I was left without care for over a year and a half. This experience raises serious concerns about how DBH providers handles individuals in crisis. Community Connections claims to uphold values and dignity and respect, yet their actions violate their principles. They fail to provide the basic accommodations and de-escalation strategies that should be standard in mental health care. Instead, they resorted to police interventions, an approach that is not only inappropriate, but dangerous for people with disabilities. DBH must ensure that all providers under its networks are properly trained in crisis interventions and disability accommodations. There must be accountability for providers who fail these standards. Additionally, we need to be more accessible and effective grievance process. When I attempted to report the incident to a DBH, my concerns were dismissed, and my complaint never escalated to a formal grievance. Without proper oversight, providers will continue to fail those who rely on them. I urge the Council to take immediate action to hold DBH providers accountable and not to implement reforms that prioritize the dignity and the safety of individuals in crisis. No one is seeking help should be met with police interventions instead of care. Thank you for your time and consideration, and I'm happy to answer any questions.
Thank you. Mr. Dana, I'll start with you. I appreciate you being here and for sharing your testimony. I think that last part of what you said is spot on, right? No one wants to seek help and then be met with police. And so I'm not sure specifically what happened there, but I would hope for our community-based providers that they would have the training necessary to notice when someone is in crisis and appropriately respond without engaging MPD in that. And so we'll follow up more because I suspect your testimony is not the only case of something like this happening.
I agree.
Thank you.
Thank you.
Ms. Ford, thank you so much for being here. And speaking of the good of the Healthy Futures program, frankly, I think that early intervention is always best. And, you know, some of the examples that you gave of for Context for Folks, Jubilee Head Start is preschool. So we're not talking about DCPS or a charter school. We're talking about babies really in the pre-3 stage, right? And so, you know, being able to correct some of these behaviors before they become permanent or routine actions, I think is super helpful. And I think it's always great that we're able to provide our early childhood educators with this additional level of support. How often does your clinician come on site?
Like 3 to 4 times a week.
That's great.
Yeah, so she's there a lot.
Okay. Do you know if she is working with any other centers as well?
I think she partners with Central NIA. I'm not 100% sure. I wouldn't be able to tell you because she has like a conscious discipline.
That's fine. In terms of your communication with parents, does the center inform the parents about this program, or is this something that's specifically, you know, her working specifically with the staff on site and going from there?
No, she works with staff, parents, and children. So it's something that's widely advertised across the whole center.
Okay. And if Healthy Futures didn't exist, what would happen?
I feel like teachers will lose the support, children will lose the support, and parents will lose the support to help their children navigate these early problems that they're facing. I feel like it's support, basically, because as I said, as the years go on, children that we see are getting different, and it starts at 0 to 3 years old. It's starting early now. So it's being able to identify these problems and correct it. So it's the support.
Oh, great. Well, thank you. Thank you for being here. Ms. Davis, I wanted to ask, is, you know, in some of our adult leaning hospitals, it is very common for them to do the universal substance use screening or talk about peer recovery, right? In that realm, it is a little, I think, jarring for folks to think, wait, why is Children's National implementing something like this? But I imagine that in terms of you all hiring these peer recovery specialists, it was born out of what you were seeing in terms of patients?
Yes, so our lead provider on this grant, in coordination with the Department of Behavioral Health, saw that this is really novel. Only one other children's hospital, I believe Seattle Children's, is doing this type of work. But we have been seeing an increased need in our emergency department for these services. And so while this is novel in the pediatric space, it was a need that we saw. And so we did run into some initial challenges in terms of like being able to recruit youth to be in those roles.
I was kind of wondering. I was like, okay, exactly, because I know what the definition of peer means, you know, and so
Yeah, so we're still in that initial interview process, but hope in the next few weeks to be able to hire someone in these roles to be able to help within our emergency department when those youth present.
Yeah, and just for context for folks, a couple of weeks ago, we went to mental health court, which is part of DC Superior Court. So it's the same judge. He does both mental health court and he does drug court. They always have a peer specialist who's in the courtroom. And part of that is around, somebody will come in, he said, and they would say, like, I don't have a problem. I don't have a problem. I'm fine, X, Y, or Z. They go out, they have a conversation with their peer specialist, and then you get a whole different story because the sometimes people can't see the actions that they're doing as an addiction, but rather they just think, no, this is me every day. I'm good. And so I would be very interested to hear more about that. And so the grant is local or federal?
This is supported by, it's local from the opioid and vape
Look,
fund.
last 2 weeks, we got to ask these questions because it's hard to say what's gonna happen. Ms. Pryor, thank you for being here. Scott testified earlier on some of the similar things that you raised, and so I'm sure we'll talk more about some of these issues throughout the budget process. I don't have any further questions for this panel. Please make sure you provide your written testimony for us for the record. Thank you. Okay, Rachel Himmer. David Freeman. Oh, there is somebody here from Community Connections. Yeah. And Eric Jones. Okay. I said this at the beginning, but is there anybody here who, like, you're here in person, but you signed up to testify virtual? Okay. I have an extra seat, so I'm gonna let that ride on today. But if you want to come up. Okay. Ms. Himmer.
Hi, my name is Rachel Hemmer. I really appreciate getting the chance to testify today. I was a patient in the Department of Behavioral Health at the end of October this year. I called the National Alliance of Mental Health Hotline as I was experiencing a mental health crisis, and I was involuntarily hospitalized. And over the course of the 4 days I was in the system, there were several things that happened that I was very concerned about. Starting with the initial contact with DBH, which was the mobile crisis team. While I wasn't super thinking about it in the moment, there were several times in which, after they had determined I needed to be involuntarily hospitalized, I was allowed to enter my apartment by myself for 10, 15 minutes at a time with nobody present there with me, which, had I been actively suicidal, would have been extremely dangerous, in my opinion. Moving on, I was then transported to CPEP. The mobile crisis team called the police. I was transported by them to CPEP. When I arrived at CPEP, I'm not sure if you've ever been, it's not the most calming of environments. So while I was scared, I was not, I believe, in an active crisis. Despite this, the doctor had said that he wanted to give me a medication to help me sleep. And when I hesitated and I was like, oh, I'm not sure if I want to take that, he told me that we could do this the easy way or the hard way, which made me think if I did not consent to this medication, they were going to inject me with something. I then later learned that the medication they gave me was Remeron, which, while I'm not an expert in psychiatric drugs, is not a drug I would describe as something just to help you sleep. I experienced a lot of adverse side effects the entire next day from taking this drug. I'm still working on getting my records from CPEP, so I can't tell you what dosage I was administered or what the doctor's reasoning was right now. But I'm very concerned that it was presented to me as in I had to take this medication, and it was not properly explained to me what this medication would do. Moving on, I was transferred to Psychiatric Institute of Washington. And during my transfer, I was put in a 4-point restraint despite having no physical outbursts of any kind, just being a little bit stressed by the environment of CPEP. I was left in a 4-point restraint for 2.5 hours during my transfer. I believe there may have been a reason. It seemed like something may have been happening at PIW at the time. I was not told why I was left. I ended up being kind of sat in a hallway by myself for the majority of this 2.5 hours with nobody really explaining to me what was going on. I could just hear some amount of commotion in the background. And when I asked I think EMT who was with me, what was going on and if she knew when I would be able to, get out of this restraint and begin talking to a doctor. She told me, and I said that I was having a hard time with being restrained for such a long period of time. She told me that I deserved it for whatever I did to get here. So I did not ask any questions after that point. Moving into staying at Psychiatric Institute of Washington, I was over the course of my 3 days there, I did 2 intakes, but at no point did I speak to a therapist for longer than 10 minutes. I was not really receiving any care. They stated that we would be doing group therapy, but group therapy consisted of rating how you felt on a scale of 1 to 10, and that was the entire group therapy. So almost all of the time I was in this hospital was spent watching whatever was on TV, just in a room. The staff weren't really interacting with us. There didn't seem to be any programming. We were not permitted to go outside. We were not permitted to go to the cafeteria. The only thing that really happened while I was there was we would have dinner, and in the morning we could have coffee. I was also very concerned about the way that they handle paperwork at Psychiatric Institute of Washington. On my second day there, because I was there involuntarily, I was allowed to speak with a public defender who was really helpful in understanding the legal process that nobody had really explained to me up until that point. After talking with her, she explained the difference between voluntary and involuntary paperwork, and I'm very glad that she did, because the second I got off the Zoom call with her, there was a nurse or tech standing there with paperwork, just like, sign this. And I was like, well, what is it? And they were like, don't worry about it, sign it. And it turned out to be voluntary paperwork, which they were pushing me to sign without really understanding what implications that would have for my ability to leave and what it would mean to check myself out against medical advice if I was there voluntary versus really what was happening with that paperwork.
Ms. Summer,
Sorry.
No. I let you go over. If you could summarize,
Yeah,
I'll have some follow-up questions.
To summarize, I'm really concerned about patients who are experiencing an involuntary hospitalization, having the legal system and their rights explained to them, and in general, just being treated with respect while they're there. Thank you.
Thank you. Mr. Freeman.
This is Damian Cabezas. I'm testifying on behalf of David Freeman.
Okay.
Community Connection.
Oh, can you state your first and last name for the record?
Damian Cabezas. I am the new president and CEO at Community Connections, started in January of 13.
Oh.
So bear with me as I catch up on the
you're fresh.
Challenges and opportunities of the district. Yes.
Okay. Go ahead.
But I am glad that I came. I was very concerned with the comments heard earlier about Community Connections, and I have given my contact information to the gentleman and hope that we are able to re-engage him at Community Connections. For me, I'm a person in recovery as well, and so it's very personal work for me. So I am glad I was here to hear the testimony earlier. Just a reminder, since 1984, Community Connections has been providing behavioral health, residential services, and primary health care coordination in the district, many of whom are coping with challenges, including mental health and addiction and the aftermath of trauma and abuse. And so I'm glad to be here. Thank you, Chairperson Henderson and the committee for hearing my testimony this morning or this afternoon. The last 5 years, I should say, has been challenging to maintain a level of service that our consumers and communities deserve. For example, in fiscal year 2020, we experienced a loss of $918,000. 2021, $2.4 million. 2022, $3.9 million. 2023, $4.4 million. And 2024, we actually had a modest surplus. Had it not been for the support from the district, DBH, and federal funding through the stimulus, as well as dipping into our reserves and having to sell one of our properties, I may not be sitting here before you. So we appreciate the support during that difficult time. I did want to note that within residential services, we had a surplus in 2020, and when the supportive independent living fee, SIL, was removed, we started to decreases ever since. For example, $99,000 in 21, a little over $1 million in 22 and 23, and about $927,000 loss in 2024. So we would request restoring the SIL for us and other providers to get back to sustainable financial results. This comes at a time, as you know, when the need for our services has doubled in terms of addiction services, in terms of while treatment has decreased, access to treatment has decreased from 9% to 7%. Rates of homelessness, as you know, has been rising at 12%. Rates of incarceration among our youth, Black, Brown, and Hispanic communities continue to increase, and rates of hospitalizations persist. We do appreciate the financial support from DBH in terms of MHCRF, and we also appreciate the fact that DBH increased daily rates in 2023 for MHCRF by 19%, and appreciate all the other support through ACT, CSP intake, day services, and trauma-informed. But given the historic increases in inflation and increases in housing repairs, maintenance, food, wages, insurance, technology, we would appreciate you consider higher rates so that we can provide, again, the value to our consumers and communities that they deserve. We would also appreciate timely local dollar reimbursement. We are experiencing quite a number of months of reimbursement from local dollars, and so we would appreciate that as well. That being said, I want to state my commitment on behalf of Community Connections to be an active partner to DBH in the district and remaining available and open in the next crisis, because we know that the next crisis is going to be there. We are interested in expanding addiction and substance use treatment, reentry. So I'm glad that there was some testimony on reentry and returning citizens, school-based services, and co-responder models with MPD. I had the opportunity to expand school-based services when I worked in Virginia and through an 1115 waiver. And we're also pleased that DBH has been funded for a CCBHC planning grant, which we hope to support. Again, I also had the opportunity when I worked in Massachusetts to oversee a CCBHC. So supportive in any way we can. And we are also interested in the 1115 waiver through CMS to provide reentry and housing services. So just want to be an active partner in any way we can.
Thank you. Dr. Jones.
Good morning. Eric Jones. I'm a clinical psychologist with the Department of Behavioral Health, where I've worked for 25 years, and I'm also a resident of Washington, D.C. I'm representing the Psychologists Union of the DBH, and I'm here to bring attention to a dire situation that has been occurring in D.C. with little awareness. Within the last few years, the district has been consistently losing well-trained psychologists and having extreme difficulties hiring equally trained psychologists. The Psychology Union covers clinical, forensic, and neuropsychologists that work through DC Public Schools, DC Outpatient Center, DC Jail and Courts, and St. Elizabeth's Hospital. Most of the psychologists within the union work through St. Elizabeth's Hospital, which currently has the highest vacancy rate in the psychology department that it has had in the last decade. This vacancy, coupled with the higher rates of pretrial admissions to the hospital, have significant consequences across multiple settings throughout DC. Currently, St. Elizabeth's has 33% of their psychologist positions vacant. This has been the case for over 2 years. While positions have been posted and advertised for quite some time, we have been unable to secure licensed psychologists to hire, and we continue to lose licensed psychologists to other similar positions, both getting higher pay and more flexibility. Furthermore, the administration has indicated that this is primarily due to our grossly non-competitive salary. Psychologists at St. Elizabeth's complete the majority of all competency evaluations and competency restoration in the district, sexual and physical violence assessments, individual therapy, sex offense-specific treatment, criminal responsibility evaluations, civil commitment letters, group therapy, neuropsychological assessments, etc. Many of these tasks are to assist individuals with serious mental illness at St. Elizabeth's, as well as keeping the community safe. This is why we, the psychologists, are asking for and advocating for much needed change to the positions to assist us in filling our vacancies and keeping the community safe. Keeping DC safe is something the district and local political leaders pride themselves on focusing on, and this is a crisis that is impacting the safety and security of DC local in St. Elizabeth and the surrounding community. Thank you.
Thank you. Mr. Stevens.
Good afternoon, Chairperson Henderson and members of the Committee of Health. My name is Leonard Stevens. I'm 36 years of age, live in Ward 5, and I'm testifying today not just as an advocate for people with disabilities, but I'm advocating myself as a mental health specialist as well. I've been deeply involved in this for almost years, and I'm here to share my personal experience with the Department of Behavioral Health. Now, granted, I was a person with disability, but I also had depression, anxiety, and just recently I was diagnosed with bipolar disorder. And I know how hard it is to get the right care, but my experiences with from a few years ago just showed me how broken the system is for people and individuals like myself that has mental health challenges. So I'm going to touch on a touchy story that happened to me. December 20th, 2021, I was hospitalized for attempted suicide. It was the scariest moment of my life. I needed help, but instead of getting the support, I got nothing but fear and confusion. I was going through medical withdrawals such as Zoloft and Paxil and also Prozac, and I felt real miserable that day. But instead of sending me to a doctor to help me, the clinic sent me to a police, and that escalated even worse. I had anxiety, and seeing armed officers made me panic even more, considering I heard a lot of stories based on people with disabilities and mental health issues being hurt or killed. And I didn't know what's going to happen to me on that day. My grandmother, who was with me, was also really scared at that point. The clinic forced me to Minnesota Washington Hospital without explaining what's going on with me. I had no idea what's going on because I was going to miss Christmas with my family by spending almost weeks, not just at the hospital, but at the psych ward at best. No one took the time to reassure me, explain my treatment plan, or understand my rights. And this is not how mental health should work. And people like myself should not be afraid of getting help. And police should not be the first response to a mental health crisis. Instead, there should be trained professionals, psychiatrists, therapists, and peer support workers who know how to handle these situations without making things worse. In addition, mental health facilities also need to do a better job of targeting patients, especially patients with intellectual and developmental disabilities. And being forced in the hospital is just scary enough, but no one explains what's happening, escalating even more. I deserve deference, honesty, and care, but more importantly, more understanding. Unfortunately, I didn't get all of those things. So the behavioral health need to make sure that providers receive disability sensitivity training and also training how to communicate with people with disabilities. Mental health treatment should not feel like a punishment nor a death sentence, yet I feel helpless and powerless, not to mention being afraid. The system should focus on helping people, not just controlling them. So I appreciate you understanding my story, and no one should be afraid to ask for help. And we need to change the way that mental health crises are handled, not just in the district, but elsewhere. So I hope the council will take action to make sure people in crisis, especially those with disability, get care from trained professionals and instead of the police. Let me know if you have any questions.
Thank you. Thank you, Mr. Stevens. And I want to thank you and Ms. Hummer in particular, again, for your willingness to share your story publicly. What you have shared is deeply disturbing in terms of, Ms. Hummer in particular. You called for help, and it doesn't sound like you feel like you got any throughout your experience. But also the fact that assumptions were made about why you were at PIW, right? PIW deals with a lot of FD12 cases, some of which individuals have done actions that led to them arriving, but that wasn't, at least from your description, that wasn't what happened here. And so I'm sorry that that happened to you, but I hope that you were able to seek help. And we've been in constant talks with PIW around some of the things that we hear about what's happening on their premises, and we'll continue to work through that. Mr. Cabasas, did I say that correctly? Cabasis. Thank you for being here. That was I was like, oh, there's probably nobody here from Community Connections. And so, but no, I can't ask you anything because you're like 2 weeks into it. But I appreciate your willingness to be here, and then also for your signaling of open collaboration.
Yes.
One of the things that you did talk about, though, around timely reimbursement, how long have you all been waiting?
Since we've been working through this since August of last year.
August.
Yeah.
Okay.
Yeah. And it's a little over $500,000, so it's not small amount of money.
No, not at all.
And when you're, as I said, when you're working within lean margins, it's important to get reimbursed on a timely manner. But you'll continue to partner with DBH on this.
Well, I'll tell you what we have also told some of our FQHCs who have similarly had situations, which is like, don't wait till you can't make payroll before you say something, because it is not as though we don't have the money to pay our bills. So there's something else that's going on there, but you're not alone in that. So we'll follow up on that.
Thank you.
Dr. Jones, thank you for being here to represent the union. So a third of the psych positions being vacant gives me a little bit of heartburn. What would you say, is it lack of applicants or lack of qualified applicants? What is the biggest impediment to our being able to hire these positions?
Yeah, I think the biggest impediment is that they are not competitive in salary, so that other jurisdictions, the nearby jurisdictions, the other state hospitals, VA, pay at a rate that brings the talent there. Keep in mind that doing the kind of work that we're doing is very specialized, working with severely mentally ill and the skill base with regards to working with the courts. So those are specialized candidates that have applied in the past, but DC has not kept pace with how those salaries have changed.
When's the last time you all had a CBA? Or a new contract, rather?
Well, the current one expires this year.
Okay.
So that we are beginning the process this month, if you will, to prepare for October.
How much off are we from our neighboring jurisdictions? Take the VA out because they're special. I don't know if you have a dollar amount or rather just percent. We've been having this conversation on other job positions as well.
Yeah, I think that it is roughly yeah, I think it's roughly 50%.
I'm sorry, you said 50%?
I think it's roughly that our currently our top salary is below some of the starting salaries.
For our neighboring jurisdictions.
Correct.
Okay. All right. Thank you for that. We'll certainly follow up and get more info. I don't have any further questions for this panel. If you could make sure we have your written testimony for the record, that'd be great. Ms. Homer, did you provide your written testimony? Okay, please do so because we'll take a look at. I know you had a couple more things to say, so we'll take a look at that further. Thank you. No, you're fine. Okay. Okay, so we're going to switch over to our virtual testimony. We got to power through. So if you're here in the room, you need to take a bathroom break, go forth. But we got to keep moving. We're going to do panels of 6. Again, to anyone who's testifying virtually, you have to affirmatively accept our invitation to become a panelist. If we miss you, right, and like I've called your name and you're not there, I'll call it at the end, but I can't just continue to add folks because that gets us off. So actually, it's going to be a panel of 7. Ashley Ruff, Nicole Travers, Catherine Procope, Xavier Smith, Mark Miller, Genesis McCrimmons, and Shannon Walsh. All right. Again, if you got to accept our invitation to become a panelist. Okay, we're going to get started. Commissioner Ruff. Commissioner, before you start, we've been joined by Councilmember Wendell Felder from Ward 7. We're going to do this panel because we have 109 witnesses. So if you could hold your opening statement. Okay, all right. Commissioner, when you're ready.
Good morning, Chairwoman Henderson. I'm not going to take too much of your time because I am at work, but I wanted to make sure that I spoke up this morning. And I did write a written statement, but I don't feel that it's necessary because I feel sentiment of everyone that has spoken before me now, especially the gentleman that talked about how aggressively he was arrested and everything. And so I just want to talk about one incident that happened for me. Everyone knows that we have Takeover Tuesday on Minnesota Avenue. And so DBH is family to us. They come out every Tuesday and they help us, everything. But sometimes Narcan is not enough. everyone doesn't have an addiction problem, so they don't need Narcan or they don't need some of the other services. But I had a gentleman that had been waiting for possibly maybe 2 weeks in advance. And so when he was waiting for those 2 weeks, he asked me, did I see this gentleman, Sean, from DBH that I work with quite often? And I met him through Councilman McDuffie's office. Awesome gentleman for DBH. But as he sat out there and he kept waiting for Sean, he told me that he wanted to get clean and he wanted to be an example to other to other people in the community. And so, can you give me a moment, please? Chairwoman, I apologize. And so when the gentleman's name is Cortez, Cortez wanted to get clean. And so when Cortez came out to take over Tuesday, we were able to call around to different agencies and different companies to see if he could get the help that he needed. But one thing that he needed that he could not get, which was a ride. No one from DBH could provide him with the ride to get there. And here it is, he's standing on the corner. He literally waited with me for 2 to 3 hours just to get a ride. And the gentleman that I have been working with DBH said, finally, you know what? I can't take this no more. I see someone in our community that needs help, and we need to get him to where he's going. And now he's been thriving for 4 weeks. For 4 weeks, getting clean. But again, like I said, everyone doesn't need Narcan. I'm tired of seeing the Narcan in the trees. I'm tired of maybe the government not allotting enough money to DBH, because DBH is well capable of doing the services, but there's not enough money. It's not enough money at all. My own experience with my own child losing his great grandmother the year before last, I have yet to still get the services that I need for my own child through DBH. And I heard, Children's has all these great programs, but we go through Children's too, and we have not received those. So maybe it's a thing that maybe Ward 7 needs to be placed on DBH's priority list for this upcoming season, because that's what I'm seeing. I'm seeing that we're not getting enough services over there. We are struggling to get those DBH services. And when we do get them, we are getting people that really love and care about their community, but also at the same time, they're overworked, they're tired. We need more people. We need more qualified individuals. Just as a whole, it doesn't matter what color you are. We all need mental health. So that's all I have to say, Chairman. Thank you for the time.
Thank you, Commissioner. Ms. Travers.
Good afternoon, Chairperson Henderson and members of the committee. My name is Nicole Travers, and I'm the Senior Director of School Support and Program Data at the DC Charter School Alliance, the local nonprofit that advocates on behalf of public charter schools to ensure that every student can choose high-quality public schools that prepare them for lifelong success. The DC Charter School Alliance is an active member of the Coordinating Council on School Behavioral Health and the Strengthening Families SFC Coalition. In my role at the DC Alliance, I work closely with charter schools on the full range of student support issues, including student mental health, safety barriers, and chronic absenteeism. In this work, we started a student support community of practice that in the 24-25 year has already brought together over 70% of charter LEAs to focus on new collaborations for school-based mental health and other student support services. It's important to know that student mental health continues to be a major challenge for schools in DC and across the nation. A recent NCES study found that 58% of schools saw an increase in students seeking mental health services in school year 23-24. Two of the three most cited reasons for these challenges are staffing related, with 55% of schools citing insufficient staffing and 49% citing inadequate access to licensed professionals. This work could not be more important. Not only is the health of our students at stake, but we have the ability to reduce chronic absenteeism and improve academic outcomes if the strategies that we know work reach more students that need them. For the past 2 years, DC charter schools have collaborated with DBH on an innovative approach to staffing mental health professionals and LEAs through the Pilot 1B program. We appreciate Dr. Bazran and Dr. Scott and the DBH team for their leadership in creating and shepherding the pilot. We're grateful that it was extended into a second year and recommend that it continues to grow and reach more schools. Today, there are 8 schools participating in the pilot. In its second year, we recommend making some modifications based on our learning to date. This includes reducing the amount of time it takes for DBH to issue award letters so that schools can hire clinicians more quickly, and organizing regular hybrid convenings throughout the school year with school leaders to collaborate and strengthen the pilot. Despite some progress, the shortage of well-qualified clinicians continues to be a challenge. In previous testimony, we recommended pursuing reciprocity agreements with Maryland, VA, and other jurisdictions. Allowing clinicians licensed in these nearby states to practice in the district continues to have the potential to enhance the pool of providers quickly. Thank you, Chairperson Henderson, for your leadership and progress in the passage of the Counseling Compact Approval Act of 24. We applaud DBH for collaborating with public charter schools and with other agencies like OSSI. This collaborative effort is essential to maximize city resources to create better outcomes for students. Additionally, we appreciate its efforts to support student needs through initiatives such as the launch of the Student Peer Educator Program pilot through the Young Women's Project and Our Minds Matter. This has already been implemented in 10 charter LEAs. In the spirit of collaboration, individual charter schools are implementing innovative strategies and solutions in their own schools to provide a menu of mental health services for their students. For example, charter leaders have partnered with the Momentum Residency to ensure clinical coverage in these schools. Other charter LEAs partner with local universities to host clinical student interns who support their Tier 1 mental health initiatives. In closing, I'd like to reiterate that we look forward to continuing the work alongside DBH and our partners to serve our students. Thank you, and I welcome your questions.
Thank you. Catherine?
Good afternoon, and thank you for this opportunity to testify regarding the critical role of behavioral health services in our school and the ongoing support needed for our students and families. I'm Catherine Prokop, and I'm the Executive Director at the Howard University Middle School of Mathematics and Science. For several years, our school has awaited a partnership with DBH, and I'm pleased to share that our collaboration is finally now in place. Through this partnership, our school is actively engaging in violence prevention training for our children, an essential initiative given the increasing exposure to trauma and community violence that our students experience. Additionally, our participation in the Momentum Residency Program has brought 2 dedicated residents into our school where they are gaining hands-on experience as they train to become social workers. This program is instrumental in expanding the capacity of our school's behavioral health team. At our school, we recognize that academic success is closely tied to the emotional, and psychological well-being of our students. Our comprehensive social emotional support system is designed to address trauma that many of our children face daily. However, despite our best efforts, we continue to struggle with chronic absenteeism and attendance challenges, and students who just cannot manage themselves because of things happening outside of school. While we've implemented school-based programs to address these issues, additional external support is always needed to fully meet the needs of our students and our families. And we urge DBH to continue to provide targeted assistance in these areas. Beyond the students, we see firsthand the need for behavioral health support within our families. Our social workers work tirelessly to connect families with appropriate resources and interventions, often going beyond their traditional responsibilities to ensure that our students have the necessary home support to thrive in school. To further this mission, we are fortunate to partner with Howard University and their School of Social Work, where graduate students under the supervision of a licensed social worker serve as interns. Their presence in our school provides invaluable support to our students, expanding access to counseling, intervention strategies, and family engagement services. Additionally, we partnered with the Howard University School of Fine Arts, they offer music therapy to students who need behavioral health support. This innovative support has allowed us to integrate creative expression as a therapeutic tool, helping students process trauma, manage emotions, and develop positive coping mechanisms. Despite strong partnerships and proactive initiatives, the demand for behavioral health services in schools remains overwhelming. Our social workers are stretched thin, managing a growing caseload of students whose needs are immediate and need long-term intervention. And we need additional licensed behavioral support professionals in our schools and all of our schools to help our children be the best that they can. So I urge your increased investment in school-based behavioral support programs to expand the access to trained professionals to strengthen partnerships between schools and DBH. Our students deserve a holistic support system that ensures not only their academic success, but their emotional and mental well-being. Thank you for your time, and I'll be happy to answer any questions.
Thank you. I don't see Xavier Smith. I don't see Mark Miller. I don't see Genesis, and I don't see Shannon Walsh. Right. Okay. Thank you for the witnesses who are here and who provided their testimony. Commissioner Ruff, thank you so much for the work that you do on behalf of your community. Oh, I'm sorry. There's Shannon. She's here. Hold on one second. Shannon? Shannon, if you're speaking, you're on mute.
Thank you. Sorry about that.
No problem.
I'm sorry, I'm running from a client. Um,
You got it, Shannon?
so sorry. My computer's just being very slow now. Okay, I'm ready. Sorry about that. Good morning, Chairperson Henderson, council members, and council staff. My name is Shannon Walsh. I'm a Ward 8 resident, a licensed independent clinical social worker, and the clinical director of the Court Urgent Care Clinic. The Court Urgent Care Clinic is a partnership between DC Superior Court, the DC Department of Behavioral Health, and Pathways to Housing DC. Chairperson Henderson, we were honored to host you and your staff as you visited the Court Urgent Care Clinic last month. We were thankful to see your compassion and concern for those we serve. Each year, the Court Urgent Care Clinic provides hundreds of adults with mental health and substance use challenges with same-day assessment and treatment of complex behavioral health challenges. The clinic was one of the first of its kind and remains one of the only of its kind in the country. On staff, we have a psychiatrist, 2 mental health clinicians, a certified addictions counselor, an intake coordinator, and a clinical director. Our office is in a unique position to provide services to individuals regardless of if they have an ID, insurance, or residency status in the United States at no cost. We are conveniently located in the DC Superior Courthouse to provide services to individuals involved in the court who often fall into one or more of these categories. Although we are located in the courthouse, we are able to provide services to anyone in the district regardless of court involvement. According to our human care agreement on page 8, the Court Urgent Care Clinic's objective is to support DC residents who are court involved, minimize recidivism with the criminal justice system, and augment justice diversion programs and triage the behavioral health needs of the consumers served there so that they will be connected to appropriate long-term care. In the first 6 months of our contract year, 85% of our clients have reported their interactions with the Court Urgent Care Clinic has positively impacted their judicial disposition. 66% of our clients were discharged with a positive outcome, meaning they were connected to a long-term mental health or substance use provider, and 49% of our clients were referred for a housing assessment due to experiencing homelessness or housing instability. This contract year, we are on pace to exceed our contractual obligation by 36% for our unique referrals. We also work closely with the Civil Actions Branch as well as the Mental Health Court to provide support to clients who would otherwise require police intervention due to their mental health symptoms. Unfortunately, our program may again be cut in the fiscal year 26 budget. This would be a tremendous loss for our clients and community. The benefit of having our office in the courthouse is that clients can be seen on the same day they are in court and experience acute mental health symptoms. If our program is closed, our clients will likely have to travel to another location, which is an added barrier and will likely result in the person not getting treatment. The Court Urgent Care Clinic also provides forensic child evaluations at the request of the court to determine if a child needs to be hospitalized. We've been able to avoid hospitalizing a child after gathering the needed information and coordinating with the hospital, the child's probation officer, family, and core service agency to be prescribed the appropriate medication and avoid hospitalization. Our office stands in the gap for clients who may already be connected with mental health providers, but are in need of immediate psychiatric intervention, including emergency medication, counseling, and involuntary hospitalizations. Our stakeholders, including judges, probation, and parole officers, attorneys, and clients, have expressed deep concern about the elimination of our program. Multiple judges expressed concern about how they will mitigate mental health emergencies in their courtroom if our program is no longer funded. An attorney reported the urgent care clinic has served as a bridge between the courthouse and DBH, and without their services, I'm afraid that this will make representing clients with mental health concerns extremely difficult. A former client reported that without the court urgent care clinic, they would not be in the housing that they are in now and be able to address their mental and physical health conditions. I believe you have and will continue to hear from our stakeholders about the essential nature of our services. Chairperson Henderson, I'm requesting your support in keeping the court urgent care clinic funded in fiscal year 26. I thank you for conducting this hearing and I'm available to answer any questions that you may have. Thank you.
Thank you. All right. Thank you to everyone on this panel for your testimony. As I was saying before, Commissioner Ruff, thank you so much for your support and for the community and for the work that you all do with Takeover Tuesdays. I think something that you talked about in terms of your experience with Mr. Cortez is around this sort of breakdown in communication. When someone is ready to enter treatment, are we able to get them to where they need to go and place them soon after? But I thank you for the work that you're doing, and we're going to keep working on that. Ms. Travers and Ms. Prokop, thank you for testifying. It's always good to hear from our LEAs and sort of their experience in terms of working with DBH. Dr. Prokop, apologies, I called you Miss Dr. Prokop. I wanted to ask, in terms of the partnership that you all have with the School of Social Work as well as the School of Fine Arts, is this augmenting services that are being provided by a DBH clinician, or is this instead of?
It's in addition to.
It's in addition to. Okay.
Yes.
Yeah. And I think you're probably recognizing that for your students, they might need a more diverse suite of options.
Yes, ma'am.
I honestly think that partnering with the School of Fine Arts for music therapy is brilliant, frankly.
They reached out to us and we absolutely said, yes, it really is working too for our students.
Okay. Did you all apply for the pilot with DBH?
We did.
Okay. And you did receive it?
We did, finally. Yes, ma'am.
Okay. But you said finally. What does that mean?
Well, because we have been, I've been here 10 years and we have been trying to get connected with DBH for quite a while. And it was really no fault of anyone's. This was a lack of clinicians available. So we were really excited to finally get on board.
Got it. Okay. Ms. Travers, my understanding is that you all, the Charter School Alliance, helped a lot of applicants who were trying to do the pilot program. Is that correct?
That is correct. We partnered with DBH and I had many conversations with Dr. Scott. We helped to hold info sessions. We helped refine and help provide clarity for the process and assisted the leaders with answering questions for their application process.
To your knowledge, how's it going? I think maybe, I don't know, I'm looking at the witness list. There might be some additional leaders who will testify about that, but I'm wondering anecdotally, is this working well? Is this model working well?
I know you'll be able to hear from a number of the school leaders who are in the pilot, but I can say for those school leaders who have been able to hire a clinician, they have positive remarks about the program. They see it as another leg of support that can assist students who wouldn't have already had opportunity to receive mental health supports from their current clinician, or if they had a clinician at all. And so I think this is just another opportunity to provide a three-prong approach in a sense. As Dr. Prokop said, just being able to partner with a university. In some cases, some of our school leaders have been able to hire a clinician on their own without the funding, and they are also partnering with the CBO or being a part of the pilot. So it's almost like a three-leg support to assist students because our students need support in a variety of ways.
Right. I don't have any further questions. I'm going to turn to Councilmember Felder.
I have no further questions, but I do want to thank all of the panelists for their questions and taking time out of your day to be before us today. So thank you. And special shout out to Commissioner Ruff, who's a wonderful ANC commissioner in Ward 7. So thank you.
Thank you. All right, we're going to go to our next panel. Please make sure you submit your testimony for the record. All right, Mark Lavota, Carol Grigsby, Heidi Ellis, Maya Smith, Stephanie McGill, Peter Anderson, Justin Lisek. Again, if you're being called, you have to affirmatively accept our invitation to become a panelist. There'll be a little box that pops up on your Zoom screen. So just hit accept so we can promote you. All right, we've got some folks who are coming in, but I see Mr. Lavota. So when you're ready, Mark.
Chairperson Henderson and members of the council, thank you for the opportunity to testify today. My name is Mark Lavota. I'm the Executive Director of the District of Columbia Behavioral Health Association and a Ward 2 homeowner. The District of Columbia Behavioral Health Association works to advance high-quality whole person care for district residents with mental illness, substance use disorder, or both, including the 35,000 district residents that our 35-member organizations serve annually. The Department of Behavioral Health continues to attempt to meet high mental health and substance use needs with inadequate staffing and resources and an underperforming provider network. The pause of the DBH provider network's expected transition to managed care has left in place a gap period that's not serving district residents well. Quality and accountability concerns persist for the provider network. My testimony will focus on these issues and highlight a few promising signals while federal financial and policy changes loom. DBH was fundamentally unprepared to extend the so-called gap period started in October of 2023 that continues to this day. Managed care plans were expected to take over critical functions related to access, authorization, and payment of services, and care coordination. DBH did not and does not have adequate staff to carry out those functions. The result is community confusion about how to access care, unnecessary service utilization, and use of inappropriate levels of care. Department of Behavioral Health gap period weaknesses are only one symptom of understaffing and inadequate resources, which are also evident in the underperformance of the DBH provider network. DBH needs to reinstate provider report cards and community service reviews so Sunshine can serve as a disinfectant to help consumers vote with their feet and starve billing revenue from organizations not offering adequate services. DBH and the Department of Healthcare Finance should target efforts to relieve higher performing organizations of burdensome scrutiny, to guide underperforming providers either to improve or to exit the network, and to remove bad actors. DBH and DHCF also should continue to make adjustments to address provider network staffing and reimbursement limitations, which exacerbate performance challenges. Department of Behavioral Health and provider network staffing and resource concerns should not spoil good news. Opioid overdose fatalities and non-fatal overdoses are no longer rising, though much work remains. There are less frequent readmissions to St. Elizabeth's and greater stability in community residential facilities. Planning is underway for a permanent Medicaid reimbursable pathway for certified community behavioral health clinics. And we also encourage continuing efforts to improve assertive community treatment, redesign community support, reassess rehabilitation day services, rethink the school behavioral health expansion financial model, align services with updated American Society of Addiction Medicine level of care guidelines, and enhance substance use services for young people. I want to thank the Department of Behavioral Health for its work and Dr. Basran for her leadership. I thank you for the opportunity to testify today and look forward to answering any questions you might have.
Thank you. Carol?
Thank you. Thanks for allowing me to testify today.
My name is Carol Grigsby, and I blog on issues affecting people with developmental disabilities at www.dcandwdc.com. I'm testifying today to make sure that DBH and affiliated entities keep in mind and demonstrate awareness of the specific needs of developmentally disabled individuals whom they serve, some of whom you've heard from today. The abrupt closure at the start of this fiscal year of 35K, where Dr. Augustus and his staff had focused specifically on the psychiatric needs of people with intellectual and developmental disabilities, gave rise to significant concerns among those who had been served there. While people with active family supports tell me now that they have been able to secure good psychiatric services from one of DBH's core service agencies, it's not clear at all that people without such supports have been able to identify services of the same caliber that Dr. Augustus was able to provide at 35K. Moreover, the lack of lead time in informing people about the closure showed a significant lack of awareness of the difficulties that such a rapid transition can present for some people with developmental disabilities. The Department on Disability Services increasingly urges the people it supports to turn to DBH for their behavioral health needs. But if DBH is going to be increasingly assuming this role, then it must have personnel with the proper expertise and perspective to address appropriately the needs of disabled people. Non-neurotypical individuals or those with a primary non-neurotypical individuals or those with cognitive deficits may not respond in the same ways to standard interventions as those with a primary mental health diagnosis, and staff who are interacting with them need to be aware of and account for those differences. It's without a doubt better for people with disabilities to encounter a CRT rather than MPD officers. However, with 10 years of personal experience as a family member of someone receiving residential supports from DDS, and with a great deal of interaction with other knowledgeable advocates and families, I personally do not yet have confidence that DBH or its affiliated facilities have the necessary expertise to deal effectively with those for whom mental health is not their primary diagnosis. Perhaps not even those, based on some of what I've heard. And in this context, it's of great importance for me to mention that Georgetown University School of Medicine is undertaking a survey of people with disabilities who have received mental health supports in DC, and also of the staff of the core service agencies who have provided those supports. If Georgetown gets good participation, the results could provide essential information for this committee and its future oversight. I very much hope that this will help sustain the momentum toward greater awareness of and support for the specific needs of people with disabilities when their services come under the jurisdiction of DBH or its affiliated organizations. It was clear at the hearing in October that a great deal of work is taking place to ensure the district's behavioral health services are well suited to existing need. So this is the moment to ensure the requirements of all residents are well served. Thank you very much, and I'll be happy to answer any questions.
Thank you. Heidi?
Can you all hear me?
If you speak a little louder.
Can you hear me?
A little louder.
You know what? 1 second. Let me, sorry. Is that better?
Sure, go ahead.
Actually, sorry, I think it's my, my AirPods.
Okay, is that better?
Yes, it is.
Sorry about that. I tried to use my AirPods, but they weren't connecting. Good morning, Chairperson Henderson and members of the committee. My name is Heidi Ellis, and I'm testifying on behalf of the DC LGBTQ Budget Coalition, which is a group of LGBTQ-led and LGBTQ-serving organizations and individuals advocating for major investments and policy changes that improve the lives of queer people in DC, with a specific focus on individuals of low to no income, Black and Brown trans folks, and those with disabilities. Thank you for the opportunity to testify today before this committee. The LGBT community in DC faces disproportionately high rates of mental health challenges, including anxiety, depression, and suicidal ideation. Nationally, LGBTQ individuals are more than twice as likely to experience a mental health crisis as their non-LGBTQ peers, with over 40% of LGBTQ youth reporting seriously considering suicide in the past year. And that rate jumps up to 53% among transgender and non-binary youth. Here in DC, where nearly 10% of all adults identify as LGBTQ, ensuring access to affirming, cultural competent care is vital. Yet at a time when we should be strengthening these resources, we are facing an unprecedented assault on LGBTQ rights and funding at the federal level. In just this past month, the new administration has issued executive orders aimed at rolling back DEI initiatives, restricting federal health funding for LGBTQ programs, and weakening non-discrimination protections in federally funded healthcare settings. These attacks directly threaten the ability of LGBTQ individuals, particularly trans people and low-income individuals and communities of color, to access life-saving mental health care without robust local investments, the very services that have made DC a leader in LGBTQ health equity could be destabilized. Now more than ever, DC must act decisively to protect and expand the programs that support LGBTQ residents. The ongoing shortage of mental health providers, the lack of accessibility, and shrinking federal resources leave too many LGBTQ residents without the care they need. The council has the opportunity and frankly the responsibility to fortify these programs, ensuring that DC remains a national model for inclusive, affirming, and accessible healthcare. Over the past several years, the DC LGBTQ Budget Coalition has successfully fought for increased funding and policies that have expanded access to affirming care for LGBTQ residents. Through our advocacy, the district has strengthened critical health programs, including securing funding for LGBTQ behavioral health services, advocating for greater investments in HIV prevention and treatment, and pushing for language access and disability accommodations. We've previewed some of our requests for FY26, but just to highlight, given the lack of time, we're going to continue to fight for expansion of LGBTQ inclusive mental health services, operationalize potential mobile mental health units, and increased for this purpose of this hearing, some increased oversight of this investment of $250,000 in harm reduction for the LGBTQ residents that's administered through the Mayor's Office of LGBTQ Affairs. That was included in the last budget, and we just want continued understanding of how that's being spent and where that's going. Happy to submit more testimony. I've already submitted some, and happy to answer any questions. And thank you, Chair Henderson, for being a great advocate and partner in this work.
Thank you. I don't see Maya Smith. I do see Stephanie McGill.
Yes. Good afternoon, Chairwoman Christina Henderson, staff members of the DBH, and fellow residents. I am Stephanie McGill. I'm a mother, a grandmother, and the president and lead conductor of my nonprofit called the Soul Train. I thank you for the opportunity to share my thoughts and observations today. I want to talk about a 1999 study that shows that 60% of drug users resided in the District of Columbia. And that's more than 10% of DC's population. Today, it's more like 13%. And African Americans are overrepresented in the drug population, which causes me great concern. I believe it's because of our inherited trauma, and it causes low self-worth, and we need proper direction in that. We as a people have a hard time asking for help. And I found myself in a situation where I was experiencing DV, and I stepped out on faith and asked for help for these services that are provided to us. I was referred to Harriet Tubman, and I was immediately, intimidated. And as you know, I saw a lot of mental health people just wandering around. I put on a brave face and walked through the doors anyway to receive the services that I, as a citizen, deserved. I was given a case manager and offered time with a therapist. When I went in there, the first case of action was for the therapist to offer me medication, and in which I declined. And I just found that a little disturbing because I see, as I walk through the District of Columbia, I see a lot of people wandering and they're on drugs, and it seems to be the norm nowadays. I'm not a native Washingtonian. However, I've been here since 1989, and I just wanted to give you my thoughts and my observations. Looking at this 1999 study, it tells me that their offspring would be today in the ranges of 15 to 25. This population is really plagued with drugs, and I want us to explore the root causes of it. I believe that a more holistic approach to behavioral health is needed in the district because we as a culture learn different, and I believe that these drugs are drugs, where they come from the doctor or the street. They're not good for our chemical imbalances, and it causes nothing good can come from it. So I urge this council to strongly consider using a more holistic approach to mental health. And my organization Soul Train focuses on that. It breaks my heart, and I think that most people are misunderstood, mostly the young population. And I ask that DBH and DPR collaborate and support more organizations such as myself and empower the leaders that are in the neighborhoods, because we are the experts. And I thank you for your time.
Thank you.
Thank you.
Mr. Anderson.
Okay.
Good afternoon, Chairperson Henderson and members of the committee. I'm Peter Anderson, Head of Schools and CEO of Washington Latin Public Charter Schools. Thank you for the opportunity to testify today about school-based mental health services in DC. At Washington Latin, we see firsthand how our students bring their challenges with families, friends, and community into our buildings daily. These challenges significantly impact their ability to learn and succeed. This year, more than 8% of our students have counseling services written into their individual education plans, reflecting the growing mental health needs in our school community. We have invested heavily in mental health support with 10 dedicated professionals working directly with students in counseling roles across our 2 campuses at a ratio of almost 1 for every 100 students. Despite this substantial commitment, the need has been so great that we've brought on 2 additional interns to help meet our students' needs. Even 3 years after the pandemic, we continue to see students struggling not only with mental health challenges, but also with basic social skills that were disrupted during those difficult years. I want to acknowledge DBH's collaborative approach with schools and OSSE. In particular, I want to highlight our positive experience with the DBH clinician program through Catholic Charities, with whom we're partnering this year. Our in-school therapist has been an invaluable asset to our mental health team. However, I must note that our Cooper campus has been requesting a therapist since the beginning of this school year without success. Last year, we lost clinicians on both campuses and neither one of them was replaced. This situation illustrates both the program's value and the ongoing challenges we face with clinician shortages. I encourage DBH to explore innovative funding approaches, particularly expanding the pilot program that provides grants directly to schools for mental health staffing. This model offers several advantages. Schools can move quickly to hire when positions open, can align compensation with their existing salary structures, and integrate mental health professionals more fully into their school communities. Our experience shows that having mental health staff who are direct members of our school team, rather than contracted through agencies, leads to better integration with our academic program and stronger relationships with students and families. At this particular moment in our city and nation's history, many of our students are experiencing heightened stress and anxiety due to political tensions, economic pressures on their families, and ongoing social challenges. It would be devastating to reduce mental health support just when our students need it most. Even in the face of budget constraints, maintaining and strengthening our school-based mental health programs must remain a priority. The costs of failing to support our students' mental health needs, both human and financial, far exceed the investment required to maintain these essential services. The mental health of our students is fundamental to their academic success and overall well-being. We appreciate DBH's commitment to innovation and collaboration, and we look forward to continuing our partnership to serve DC students. Thank you for your time, and Chairperson Henderson, and thank you particularly for your investment in addressing the mental health needs of students in DC schools.
Thank you. And I don't see Justin. But thank you so much to this panel of witnesses for your testimony. I've met with several of you to get a better understanding of some of the various challenges and issues. Mr. Anderson, I had mentioned this earlier to the panel right before. I was interested to hear from LAAs who've participated in the pilot in terms of how it's going. I know that you mentioned that you all had trouble getting clinicians for both of your campuses. Are you in the pilot now? And
We're not. So we were really interested in the pilots. However, there was an opportunity that came up for us to partner with Catholic Charities. And if we were partnering with them, we couldn't be in the pilot. And so we opted to do that at the beginning of this year. And we've been very pleased with the clinician that we've gotten at our 2nd Street campus. But even now, we're in February and we have not gotten a clinician for our Cooper campus.
okay.
And so, given that, we would love to be, I think, if we had another option, another choice, we'd choose to be in the pilot.
Yeah, I mean, I think you mentioned before in terms of the number of students who seek counseling services. So if you got one clinician for one campus, obviously, I think you all have, social workers and counselors and otherwise. But in terms of workload, in terms of meeting the need, it's clear that you all need some additional clinician support there.
Yeah.
Mr. Lavoda, I wanted to turn to you. School-based behavioral health is something that we've been talking about for a very long time. And I think we have diagnosed some of the challenges, which some of the individuals have brought up before around billing and otherwise. And I'm curious, in your opinion, how are conversations going with the Department of Behavioral Health to change the funding formula such that CBOs might have a better time recruiting?
Well, I think that there's a growing understanding of where the challenges are and that we can't maintain the status quo. What we've been doing is not getting us to every school and likely will not get us to every school. I think that we're going to have to both change the financial model for schools where it remains appropriate for CBOs to provide clinician services, and we're also going to have to assess whether or not this is the right approach for schools where we may need to take a very different approach. So it's a lot of work to get where we need to get. I think we're also going to have to revisit some of the early conversations we had when we were standing up the expansion program about the risk profiles of different schools and see whether we need to even consider reassigning some of the currently placed clinicians where we know that there are schools with higher needs that are a better match for the CBO approach and where we may need to deploy different resources.
Yeah, I hear you. Thank you again for your testimony, and obviously we'll keep talking about this issue and working on it. I did want to ask something separately from school-based behavioral health, though, which was brought up a little bit by Community Connections, which is the timely reimbursement issue. Is this something that you're also hearing from your members, Mr. Lavoda?
It's uneven. I think that we know that there are challenges both with financial processing for grant and contract payments and also with billing. Some of the things that we're seeing on the billing side, I would say, are not even necessarily about how quickly the Department of Healthcare Finance can process a claim, but it's earlier in the process. Did we actually get the care authorized in a timely manner? When the care was authorized, was there a notification put in place to the Medicaid payment system that those services were eligible for payment? Some of those prior steps, I think, are what we're seeing not work as quickly as we need them to work, and then people can't bill because the Medicaid system wouldn't yet recognize that as an eligible bill. So, again, grant and contract payments, slow, need further attention, specifically from DBH staff. Some of the other issues around billing challenges, I do not actually think are about once you are able to submit a bill that it doesn't get paid quickly, but more along the lines of it's hard to get authorizations. It's hard to get authorizations recognized in the Medicaid payment system. I will also say those are the things that are true for services that the government reimburses directly. We hear from all of our members that there are challenges with payment from all of the managed care plans. And so I think that's a different area that requires a different kind of scrutiny.
Okay, thank you. Ms. Ellis, did you have something you wanted to add?
Oh, I was just nodding in confirmation. We're in the same situation with our coalition members that, as you know, are a lot of service providers, Chair Henderson. So they're in the same boat in terms of delays in reimbursement and just overall funding, starting some from August, and definitely for this current fiscal cycle.
Okay. I'm over my time. Councilmember Felder, do you have any questions? Okay. I want to ask one last question for Ms. Grigsby. I always find that folks who run blogs or, you know, they have lots of questions. And so I'll ask you this. If there was one question that you feel like we should most certainly ask the Department of Behavioral Health on Wednesday when they are before the committee, what would that be?
I would like to know whether the Department on Behavioral Health plans to specifically develop expertise in dealing with other people who have cognitive disabilities, because at this point, I don't believe that that is really a goal in the Department of Behavioral Health, and yet DDS is referring people increasingly over to them.
I see. Okay. Will do. Thank you so much to this panel. Please make sure we have your written testimony for the record. We're going to go to the next panel of witnesses.
Thank you.
Thank you. Manutri Martin, Raymond Whedon, Marissa Perella, Rachel Kimboko, Laura Masteus, Shane Sullivan, and Emily Hayden. All right. I see Manutri, so why don't you go ahead and get started?
Sure. Good morning, Chairperson Henderson and Committee on Health members. My name is Manutri Martin, and I am the Advocacy and Communications Manager for the DC chapter of Education Reform Now Advocacy DC. Today, I'm advocating alongside members of the Strengthening Families Through Behavioral Health Coalition for a stronger behavioral health system for children and families in DC. Before stepping into advocacy, I spent over 10 years as an educator, where I saw firsthand what happens when students don't get the behavioral health support they need. I watched bright, capable students spiral into chronic absenteeism and academic decline. And while waiting months for mental health support, I saw their issues escalate into a crisis. I'm happy to know that the school-based behavioral health program is now reaching 146 schools to date. However, 111 schools either still have provider vacancies or they remain unmatched with the CBO. Even where coverage exists, we lack data, public data on wait time, service access, and outcomes, and families still face barriers to resources. Meanwhile, the latest 2023 Youth Risk Behavior Survey reveals the scale of the crisis. Over 70% of DC middle and high school students reported struggling with behavioral health, and more than 20% have felt this way most of the time or always, but they don't know where to go for help when that happens. Without a fully staffed, well-coordinated behavioral health system for our schools, these numbers are only going to worsen, as I'm sure you know. The vision of the SBBH program has always been clear to address these issues, but as of today, executing is falling short in two key areas. First, we have an inconsistent and unstable workforce. Without a sustainable multi-year workforce plan that keeps pace with inflation to ensure workforce stability, we're continuing to lose providers to other industries, leaving students vulnerable and without essential services. And two, there is a gap in access beyond schools. Currently, DC does not have a truly easy to use centralized platform specifically for families to find behavioral health services beyond what schools provide. While various directories do exist, families have not found them to be user-friendly, comprehensive, or well-maintained, making it difficult for them to navigate the systems. This leads me to wonder where we are on establishing the Child Behavioral Health Service Dashboard Act of 2024. I'm wondering, when can we expect an update on this bill? The bottom line is that we cannot afford to let behavioral health support in schools remain unstable. Students' well-being depend on it, and their future does also. And so we urge the DC Council to use this oversight process to push DBH towards more proactive solutions. Thank you for your time.
Thank you. Mr. Whedon.
Good afternoon, Chairperson and members of the committee. My name is Raymond Whedon, a proud Ward 7 resident, and I am the Executive Director of Thurgood Marshall Academy in the Great Ward 8. I appreciate this opportunity to speak about the partnership with DBH and its impact on our students. I especially want to celebrate, before we get started, Ms. Black, our on-site DBH clinician. She is a superstar. She is a full member of our TMA team and works incredibly hard to support our school's missions through her services. We also want to thank Dr. Sharnita Scott and Dr. Bazran for their leadership. Dr. Scott is a steady voice of reason from the initial phases of the expansion through today, and Dr. Bazran has consistently kept the eye and the ball on students. Through our successful collaboration with DBH, we have been able to offer critical counseling services and social work services to our entire school community. This partnership has made it possible for last year 130 of our 340 students to receive direct mental health services as a result. These services have been instrumental in addressing our students' daily social and emotional challenges, allowing them to engage more effectively in their educational and personal development. Additionally, we do appreciate DBH's school mental health expansion pilot, which has helped us look for opportunities to fill vacancies. We want to encourage them to continue the investment in this initiative and further refine the application and awards process to ensure more schools can benefit. This is the right program for schools, and it has been an iterative process, and the product we have now is stronger than it was years before. I do want to mention that, however, that it also is connected to our biggest challenge, remains a shortfall of qualified clinicians. Since the expansion, since we transitioned to the expansion, as a result of our CBO not being able to staff consistently, we are still continuing to look for a qualified clinician in the role. This has proven to be complicated, and it sounds like because a lot of us are actually looking for the same type of qualified folks. And on top of that, we're looking for qualified folks who can work in a population of high need populations. We appreciate DBH's efforts to grow this pipeline of well-qualified clinicians, including strengthening the reciprocity agreements with neighboring states to attract more licensed professionals to work in the district. We know that mental health services are not a luxury, they are a necessity. And so without a fully staffed team of clinicians, we cannot meet the increasing needs of all our students. We urge the Council and DBH to sustain the funding for school-based clinicians and prioritize the policies to ensure that every student has the support that they deserve. Thank you for your time.
Thank you. Marissa?
Thank you. Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for this opportunity to testify today. My name is Marisa Perella, and I am a DCPS parent, foremost, and the founder and executive director of the Momentum Residency, which is a new initiative that addresses mental health workforce sustainability. Momentum recruits social workers and mental health counselors and matches them with employment in partner schools or community-based organizations who invest in clinicians' growth and sustainability. Momentum provides hands-on experiential training, clinical supervision, mentorship, and a cohort learning environment, activities that address what we know support retention and school-based work. I've spent the last 25 years as a social worker in Washington, D.C., and the last 15 dedicated to addressing the youth mental health crisis through school-based supports. As the former director of the Mary Center School-Based Mental Health Program and one of the original architects of the school-based expansion program, I saw firsthand the impact that excellent practitioners can have on children and families in schools, and how their longevity in the work exponentially improves the school environment, as well as trust among families and communities. I also saw how the brave investment of this council and the hard work, as Raymond mentioned, of Dr. Scott and Dr. Bazran in the expansion of school mental health has provided this opportunity to immediately address the youth mental health crisis. The high utilization of the program when it's working, combined with the student and family support of the program, are a testament to its success so far. We often give voice to the challenges and hear about the high practitioner vacancy rates in our schools, and those must be addressed. However, let's also consider that nearly 60% of schools, that's thousands of children and families who benefit from this investment, and that reduction in support could disrupt their health and wellness. Let's also consider that there are still adjustments that can be made through this iterative process, through collaboration and continued investment in creative initiatives, such as Momentum, that support schools and CBOs to make the program successful. Finally, we continue to be short the recommended ratios of children to mental health practitioners in schools, and the expansion program continues to get us closer to meeting those appropriate ratios. As one of the original members of the task force that envisioned the school-based expansion program, I'm very familiar with the successes, the challenges, and the opportunities that the investment provides. I know we have the expertise and commitment to enhance the program and creatively tackle its
Okay. I think we lost Marissa. I'm trying to give a. Okay. All right. We'll circle back when hopefully her connection improves. Rachel?
Hello?
Oh, Marissa. Yes.
Yes. Am I back?
Yes, you're back. We lost you in the last 30 seconds there. And we
I'm not
lost
sure
you
I
again.
I'm not sure where I left off, but I was saying I know we have the expertise and commitment to enhance the program and creatively tackle its pain points. This will take continued investment in the existing creativity and collaboration of the public and private sectors. As a member of the Strengthening Families Collaborative, I see the myriad of stakeholders, community members included, and initiatives it takes to address the needs of children in schools. They are complex. This investment has been groundbreaking and has yielded national attention. The Momentum residency, although new, has attracted both national and even international candidates who report they're interested in working in DC because of the expansion program and the commitment to children and families. They see DC as an environment that invests in its children. Filling this much needed gap for our children has transformed many schools, such as the one Thurgood Marshall, and expanded access to care. And because of this, families are supportive of the program. We ask for the opportunity to develop continued solutions, continue with this iterative process, solve some of the issues that we're having, and enhance the program as a whole so that we can continue to provide consistent resources that are widely available and tailored to the needs of our community.
Thank you so much.
Thank you for this opportunity.
Thank you. All right, Rachel?
Good afternoon, council members and staff of the Committee on Health. My name is Rochelle Kimboko, and I'm the founding executive director of DC Wildflower Public Charter School with facilities in Wards 7 and 8. We're a growing network of Montessori 1 and 2 classroom microschools with students from pre-K 3 to first grade and eventually 5th grade. We've known from the start that we wanted our schools to be a place of healing, not a place you had to heal from. We're committed to centering the wellness of both students and adults in our community and have addressed this by implementing a strong, inclusive Montessori approach. With the majority of our students under the age of 6, we are serving students whose lives are entirely grounded in the context of the universal trauma of a global pandemic. And it's not only the children who are struggling. Their caregivers are also coping with pre-existing challenges like economic hardship or community violence, which can manifest as stressors at home. It's no surprise that there are behavioral and mental health challenges that significantly impact students' ability to learn and succeed. Because we have a uniquely small community, 1 or 2 classroom microschools, we have struggled to afford the professional service we had imagined. It was frustrating to see the need, but not have capacity to address it directly. And at our small scale, we weren't an appropriate placement for a typical DBH clinician because we don't require full-time support. In year 2 of the recent school mental health pilot, we're receiving funding to support a partnership with an external service provider, Onyx Therapy Group. This winter, we have a contracted clinician working with our students who need extra support, developing their social emotional skills, or coping with student-specific kinds of behavior. We've identified a curriculum for all students that will build their capacity to identify and discuss their emotions and to learn to separate big feelings from inappropriate action. First, I want to thank Dr. Scott and her team. Throughout our application journey and implementation process, they have extended abundant grace and patiently given technical assistance when needed. I would encourage the team to incorporate feedback about how to accommodate variations from the standard in-house full-time clinician model so that we and other small LEAs can continue to benefit from DBH funding. These might include streamlining grant award timelines so schools can move more quickly from award to implementation, as well as smaller refinements to the application process. The DC Charter of School Alliance has played a key supportive role in our process, providing an initial review of our application and checking in regularly on our experience. I would encourage DBH to continue this collaboration, including hosting convenings of these pilot schools. Finally, we hope that DBH will continue to support community-based clinicians and make the inflationary adjustments that make it possible for those to continue so that there are clinicians in place to respond to behavioral health needs of my and other DC public schools. We'll all benefit from there being more capacity in the system. Thank you for your time and consideration.
Thank you. Laura? Oh, I don't see Laura. Shane? I don't see Shane. All right, Emily.
Thank you, Chairperson Henderson and members of the committee. My name is Emily Hadeen. I am a Ward 4 resident and the Executive Director of Breakthrough Montessori Public Charter School. We serve 383 students from grades pre-K 3 through 6th grade. And I would like to take this opportunity to share Breakthrough's experience with DBH's school-based mental health pilot program and urge the continuation of this resource for public schools. Last spring, Breakthrough received funding through the SBMH pilot program to hire a school-based clinician, and this has made an important impact on our school community. Prior to this pilot program, Breakthrough only employed one social worker, and this clinician struggled to meet the needs of a ballooning caseload. And with only one clinician, our school could really only accommodate the counseling services called for in student IEPs. So this means that when other students required counseling services outside of the context of an IEP, they languished on a wait list and rarely received consistent support. That changed with the SBMH pilot program because we were able to hire a second clinician who is a licensed professional counselor. Now, this second clinician offers individual and small group therapy to students on 6-week rotations, and she can respond quickly to students who are experiencing acute mental health needs due to divorce, a death in the family, housing instability, or other traumatic circumstances. We can also respond to the evolving needs of our school community by organizing short and medium-term small group counseling on a topic or a focus point that is relevant to multiple students. So for example, we can offer a small group on how to manage our anger, another small group on responding to peer pressure. With a second clinician, our families can very easily and very quickly fill out a referral form and a consent form so that their child can be seen by this clinician without a lengthy IEP eligibility process. So thanks to this pilot program, Breakthrough is finally making progress on building out an authentic multi-tiered support system for mental and behavioral health needs, whereas previously we really only had the capacity to serve students in the highest tier of needs. And I want to be clear that this expansion in mental health services at Breakthrough would not have been possible without the DBH program, because hiring this clinician would not have been likely with our UPSFF funding alone. We really appreciate DBH's patience as we have learned to navigate the reporting requirements and the application requirements. We hope that DBH will continue to work with charter schools to understand this new process. But overall, we really strongly support the continuation of this funding stream and the focus on ensuring schools have adequate clinical support for students. Thank you so much for the opportunity to testify.
Thank you. Thank you to this panel of witnesses for your testimony and of This was very educator focused. So I want to say for all of the work that you guys do on behalf of DC kids. Emily, I wanted to ask, you mentioned specifically in your testimony that through the pilot program, you all hired a licensed professional counselor. I'm curious, did you find recruiting for that type of position as opposed to a psychologist or social work to be easier?
No, I don't think it was easier. So initially in the spring of last school year, we received notification of our grant in April, and between April and the end of that school year in June, we were unsuccessful in hiring a clinician. We had initially sought to hire a licensed graduate social worker, but were unsuccessful in recruiting that candidate. And then over the summer, we broadened our scope to look for other types of clinicians, and we were able to connect with the licensed professional counselor that we ultimately hired through our schools network, right? So we families in our community and faculty members in our community were helping us connect with individuals. So I would say that it was a struggle. We are so grateful that we found this individual and were able to bring them on board, but I don't think it was necessary easier to recruit a licensed professional counselor compared to a social worker or another clinical role.
Okay. I'm just kind of curious, because, in sort of the cadre of various licensed positions, you can kind of, not every school needs a psychologist, right? You might need something a little bit different. And I thought when we were working with DBH to try to get them to do this pilot, to allow for the flexibility of a school to be able to, evaluate what their student population looks like, what size their student population looks like for schools like Rachel's, which is smaller, micro school, they might not need, a full-blown situation for 40 hours a week for 2 classrooms, right? So it could vary, but we're trying to kind of balance what it is. I want to ask you, though, because you all had the experience of talking with candidates and otherwise, was there a particular reason as to why this didn't click for folks, or was it you literally were not getting application responses?
A little bit of both.
Go ahead, Emily. No,
Sorry.
Emily, go ahead.
So we were getting application responses. We were getting a few application responses, and we were determining that these individuals just might not have the professional experience to work specifically in a school setting with children.
Okay. Yeah. Yes. There might be some people who are applying who have only ever dealt with adults, and dealing with a 12-year-old is a completely different situation. Okay. Raymond, you wanted to hop in on there?
I don't think it's much different than what you said, Councilmember. It takes a special person to work in my building. And so when we go through the screening process, we look for efficacy, like people who really believe children can achieve at high levels no matter what. And unfortunately, there's just not a high level of that. And I think vice versa, when we were with getting clinicians from the CBO, unfortunately, there was really good, well-meaning people, but the workload is high here. A lot of our children are receiving services, and this wasn't the type of work that they wanted to do. And so when we did our interview process with folks, it's either one of those two things, like, oh, wow, that's a lot, is what we heard. Like, that's a lot.
Okay.
They just really weren't about the work of serving Black children, honestly.
All right. Rachel?
I was going to add that because we are a program that has centered Black and brown children and has a predominantly, Black and brown staff, I think we really wanted to find clinicians that we felt confident would be prepared, to Raymond and Emily's point, to be working with those children and families. And so Onyx was kind of a natural partnership, and we had been talking with them for a long time. The challenge was finding the additional funding. And even now, I think there is at this point a question about, so does Onyx help us hire somebody that can be, that can be more cost effective than contracting? So we're still thinking about what are the financial consequences of the decision, and of being in a relationship with someone who is a contractor versus on staff, and looking forward to having someone on staff eventually. So.
Okay. Shane, I see you. Just sit tight. We'll just have you go for the next panel. Marissa, in terms of the conversations that you've had, what has the feedback been?
Yeah, this is a really interesting conversation because the residents that we recruited this year, there's 13 of them working in DC, mostly charter schools, but in DC schools. Many of them, the challenge of working in a DC school comes from not necessarily not wanting to do the work, but not wanting to do the work without the level of support that I think they really need, particularly because the majority of folks coming into school-based work now are very new. We lost a lot of our experienced workforce during COVID, and I saw that happen before my eyes. And so now you have this new workforce. And actually, I just met with a group from University of Maryland, 20 of them, who are ready to enter the workforce this spring and wanting to work in schools. They're in a school-based fellowship. And they are seeking a place that can provide them support, a lot of supervision, everything they need to build their skill set in a very difficult environment. And I know Raymond has an amazingly supportive school, and I'm sure all of you do, but I think to have a community of mental health practitioners that kind of speak your language is also a really important place to be. And so a lot of what we've done and what we've seen in our residents is just that need for support, for feedback, for supervision, just that. And that's why we call it a residency. It's a practical 2-year intensive focus until Joe Biden gave us money to give graduate schools fellowships for school-based social workers. There were very few graduate programs preparing our students for work in schools. And so you were relying on competing for LPCs and LICSWs. And we were competing for them, for those experienced folks moving around. But right now, I think we need to invest in this new workforce, this young, excited workforce that wants to do this work, but they want to do it differently. They want support, they need training. At a place like DCPS, they get kind of they get, well, first of all, that's only social workers. So LPCs can't enter that market. They only hire licensed clinical folks, which is great. But the charter sector, of who we're talking to right now, I mean, they have to look at everyone. And I think they need support and they need funding to support providing that backbone for those first couple of years for our new
I wouldn't say that the folks in DCPS don't need the support either. In the programs that I have seen be very successful, KIP, for instance, comes to mind, where it's a team situation, but also KIP has multiple campuses, right? So you can facilitate the team-based setting. But I imagine for Emily, who is, I think Breakthrough is a single site, Rachel, single site, Raymond, like single site, that's hard, right? To be able to do the, you have the team calls and a manager who's checking in, and if you need to triage something or take it, if you have a case that you can't figure out, taking it one step ahead to somebody who might be more experienced. But that's a very interesting sort of thought and approach at the same time, because I imagine, even though Raymond may not say it, he's looking for somebody who's ready to go, not someone who's looking for on-site training, right? Because he doesn't want his kids to be the guinea pig. And I get that and I respect that. So we kind of have to figure out what the balance is on these pieces. I don't have any further questions. Manitri, thank you for being here. I don't have any further questions. Please make sure you submit your testimony for the record. We're going to try to, we're trying to figure this out. How do we do this in a world where I have less clinicians? I have less clinicians who desire to serve in person at schools, because if I look at the data from DC Health, the workforce exists. They're just they can make all their money that they need from private practice. All right, we're gonna go to the next panel. I just want to forecast for folks because I've been sitting in this chair since 10. After this next panel, I am going to take a short break, and then we will come back and finish up. Okay. All right. So I've got Shane, who's already here, Burnett Crislet, Renita Hutchinson, Christina Radin, Diana Ginn, Lamika Payne, Regina Marr. Okay, all right. Only Regina is here. So we're gonna keep going, just so we have a fulsome situation. Okay, Whitney Gray, Tamika Jackson Gilbert, Aisha Barnes, and Jessica Rice Lonecker. And Betty Gentile. Okay, all right. I'm seeing enough folks. We can go ahead and get started. Shane, why don't you go ahead and start?
Thank you. Can you hear me?
Yes.
Okay, great. Thank you. Good afternoon. My name is Shane Sullivan. Aisha Siddiqa reminds us that every border implies the violence of its maintenance, but until the full abolition of the state, I am a problematically proud Ward 4 resident. I currently work in drug policy, and in addition to being a committed abolitionist, the other primary lens through which I engage with the world socially and ethically is as a harm reductionist. I worked with HIPS for 11 years, beginning for half of that time as a volunteer, and the latter half on staff as their harm reduction coordinator. Within that entire time frame, though, I was always an outreach worker. It continues to be the greatest honor of my life to have had the privilege to be able to engage in that work and to collaboratively establish and foster relationships and community with HIPS participants, the bulk of whom are people who use drugs, sex workers, unhoused individuals, and other people engaged in street economies. I'm grateful to be here today as a member of the National Survivors Union, or NSU, which is this country's only national drug user union comprised of both current and former drug users who engage in advocacy, community-based mutual aid, and capacity building for local union chapters, with the recognition that people who use drugs are the experts on this country's overdose crisis, which I increasingly refer to as a crisis of racialized carceral capitalism after years of witnessing firsthand how the so-called war on drugs perpetuates historical legacies of criminalization, violence, and trauma rooted in a racist and classist caste system through various mechanisms of social control nationally and also in DC make the words of Toronto-based harm reduction activist Zoe Dodd continually and depressingly salient. Every overdose death is a policy feature. I personally know drug users who've reversed hundreds of overdoses, and that is just one example of them being the experts. They are the frontline responders. They reverse 80 to 90% of overdoses that occur. And I think it's important to point out that trauma. I know that when questioned, DBH leadership will point to the decrease in overdose deaths. I don't know any drug user personally who's celebrating right now. I know a lot who are grieving. I don't think it's a win to kill off an entire generation of people through overdoses. We anticipated that at some point there would be a decrease in these numbers, and nationally there also has been a decrease. And I think the important point there is really just that we don't actually know why there's been a decrease in overdose deaths. It is just one marker of drug user health, and so I want to look at things holistically. With the time that I have, I also want to just state my support for the testimony of members of Hayride Wildest Dreams who testified earlier, Nini, Frankie, and Jillian. Ultimately, I am not saying much new from what I have previously testified about, except that I think it's important to center drug users and speaking also to the testimony of people who are patients earlier. We need community-based providers like HIPS to be able to actually be supported and scaled up. And so the ask that we've had for years now for a 24-hour harm reduction center, or rather for, oh, sorry, I didn't realize how over my time I was. I can wrap up. Ultimately, I think that people do not trust DBH at the end of the day to provide these services, and we have models to look at, community-based models that would solve both the issue of drug overdoses, but also mental health crises. So Cahoots in Eugene, Oregon, and also On Point in New York City. And sorry, I'll end there since I'm so over.
Thanks, Shane.
Thank you.
Regina? Regina, if you're speaking, you're on mute.
Okay. I'm sorry, I apologize. Good afternoon, everyone. My name is Regina Marr. I am a teacher at CERG Child Care Center here in Ward 7 on Minnesota Avenue. Today, I am advocating for the children at my center. I just have a few lines here. Just a few lines to inform you how very important our mental health consultant, Ms. Snorri Jones, is to our community. Since day one, Ms. Jones has done a phenomenal job, not just assisting the children we refer her to, but to the staff as well. Whenever I have a student that I think needs assistance, she never hesitates to come into class saying good morning to each student by their name, interacting with all the children while observing the student I spoke with her about. After she gives me feedback and always answering my questions, she also emails me resources to help me with the child in the class. She will sit in on parent-teacher conferences, help lead parent meetings, always going above and beyond to make sure the students, teachers, and parents get the support that I need, that's needed. I really don't know what we would do without her. The thought of her not being here for our students is devastating and never should be an option. Never. I have seen the difference and will continue to advocate for the children in my care. Ms. Jones plays a vital role in our community and will always be needed. Thank you.
Thank you. All right, I don't see Whitney or Tamika or Aisha. I do see Jessica.
Hello. So thank you. Good morning, Chairperson Henderson and members of the Committee on Health. Thank you for the opportunity to address the council today. My name is Jessica Rice. I'm the clinical director at the Latin American Youth Center. So for those of you that don't know, the Latin American Youth Center was founded over 50 years ago and has grown to offer over 50 programs to empower a diverse population of youth to achieve a successful transition to adulthood. Each year, we serve around 4,000 youth and their families through programs supporting youth academics, job readiness, health and wellness, and housing, among others. And our behavioral health and mental health program in DC is a small but vital part of this work. A lot of people have spoken today about the school mental health program, but we are one of those providers. And we also have both substance use and mental health therapy in the community. In the past couple of years, instead of being able to increase our capacity as the need in the city increases, we have had to cut positions and programs. For example, we were one of the agencies who used to provide CBI 4 or 5 years ago, but are no longer able to staff it. So we've made these hard decisions to ensure that the services that we do provide are strong, and we're proud that the clients, for example, responded to our survey last year to report feeling overwhelmingly supported, understood, and safe with their LUAC providers. We try to spend most of our budget directly on our clinical team, right, to be as competitive as possible, to offer bilingual and culturally competent and experienced providers. I would note that the administrative burden, though, is also significant, and with the change from the carve-in, we are hoping to see a review and a streamlining of these confusing, disparate, and often duplicative processes soon. So we've talked a lot about billing with school-based mental health, so I would add my voice to those statements. However, school-based mental health, as important as it is, cannot be the only option for DC youth. And in fact, the young people that we serve out of schools are more likely to be homeless, disconnected from resources, or struggling with co-occurring disorders. The concern about the billing model is true across community mental health, across the landscape, and so much of this work doesn't translate to billable codes. It makes sense that a client may disappear from therapy when their family's housing is disrupted and they're living in a shelter, as just one example. In our substance use treatment, we find the same barriers, and if anything, a lack of trust in the system, stigma, and disruptions from services is even greater, and billing is even harder. Access to services means being able to hire and retain these providers. It means having enough funding to spend time to meet clients where they are, and it means providers who speak the language of the young people and their families. As you mentioned earlier, Chairwoman, part of access is having services across a full spectrum. We are best able to support when mental health, substance use, and trauma can be considered together to tackle both the internal management of stress, but also addressing systems become more trauma-informed and easier to navigate. Mental health doesn't happen in a vacuum, and true mental health, community mental health, connects what is happening in the therapy office to what is happening in the real world. So thank you for your time and consideration, and if you have any questions or matters you'd like to discuss, I can be reached.
Thank you.
I'm happy to answer questions.
Betty.
Greetings, Chairperson Henderson and members of the committee. Thank you for the opportunity to testify today. My name is Betty Gentle. I'm the Senior Advocacy and Community Engagement Specialist at Sum Incorporated, a DBA certified provider. Since 1970, Sum has fought poverty, homelessness, and hunger through our whole person care approach, which includes behavioral health programs that support mental stability and SUD treatment that helps individuals overcome addiction and rebuild their lives. We are members of DCBHA and a DC SUD Provider Coalition. Sum has long recognized that access to deeply affordable housing is a cornerstone of long-term recovery and stability, which is why, regardless of support through billing or grants, we provide transitional housing and support individuals in securing permanent housing. We appreciate that DBH and the Opioid Abatement Advisory Commission have begun prioritizing housing as a critical component of behavioral health care. However, systemic challenges within the DBH continue to hinder providers' ability to deliver essential services efficiently and effectively. Today, I want to highlight two key issues summarized in my more comprehensive written testimony. First, a strong SUD system benefits individuals while also fostering a healthier, safer, and more empathetic community, yet prolonged funding delays undermine its impact. Some appreciates expanding funding, however, unpredictable disbursement stalls critical services. For instance, an 18-month grant was reduced to only an effective 12 months due to delays, and another grant set for September 2024 is still pending a final letter of intent, preventing us from launching vital services. These delays have direct consequences: fewer clients served, fewer services delivered, and a diminished impact on the community. Second, year after year, some other providers have raised concerns about DBH's excessive administrative burdens, yet challenges persist and in some instances have worsened due to inconsistent communication and unclear guidance. For example, DBH's failure to clearly communicate Medicaid code changes in early 2024 led to widespread claim denials, forcing SUD providers to navigate costly and time-consuming resubmission processes that strain limited resources. While we are grateful to have recently resolved the issue with DBH's assistant, this situation highlights the urgent need for more proactive communication and collaboration to prevent future disruptions. One such matter is the transition from data WITS to an approved electronic billing system that has included minimal guidance from DBH, leaving providers to navigate complex reporting requirements with little support. Ongoing technical issues and unclear expectations have led to costly inefficiencies, with some spending an increased several $1,000s per month to remain in compliance. To address these ongoing challenges, we urge DBH to provide greater flexibility in submission deadlines, particularly when delays stem from DBH's own processes, establish regular provider forums for real-time discussions of challenges and solutions rather than the current fragmented approach, improve communication with vendors like ECW to streamline data submission processes, ensuring providers are not forced to access intermediaries between DBH and its approved vendors, and clearly communicate regulatory and coding changes through widely circulated bulletins and direct engagement with providers. SUM is committed to providing high-quality behavioral health services and supporting individuals on their path to recovery. We urge DBH to take concrete steps to strengthen its partnership with providers to support our shared mission. Thank you.
Thank you. Thank you to this panel of witnesses. I'll just jump right in. Ms. Gentle, I'm curious, we've heard earlier from some testimony from folks with concerns about staffing at DBH. And I'm curious in terms of the individuals that you all deal with around billing and some of the other issues, do you find that it's easy to get someone on the phone if you need some technical assistance?
I think it probably could be inconsistent, but I would say that our staff would more than likely say it's not easy to get someone on the phone. And I think one of the major issues too is, like, for instance, if DBH asks us for something, we try to get them that information within 48 hours, for instance, like I talked about with the delay in grants disbursement, but it can take several weeks to finally get a response or a confirmation about
So not even an acknowledgement that they received what you sent.
yeah, no. And when they do respond, they usually will tell us like, oh, that's under review.
Okay. Yeah, what you talked about in terms of proactive communication, I think is key. And as you said, could probably solve some of the delayed challenges if we are just more forthright with folks, but also if someone has a question for them to be able to get somebody on the phone. Ms. Rice, I saw you kind of nodding as well. I'm not sure if LAYC has had similar issues.
Yeah, we've had a lot of issues around Medicaid, but also around local dollars for sure. Just even getting a sense of like their kind of accounting of what they've paid us already and what's missing.
And what's missing. So just on the accounting side, so that's a bit alarming, considering we should have systems that are truly checking all of the payment pieces. Let me ask a question that, and I'll start with Shane, that I asked a witness earlier. Often you guys hear these, you're observing these hearings, you're testifying now, but you won't be participating on Wednesday. But if there was one question that you feel like the committee should most certainly ask DBH, what would that be? Shane?
It's hard to make it just one question, but I'll try. I mean, this would like necessitate like the assumption that they would answer honestly, and I honestly don't know whether that's the case. But what I would ask is if they're actually committed to investing in a harm reduction infrastructure for DC, with the recognition of what I've been saying for years, that we need to listen to drug users and frontline workers and people in harm reduction. So that would be my question, like commitment to harm reduction infrastructure, and also actually listening to people who use drugs who are never represented at any of these meetings, like the Opioid Abatement Commission, for example.
Yeah. Okay. Ms. Rice?
Yeah, I agree that it's hard to ask one question, but I do think to some extent, without a good understanding of what, the services are that are like the administrative kind of plan, like what's the plan forward in terms of, like, what is our goal here? So a lot of times, for example, it feels a little bit unclear to even get a sense of who is like kind of officially enrolled with us. And some of the very basic kind of administrative tasks has been much more confusing the last couple of years. And so to me, like streamlining that stuff first so that we can make a better plan to address some of these things in the future, what I think would be the first step for me.
Betty?
Like with everybody's hard to just choose one question, but I think, and Mark Lavoda talked about this, really understanding the plan, or if there is a plan for this continued gap period where we aren't completing the full MCO transition. Because I think for our clinicians and our leadership, a lot of issues do stem from that. And even like with the reduced staffing, or hearing people talk about how like the access helpline is different now and people just being confused. So like what exactly is the plan? And I guess the new timeline for the transition to be complete.
Yeah. I think you guys brought up look, I too have the question of what's the plan in terms of the MCO integration, right? We paused it, but is it paused indefinitely? And if so, though, there were people who were transitioned from DBH because they were thinking those like that type of administrative work was not going to happen by the MCOs. So now we need to like backfill or do something different. And frankly, Shane, we could be asking the same question about what's the plan on harm reduction. When I talk to DBH and have very difficult conversations about their grants, right? That was what, 3 hours before the original cutoff of all federal assistance, for which that means every SAMHSA grant gone. So like, what is the plan? If we cannot fund it federally, how do we continue to do these types of things? And I think we have been caught flat-footed, and then we'll find out on Wednesday if there is a plan. All right, well, thank you so much to this panel of witnesses. I don't have any further questions. As I telegraphed before, we're gonna take a 10-minute break. So we will be back for the rest of the witness list. Thank you, 10 minutes. Okay, we are back. We'll call the next panel of witnesses, Carol Parks, Miracle Bell, Rhonda Williams, Tyra Hawkins, Bridget Hall, and Rosalina Burgos Gill. We'll also add Colleen Hawkinson. Again, for those who are testifying virtually, you need to affirmatively accept our invitation to become a panelist. Okay, all right. Ms. Hall, just hang on one second. It seems as though we are missing some folks on today. Elizabeth Budasing, Deborah Arnold, Masa Javakovich, Amy Quinn, Allison Muck. And Liliana DiMaggio, or DiMaggio. All right. Still looks like we're missing some people, but I see Ms. Hall, so why don't you go ahead and get started? You've been patient.
Good afternoon. Thank you, Councilperson Henderson, for allowing me to speak today.
Oh, I'm sorry, Paul, can you hang on one second? Sorry, Ms. Hall, we're waiting on cable to come back. All right, there we go. All right, now you can go ahead and get started.
Good afternoon, Councilperson Henderson. My name is Bridget Hall. I am the Executive Director of Big Mama's Children's Center, located in Ward 8. We are a licensed child care facility in serving the Ward 8 community for the past 42 years. We are nationally accredited. We are recognized through OSSI as providing high quality care and education. And we have been privileged to be partnered with the Department of Behavioral Health program, Healthy Futures, for over the past 8 years. This program is a very helpful program. The program helps us to be able to communicate with the parents positively. It also gives direct support with my staff, with being able to come up with comfortable plans for behavioral management and classroom management for children, for classrooms that host children with difficult behaviors, and a lot of times are not diagnosed or misdiagnosed. And it helps our staff, our teachers, kind of alleviate a little bit of the burnout syndrome, because we are servicing a high population of children with behavioral needs. It also helps the parent become more comfortable with not being in denial and being able to be receptive of services, very much needed services that they do not get from their regular healthcare provider, their doctors or pediatricians. I am very happy and very privileged to have the clinician that serves us now. She is very, very patient, very intuitive and very empathetic when it comes to the care and services that we render and the population that we serve, which are mainly our brown babies. Again, I thank you for this opportunity. I pray that we continue to fund these type of programs that are very much needed in the childcare community, because we serve a very, very precious population, and we're trying to help them bridge that gap positively into the next phase of their education.
Thank you, Ms.
for
Thank you. Liliana?
Good afternoon, Councilwoman Henderson. Thank you for letting me testify today. My name is Liliana DiMaggio. I have the privilege of working at Barbara Chambers Children's Center for more than a decade now. I have served for the last 5 years as a center director, and we have 5 locations around the city. On my location, center number 4 has been open for 2 years and a half, and for the last year and about almost 2 years, we have the privilege of working with Healthy Futures. And you know, I want to testify saying that the initiative is crucial for daycare centers because it promotes the well-being of young children by integrating mental health support, early interventions, and wellness programs into the early childhood education. By addressing behavioral health needs early, daycare centers can create nurturing environments where children develop emotional resilience, social skills, and a strong foundation for a lifelong learning. This initiative is a great support not only for the children, but also for parents and staff. It is especially important for centers to offer these services to families who do not speak English and may struggle to find the help they need. Language barriers can make it difficult for parents to access essential mental health and developmental resources for their children. That is why we are incredibly grateful to Healthy Futures as they always manage to provide a bilingual support, ensuring that all families receive the help and guidance they deserve. Their dedication allows children to thrive, parents to feel reassured, and staff to be better equipped to support the needs of every child in the daycare center. Thank you.
Thank you. Thank you, Ms. Hall and Ms. DiMaggio for all talking about the same program, which I don't feel like gets a lot of shine, but as I said earlier, you know, all that we can do for early intervention and certainly supporting your childcare centers, your small businesses, I think is super helpful. Ms. Hall, you said you all have been part of the program for the past 8 years. Do you have to continuously reapply for the program, or do they waive you in?
No, we signed a MOA agreement yearly.
Okay. Same for Ms. DiMaggio. You didn't mention how long that you all have been working with them.
For my center, it's been almost 2 years, but I know that the main location that has been open for more than 50 years, and they have been working for it longer. But it's the same way. We sign that MOA every year.
Okay. And how often is their clinician on site?
Once a week.
Once a week. Ms. Hall?
Yes, once a week. But sometimes we are, sometimes she will attend our parent meetings that we have also. So that will give her a couple of times in a week that she will service us. But she is always willing to meet with parents and teachers at Cole. So all we have to do is set up an appointment, and we can meet either virtually or in person with our clinician.
Yeah, I mean, again, I think early intervention is key. I feel like for
Yes.
early childhood educators, you all spend more time with these young people. And so you're able to pick up on things that perhaps a pediatrician can't pick up on in a 20 to 30-minute visit with a young person. And so it's good to hear that this is going well for you all. Are there any suggested changes that you would want to see with the program?
I would suggest that we get more time with her in-house. As I said, we've been here for 42 plus years. And the amount of children that we're servicing currently with behavioral problems, diagnosed and misdiagnosed and undiagnosed, is really, really a lot, more than I've ever seen in my history.
Skyrocket after pandemic.
And it is really trying for our teachers, though we have degree holders and we have teachers with certifications in early care and education. They are not equipped with mental health services or with special education resources a lot of times. So they are faced with burnout syndrome, and our clinician is excellent with helping support with that. He offers, a tremendous amount of professional development and trainings and workshops that we have to directly support our teachers as well as some of the parents, and it helps a lot. So, like, to get a little bit more time would be wonderful. Maybe that sounds greedy, but it's very much needed.
No, it's not greedy at all. If there is a need, right? Okay, well, thank you guys so much for your testimony and for being here. If you submit your written testimony for the record, we'll ask some follow-up questions about the future of Healthy Futures during performance oversight. All right, we're going to go to our next panel.
Thank you.
Will Doyle, Anna Rodriguez, Ty Andrews, Tiffany Randall, Morgan Denny, Luam Barhane, okay. Feel like we got a larger crowd this time. All right. Will, when you're ready.
Thank you, Chair Henderson, council members, and council staff. My name is Will Doyle, and I'm the Vice President of Housing First at Pathways to Housing DC. My role includes responsibilities for our programs under DBH, namely ACT and Community Support Services, as well as the Court Urgent Care Clinic at the DC Superior Court. We are grateful for DBH's collaborative work with providers to modify the ACT billing structure to ensure that it is achievable and supports the financial needs for operating ACT programs. We are also excited about their increased investments in training and technical assistance to ensure that all ACT providers are adhering to nationally recognized, rigorous, evidence-based practice standards. This will result in higher quality services and accountability across the entire provider network. However, we are currently experiencing delays with finalizing the final rules on billing, which has been exacerbated by a lack of timely and clear communication. We thank DBH and DHCF for the ongoing monthly half payments while these final details are implemented. While we are excited about the future of ACT and wish to expand our program, we continue to experience significant challenges related to increasing our capacity due to the major workforce shortages of licensed counselors and social workers. We appreciate this committee's continued collaboration with DC Health to address barriers to the counseling and social work professions. With DBH's support, the Court Urgent Care Clinic staff have been serving an unprecedented number of clients, providing immediate access to mental health and substance use assessment and treatment at the DC Superior Court. In FY24, CUCC staff completed 697 unique intakes, which is 16% above our contract benchmark. Additionally, we conducted 821 assessments and 4,157 follow-up visits. In FY25, CUCC staff are on pace to complete 792 unique intakes, which is 32% above our
Will? Okay, I think we lost Will. See if we get him back. One of the joys and hazards of Zoom, internet stability. All right, his box is still frozen. So we're gonna go to Anna Rodriguez, and if Will rejoins us, we'll restart. All right, Anna, why don't you go ahead?
Good afternoon. My name is Ana Rodriguez, and I'm a proud parent of a ninth grade student who attends McKinley Tech High School in Ward 5. I also serve as a McKinley Tech parent PTO, actually the president for Tech with PAVE, and also with PAVE, Parents Amplifying Voices in Education, on the citywide board, and Ward 5 parent leaders in education. Of course, thank you for the opportunity to testify today on such an important topic, increasing access to school-based mental health. Mental health impacts all aspects of students' performance, whether that be academic performance or the way they interact with their peers. When my daughter tells me about fights at her school, it is clear that many of these fights are happening because students do not have the conflict management skills or the coping skills they need to handle various situations. We have made great strides in increasing access to academic resources in schools to ensure that students are supported in schools. However, we have not made the same strides in providing our students with mental health support. We all want to see our students succeed, and a part of that is ensuring that they have access to conflict management. And coping skills, they need to be successful. I urge the council to consider how we can offer resources for mental health, coping skills, and conflict management skills in school. Not only do students need access to resources, but some students may require a higher level of support that only a trained clinician can provide. I am grateful for the Department of Behavioral Health previously worked on getting clinicians into schools. However, we do not have trained clinicians in all schools yet. I urge the council to continue supporting the efforts to get more trained clinicians into schools so all schools have staff and are properly trained for students. Finally, when I'm thinking about how we can increase numbers of clinicians in school, I cannot help but think of how ways to increase the pipeline of students who want to become mental health professionals. I know the council has been working to increase the pathways to becoming mental health clinicians. I urge the council to continue to expand this work to include our young people, how we can use CTE to build mental health professional pipeline. How do we get our young people interested in this field and provide them with a pathway to this career, starting in high school? I believe we have a real opportunity to empower our youth with what they need to achieve their goal through providing this pipeline. Thank you for the opportunity to testify. And I hope with this, creating a pipeline for students to become mental health professionals will help our students to be more successful. I'm looking to seeing this progress, and this is made through the year, and I yield to answer any questions you may have. Thank you.
Thank you. All right, Will, you're back with us. You had about a minute left. I think you were talking about the core urgent care clinic when you froze. If you want to finish out your testimony.
Sorry about that. Yeah, in FY24, CUCC staff completed 697 unique intakes, which is 16% above our contract benchmark. Additionally, we conducted 821 assessments and 4,157 follow-up visits. In FY25, CUCC staff are on pace to complete 792 unique intakes, which is 32% above our contract benchmark. They are also on pace to complete 960 assessments and 6,328 follow-up visits. This exponential growth illustrates the ongoing and increasing need for this critical same-day behavioral health service. DBH's funding of this program has been crucial in being able to provide urgently needed services regardless of client identification, insurance, or residency status. However, that funding is proposed for a cut from the budget. If nothing changes, it will end as of September 30th, 2025, and there appears to be no clear plan for replacement services. Councilmember Henderson, you played a key role in restoring FY25 funding for the Court Urgent Care Clinic. You have taken the time to visit the CUCC to fully understand the need for its continued funding. We deeply appreciate your support and ask that you continue to work with DBH to ensure that funding is in place for FY26 and beyond. Thank you for holding this hearing. I'm happy to answer any questions.
Thank you. Ms. Andrews.
Thank you. Good afternoon, everyone. My name is Ty Andrews, and I'm a Ward 8 resident, proud parent of 2 children, 1 third grader at Mary H. Plummer Elementary and 1 10th grader at McKinley Technology High School. I'm also a parent leader with PAVE, I represent PAVE in the capacity of a citywide and Ward 8 PLE board member. I'm also the vice president of the McKinley Tech Educational Campus PTO and a parent LSAT member for Mary H. Plummer Elementary. Thank you for this opportunity again. A child's mental health can affect their focus and understanding to retain information. Many children do not have loving homes to go to after school, and this exudes in their daily academic activity. Some children do not have a hot meal at home, and breakfast and lunch are the only times they eat a full meal at school. Lack of nutrition leads to lack of focus and understanding. We should also consider that mental health issues overall have increased nationally since the pandemic. Some families need mental health supports for themselves to better take care of and provide for their children. If the parents are not in a great mental space, you cannot expect them to ensure that their children are in school and on time. For many of our DC youth, school is a sanctuary from home. Therefore, our schools and our staff should take pride in participating in our youth village. School staff is there to support the children. There's no better way to support the district's academic achievement than by school staff providing a safe space for our DC youth. This can be done by ensuring that they eat breakfast and lunch and asking how their day was, referring them to mental health professionals, and sharing needed resources such as food and clothing drives with students' families. There should also be a mandatory evaluation for all incoming preschool students in DC so that we will not leave any child behind by catching any learning deficiencies early on, way before required school testing. My future goal for the district is to hopefully have a mental health clinic within each school in the future. I know this may sound far-fetched and very expensive because I'm sure it will be. However, that is what I envision and that is what I hope for, so that we are not only taking care of our students, but also their families and the school community as a whole. I am open to answering any questions or explaining anything in detail if you require so. Thank you.
Thank you. Tiffany Randall?
Hi, okay, I'm unmuted. Good afternoon, everyone. My name is Tiffany Randall. I too am a Ward 8 parent and the parent of Ramal Randall, who attends DC International in Ward 4. So I appreciate this opportunity to share my experience currently, as we have been soliciting assistance from his school specifically for his mental health due to his school staff actually mocking us after my son being robbed. So with that, my son middle school struggled deeply after being subjected to the mockery behavior by some of his school administrative staff, including a principal, assistant principal, and his science teacher. The impact of this behavior went beyond the classroom. It actually led my son to attempt to commit self-harm and contemplate suicide. I'm sorry. So in our most vulnerable moment, I sought out help from his school, expecting support, compassion, and accountability. Instead, my family actually encountered indifference. So despite informing the school of the severity of the situation, they were not proactive. I actually met with the principal and the executive director, Michael Roskin, on multiple occasions, and they neglected to do the minimum, follow policy, and even connect us to said services that's being required. The executive director unfortunately also labeled this incident as an unexpected mistake and an unacceptable mistake. However, my son is still faced with seeing all three of these Black individuals that emphasize supporting Black students. He's faced with seeing them every day. Their failure to adhere to the policies meant to protect students have intensified the trauma we've been enduring. This issue isn't just about my family. It highlights a larger systematic problem with ensuring that schools prioritize behavioral health and mental well-being as much as academics. When schools fail to act, the burden shifts to families who are often ill-equipped to handle such crises without proper support. I urge you to continue to advocate for stronger enforcement on mental health policies, increased oversight, and accountability when schools fall short. Mental health is just not a secondary issue. It is essential to our student success and safety. I'm here today because I don't want any other families to actually be left to struggle with such occurrences alone. Thank you for listening to my story and considering these vital changes we need to see.
Thank you, Ms. Randall. Morgan?
Thank you, Chairperson Henderson and members of the committee. My name is Morgan Denny, and I'm a lethality assessment program advocate working in DC Safe's crisis shelter. DC Safe provides 24/7 crisis intervention for domestic violence survivors in the district. This year, we served over 12,000 clients, including 388 individuals and families in our emergency shelter, many of which are mental health consumers. We know that domestic violence can have a lasting impact on a survivor's mental health, but existing mental health challenges can also make individuals more vulnerable to abuse and increase the frequency and severity of incidents from those who abuse. DC Safe aims to meet clients where they are when seeking help, and we work closely with our partners to ease access to support at a critical moment in survivors' lives. As such, we are proud to partner with the Department of Behavioral Health. Their work with our lethality assessment program and domestic violence system review team has shown their commitment to working proactively to assist the most at-risk survivors. We were pleased to be in discussion with DBH over the past year about strengthening our connection for survivors in shelter by working to bring mental and behavioral health support directly to DBH consumers in our shelter space. Meeting clients where they are best serves their ongoing needs and strengthens their connection to mental health supports, which is critical to long-term safety and healing. Survivors of domestic violence face unique circumstances which disrupt their lives significantly, including their mental and behavioral health care. We hope our work on services delivery at shelter is a start, but we know our shelter clients will continue to need support and help when their stay with us is over. To best serve our most vulnerable clients and the city as a whole, we hope to see DBH think creatively about how to reach consumers long-term, particularly how to bring services directly to those most in need outside of the crisis window to create sustained service delivery that meets consumers where they're at in the community. Finally, while DC Safe focuses on working with survivors directly, we want to acknowledge that there's a distinct lack of services for perpetrators of domestic violence in DC. As DC continues to do important work around diverting and minimizing criminal justice involvement for citizens, programs and outreach to divert and offer services in the community are increasingly common, often with a focus on behavioral health services. This movement, however, has not reached domestic violence offenders. Unfortunately, the only current pathways to targeted treatment for individuals perpetrating abuse is through the criminal or civil court system. This creates an undue burden on survivors who must engage these systems proactively, sometimes in cases where doing so might be explicitly dangerous for them. Additional and innovative services for those perpetrating abuse was a frequent theme of recent roundtable discussions for the domestic violence system review, particularly for chronically abusive individuals as a means of diversion and a tool for accountability. We think DBH would be a strong partner as we continue to explore ways to create a more dynamic system of services, supports, and accountability for offenders. We want to express our deep appreciation to the hard work of DBH. We have seen time again the dedication and thoughtfulness of both direct providers and leadership. We know that creating expanded and innovative services do not happen overnight. We look forward to seeing budget discussions that reflect the needs of their staff to provide the innovation and collaboration needed by our community. Thank you.
Thank you. Thank you to this panel of witnesses for your testimony. Ms. Randall, I want to express my deep disappointment in how school officials responded to your particular situation, and express that if you're still looking for some additional help or guidance on that, my office would be happy to connect you with the ombudsman for public education who might be able to help mediate the situation with the school if you're looking for further resolution there. But thank you for sharing your testimony. That was incredibly brave. Ms. Rodriguez and Ms. Andrews, thank you so much for being here and for your advocacy on behalf of young people. Ms. Andrews, you talked about wanting a mental health clinic in every school. Wouldn't we all? But I think we heard from some of the testimony from other folks trying to find enough clinicians. That seems to be our big challenge at the moment that we're going to be working on. But thank you so much for being here. Mr. Doyle, I wanted to ask, were you given a timeline in terms of when the regulations would be finalized for the ACT payments?
I mean, originally it was supposed to be December. It's still just delayed. So it's kind of a month-to-month process where we're trying to make sure we're, aware enough. But, now we're in a new month, staff are just proceeding as we are under the current structure as we're awaiting, further word. But there's no set transition date yet.
Okay. All right. I don't have any other further questions. Thank you all so much for being here, and please make sure you submit a copy of your testimony for the record. Thank you all. Okay, we're going to go to our next panel. Letty Williams, Hillary Kaser, Carla Portillo, Ayuka Miller Agami, Jordan Taylor, Messiah Williams. All right, I think we have quite a few students to round out this hearing here. Okay. All right. I think some thought the hearing would go longer, and so we're missing some folks, but that's okay. We're going to go through. All right. I see Carla. I see Letty. All right. Addison Blosser, Nyla Anderson, Abby Tucker, Kai Johnson. I know it's 2:30. If there had been some more folks here, we might have gotten to the 3:15. I know. All right, we'll stop there, and then we'll try again. All right, Ms. Williams.
Thank you. Good afternoon, Chair Henderson and members of the Committee on Health. Thank you for this opportunity. My name is Letty Williams, and I am the Teaching and Learning Officer here at the Edward C. Mazik Parent-Child Center, Incorporated. Our Advanced Institution of Early Learning has 2 locations in Wards 2 and 6. I have been in the early education field for nearly 50 years, both in the classroom as an early educator and now supporting our entire program in doing what is best for our children every day. I am here today to testify about the benefits of the Healthy Futures program to our children and families. Mazik has participated in the Healthy Futures Early Education Mental Health Consultation Program for 3 years. In that time, we have documented tremendous benefits to our workforce and the families we serve from the program. Our early educators have been able to attend workshops covering stress management and wellness. They have also been trained by Healthy Future consultations on the practice of conscious discipline, an adult first technique that empowers adults to model, teach, and live the lives and ideas we want children to acquire. I want to especially acknowledge the high quality support and partnership with our 4 Healthy Futures staff members that have been with us, Miss Angelica, Dr. Green, Dr. Dorsey, and Miss Siobhan. They embedded themselves into our classrooms and conducted observational research to help our teachers identify successful strategies to support classroom management. They have also joined early educators in sitting down with parents and working together to identify the appropriate mental health supports for their child. One of Mazik's greatest challenges has been establishing healthy classroom environments in a post-COVID era. When children returned to school, it was very chaotic in our classrooms, with many children lacking the social skills to function calmly. Even the best of the best teachers were experiencing difficulty. It was because of Healthy Futures observations, modeling, and training that we were able to keep our classrooms functioning. My only concern about Healthy Future is that the demand for mental health support in our program exceeds their caseload capacity that is being offered. Ms. Siobhan is here on Wednesdays, and Dr. Dorsey is here every Monday. Short of full in-house mental health consultants, the Healthy Futures program should be expanded so that all infants, toddlers, young children, and families and early educators can benefit from the behavioral health consultation. DBH should prioritize recruiting additional clinicians for the Healthy Future program to expand services and reduce clinician ratios so that each clinician can do more intensive work with each facility. I encourage council members to ask government witnesses to discuss what steps DBH has taken in the past year to retrain and recruit more Healthy Futures clinicians and to discuss what else is necessary to successfully grow the program. Thank you for your time. I am open for any questions.
Thank you. All right. I don't see Hillary. I do see Carla. Carla?
Hello, can everyone hear me okay?
Yes, we hear you.
Okay. Hello, Councilmember Henderson, and committee. My name is Carla Portillo. I am 22 years old and I am from Ward 1. I am a youth advocate and one of the lead organizers of United Leaders for Freedom. I have also obtained a bachelor's degree from Catholic University, majoring in architecture. I'm very passionate about my community and ensuring everyone's safety. No one deserves to feel unsafe or in danger. I will be addressing the prominent issue of gun violence and current events that have impacted our youth's mental health, which is all going on within our communities and within DC, as well as around all the United States. In 2023, the rate of gun-related deaths in DC was 124% higher than the overall rate of gun-related deaths in the US. Sorry. I have experienced many instances when I have been able to hear bullets so close to me that I knew I was in danger, and I then started to panic. Many drills throughout the years within the schools that I have attended, all in DC, because there might have been a possible shooter in our proximity and we had to stay safe. I experienced someone dying right in front of my apartment complex, one of my childhood friends, and the shock that I felt afterwards. It felt as if the panic and the anxiety always followed me. Not only within Ward 1, I know many young people and communities in DC also relate to my experiences and share the same fear that I do as well. My heart aches knowing that in our society, mass school shootings have become more of a reality every day. I constantly hear the news as the rate of school shootings are increasing, also due to our new administration, who is not prioritizing the safety of the children. Instead, they are putting them more at risk. According to CNN, during 2024, there were 83 incidents involving school shootings, while in 2022, which was considered one of the deadliest years with a total of 47 fatalities. Not to mention the way that our administration is pushing for the ostracization of immigrants and depriving our Black and Brown communities from being supported and treated with equity. The assumption that if someone speaks Spanish, they are automatically depicted as immigrants. This agenda of hate and encouragement of inclusion of immigrants is causing a normalized stereotype. Previously this month, there was a shooting at Antioch High School in Tennessee where Jocelyn Correa Escalante's life was taken, and other students also received wounds after being grazed by bullets. According to the Brady campaign, evidence shows that hate crimes are significantly underreported. A nationally represented survey from the Bureau of Justice revealed that from 2005 to 2019, there were approximately 250,000 hate crimes each year, over 20 times that of the FBI's totals reported. A majority of mass shootings are racially motivated, with the shooters forming a part of white supremacist groups or other extremist organizations. From 1966 to 2024, mass school shootings that are being done from K to 12 grades, 81% of shooters have been white. We must hold everyone at the same standard and demand justice for all the lives lost, and we must address the trauma created in our youth. We must mitigate this issue and restore the safety that schools once held. Uncertainty and fear should not be a factor in a 10-year-old school day, but the solution is to not live in fear. It is to reach a point and find a solution. We must make efforts to create workshops with students and with their parents to inform them and be able to create an enhanced personal connection with both administrations so we can unite in solidarity against these life-threatening occurrences.
Carla, if you could wrap up, you're about a minute over your time.
Okay, I'm sorry. So just to wrap up, I just wanted to say that it would be very beneficial to have designated protocols following after gun violence incidents in our communities and in our schools as well, because a lot of children after these occurrences suffer from PTSD, panic attacks, increased anxiety, and just fear to return to school in general. And I hope that DCPS can find a way to relocate the adequate resources for children to feel safe in schools. And yeah, we must protect our communities, and we must defend everyone who lives in fear and defend all the children. Thank you for your time. Thank you.
Thank you. Messiah?
Yes, I'm here. Good morning. Can everybody hear me?
Yes, I can hear you.
Okay. Good morning, Councilmember Henderson and members of the Committee on Health. And thank you for my opportunity to speak today. My name is Messiah Williams, and I'm a student at Bard Early College and High School. It's in Ward 8. And since the start of the school year, I've been a peer educator with the Young Women's Project, and it's just an organization that empowers the youth, and it leads to solve community problems. And one key issue I want to highlight is the need for better mental health support in schools. I just feel like mental health resources are important for students to succeed, but I also feel like many schools don't have the proper support. Me personally, I've felt the effects of like stress and anxiety, especially when I'm trying to balance my schoolwork and with the tight deadlines. It can be extremely overwhelming, and it leads to burnout or exhaustion. I've also seen I'm not the only kid that struggles from this. Many kids in my school, and it also my friends, it affects them too. But I also noticed something that's similar between us is that we don't know where to go for help, or we don't feel comfortable going to certain people for help. And I feel like that's a problem, especially in my school, because I feel like we should have that. And though my school has started some mental health activities, which include morning announcements with inspirational messages, I just feel like it's not deep enough, and it it's not helping, and there's also not enough access to professional support or any ongoing mental health programs. Even though we have counselors, most students don't know where to go to find their counselor or don't feel comfortable going to their counselor. At the Young Women's Project, I work as a mental health advocate, and we teach students about like their stress and other like relationships, and we can share simple tools like breathing techniques. And I just feel like that's important because like the topics we're learning at the Young Women's Project are things that should be covered in our health classes, but they aren't. And it helps students that don't have the skills to deal with stress kind of build them up. And the goals for that is to make mental health issues less stigmatized. And I feel like a way to start that is through peer education, because peer education is important and it's more helpful because more students are more likely to open up to each other than to adults. But mental health isn't something that we talk about enough in school, and it's one of the main things that affect our students. Like many feel lost and they don't know how to deal with their emotions. But I feel like if we had more mental health education and access to resources, we could help them understand how to handle their stress and anxiety better. Like one thing in my school personally is we have assemblies, but those assemblies don't focus on the real issue in our school, which is mental health, and it more likely focuses on a school spirit that isn't really even there because the mental health problem in our school is that bad. And I feel like to help DCPS students, we need to teach mental health in health classes instead of only teaching sexual health in health classes, because that's the main thing that we're learning. We need more wellness days or more events to show and tell students that we are there for them and that we do care. And something else, going back to peer education, is that peer-led groups could also help students learn how to cope with stress, because like I said before, students do feel more comfortable going to students than they do adults. And I think one way to implement that is that the Department of Behavioral Health can provide resources with and staff. They can
All
also
right.
provide resources.
Ms. Williams,
And yes,
you're about a minute over your time if you want to summarize.
I'm almost done. And I feel like that would give students the support that they need. And that was it. Thank you for your time.
Thank you. Ms. Tucker.
Good afternoon, Chair Henderson and members of the Committee on Health. Thank you for this opportunity to testify today. My name is Abigail Tucker, and I'm a Ward 3 resident. I'm also a junior at Basis DC, and I'm a youth advocate at the Young Women's Project, working on the mental health team. The Young Women's Project is a DC nonprofit that promotes leadership in youth so they can make an impact in their community. Today, I would like to talk to you about the lack of mental health support and resources in schools, and to request that the DC Council address this issue by allocating funds for mental health services in DC public and charter schools. Mental health and wellness is an important issue to me. As I am sure you can all remember from your days as teenagers, being a high school student can be a stressful experience. Between academic pressures, social anxieties, the college application process, and the uncertainty about the future, it's very easy to feel overwhelmed and to struggle with mental health. In fact, many people I know suffer from mental health issues, and I want to be able to help them and others in my community grappling with the same concerns. What's become clear to me, though, through this program is that many students at different schools don't know of any resources to help them manage their stress. At YWP, we learn about different mental health issues like stress, sleep, and relationships, and how to cope in these areas. We then share this information with our peers via emails and classroom presentations. The information we offer is important because it informs my peers about ways to improve their mental health, and it gives them resources they can use. Some students don't learn this information in their health class, meaning that this program may be their sole resource for acquiring mental health knowledge. For example, we learn that different breathing methods, such as the box method, can help calm
Abby, you're going in and out.
a stress in your body. Perfect example. Sorry, can you hear me now?
Yep, we hear you now.
My school is a perfect example of an institution that both offers programs but could also benefit from additional resources. Students are fortunate in that the mental health counselor comes to each class at the beginning of the school year to introduce herself and give a presentation about mental health. There's also a monthly newsletter with articles, resources, and information about taking care of your mental health. But most, if not all, students don't see these posts because their parents are the ones receiving this information from an app. According to a survey done by the Young Women's Project, 42% of survey respondents said they have not received resources from mental health counselors in the past 3 months, and 46% of survey respondents don't know the name of their counselor. My school has roughly 650 students between grades 5 and 12, but only 1 mental health counselor and 2 staff members designated to student support services. If more funds were allocated for mental health services in schools, then more students would have access to resources that would help them with their mental health struggles and reduce the impact of mental health illness, which is why I encourage you to please consider allocating more funds for mental health services in DCPS and charter schools. Thank you for your time and consideration.
Thank you. Hillary. Hang on, guys. Hillary is giving her testimony in person. She's coming up to the table now. Either one. You just have to hit the button in front of you.
I hope you can hear me okay.
Yes.
With this mask, I have to really safeguard my health, even here with you at the Committee on Health. Thank you so much. I'm really grateful for the opportunity to testify live. And you probably know why I'm here today. With everything that we have going on and incredible challenges, hoarding disorder remains a severe unmet need and service gap in behavioral health in Washington, D.C. With estimates of over 40,000 residents who live with this condition, and that estimate comes from a Washington Post article whose title I can't pull up, but there's a Washington Post article about hoarding. That's where that number comes from. Anybody who goes past people's doors know the home health responder, the home health aide, the cable guy, the first responder. I'm just looking to see if there's a clock. Oh, thank you. Okay, great, thank you. And over 12 years ago, the American Psychiatric Association clinically defined this diagnosis as hoarding disorder. It's fundamentally a behavioral health condition, yet our city's Department of Behavioral Health, who, according to their answers to your questions, field calls to the Access Helpline, which, thank you for your questions. They say many calls are related to hoarding disorder, but DBH basically, when they field those calls, refer them out to Adult Protective Services, which is part of the Department of Aging and Community Living. And Adult Protective Services and Department of Aging and Community Living are not behavioral health care providers. Yes, this problem is an interagency problem and requires an interagency approach. I've already touched on the implications for fire and emergency medical services. It's definitely a public safety issue, but that's in an extreme emergency case. Adult Protective Services put people under guardianship and into long-term care through no choice of that person except for the fact that we are not providing early behavioral health care. Research says, and these young women are really impressive, and a lot, you see the slides. Thank you very much for sharing the slides. These are, it says a hoarding rating scale. It should never get to this point, especially if it presents in youth. And we have these wonderful young people talking today, and your committee wrote an amazing report last year, which I really commend you for, that there's a URL for that. If you go to tinyurl.com/DC-COH 2023 hoarding disorder memo. How has DBH responded to your report? And I see my time is up. Thank you very much.
Thank you. Thank you to this panel of witnesses for your testimony. Ms. Kaser, thank you for your continued advocacy on this particular issue. my staff is just showing me, so we do pre-hearing questions to the agencies and we get the responses back. And earlier today, there was a conversation about the crisis response team that goes out to address a variety of issues. I think we asked what are the top 5 reasons as to why someone would call CRT, and within that top 5 is hoarding, which was a surprise because that's often not something that is discussed, right? It's often around some sort of other type of active behavioral concern where someone might be suicidal or otherwise. And so thank you for your continued advocacy. We'll certainly ask some follow-up questions there.
Early intervention, it should never get to a crisis stage. Harm reduction, risk mitigation, a trauma-informed, low skill, but specialized, even a peer response person who is able to gain the trust of the resident to get inside their home and can work from a behavioral health care point of view, not a non-behavioral health intervention that addresses symptoms but not underlying behavior, to make 3-foot wide paths of egress, for example, harm reduction.
Yep. And I mean, also, I think the idea that if somebody calls the Access Helpline for help, to just refer them to the Department of Aging isn't actually solving the issue.
Sweeping it under the rug.
It's
not an easy fix, but we have to shine light into the prayer closet. Thank you for your attention.
Ms. Williams, thank you so much for testifying about Healthy Futures. We've heard a number of early childhood educators who've talked about how important that is. And, one of the things I wrote, what you said in your testimony, that demand exceeds the caseload capacity. And so that's something we're going to keep top of mind and ask some questions about that, because we're sort of talking about hoarding, but talking about this behavioral issues in early childhood, right? Early intervention can be key, and helping to provide coping mechanisms or get treatment for a young person if they might need it prior to them entering school, to help them with regards to that. Ms. Portillo, thank you for testifying on behalf of Black Swan. I think agree. This question around designated protocols after a gun violence incident occurs and how we can provide some additional supports. I know there are a bit more protocols in place if there is a incident that occurs like at a school or immediately around it, but not necessarily in the surrounding community, which is also a source of trauma as well. So we'll ask some questions there. Ms. Tucker, I wanted to ask, it was something that you talked about. You said that there is a newsletter that goes out, but that the newsletter goes to parents and not to students?
Yeah, there's an app called Parent Square, which my school uses, and only parents are added to that app. And on that app, they post like a newsletter to all parents that gives them mental health information. But since only parents are on that app, students are not receiving that information.
Right. So when you guys survey your classmates to say, hey, how have you received any resources lately? I could see the disconnect where the student is saying no, but the school is saying, but we sent the information. And so this is something I brought up earlier around, we had a conversation about school-based mental health and really needing to sort of bifurcate how we deliver this between age group of children, right? So for elementary school, elementary age young people, parents being involved in that process is probably more hands-on, but when you get to high school, there might be something going on that one of your classmates might want to talk to their parents about just yet, or that their parents may not know about. And if all the resources are going to parents and not to actual students, I could see where there's an issue. So we'll do some follow-up there, but thank you for being here and providing testimony. All right, we're going to go to our next panel of witnesses. We're going to see what we got. All right, Sanai Brown, Nair Artununian, apologies, Masa Jakovlich, Ileana Fedoro, Hillary Reyes Rubio, Destiny Oates, Phoenix Sims, Angelin Mata, Ayana Fado, Ali Rizvi, Sojin Kim, Caitlin Kilgore, and Sanaya Evans.
Foster youth also experience a high amount of hoarding issues because they never know when they're going to get something again. Thank you so much.
Thank you. Okay, let's see who we got. All of those. All right. Okay, we got a few. All right, I see Nair.
Hello.
Hi. All right.
Hi.
3
I'm good.
minutes.
How are you?
When you're
Okay.
ready.
Well, good morning, Chair Henderson and members of the Committee on Health. I'd like to start by thanking you for having me and my peers on this day. My name is Nara Haratunyan. I am a sophomore at School Without Walls. I'm the vice president of Penguin Minds Matter, the mental health club of our school. I'm also a youth advocate from the Young Women's Project, so YWP. Today, I am here as a peer youth educator to testify about the importance of mental health in schools. Since grade 6, I have seen many of my peers struggle, and it only gets worse as we get older. Stress, anxiety, social anxiety, insomnia, depression, self-harm, and even suicidal thoughts are a heavy load of issues for adolescents. I'm no exception to these struggles. Neither are my peers at School Without Walls. My school puts a lot of effort into helping students' mental health. In my health class, we had a 1 unit focused on mental health. We learned about impacts of stress and toxic stress. However, we didn't talk about how to manage said stress or time or sleep or relationships. As a YWP mental health advocate, I learned about mental health related topics and shared them with my peers. I introduced them to stress management techniques, including deep breathing or meditation. I also make presentations about healthy and unhealthy relationships. At WYP, we conducted a survey with 739 participants across multiple high schools in DC. 71% of survey respondents received 1 hour or less of mental health and wellness instruction. The majority, 89% of survey respondents, didn't know the name of their mental health counselor. Half of the respondents rarely or never received any mental health or wellness support offered by teachers, and only 5% regularly received it. With no mental health assessments or check-ins, it is left to students to seek help. So we end up depending on each other for support. While peer help is valuable, we deserve support at schools. In our survey, students showed that a high interest in art therapy, 42%, followed by individual talk therapy, 29%, and yoga and stretching, 24%. These activities could be made available either during health class or as an extracurricular activity. Yet they should not be squeezed into advisory as regularly attempted. When an advisory period is replaced with other activities, students disengage and their stress level increase. It is also important for counselors to create in-person meeting opportunities with students. We would benefit highly from building relationships with counselors similarly to how we relate to our teachers. Admittedly, our schools are simply understaffed, leaving counselors with limited resources. Yet the mental health crisis in our high school demands immediate action. With your support and the suggested changes, we can create an environment where students don't just survive, but thrive. Thank you very much for your considerations on this crucial matter.
Thank you. Massa?
Oh, wait. Give me a second. Wait 1 second, 1 second.
No problem.
Having some camera issues. Is it okay? I don't know how to flip my camera. Oh, I'm upside down. Great, lovely. Is it okay if I just leave it like this? I don't know how to.
I mean, go ahead. We're listening to you. We don't. That's whatever you're saying is more important.
Okay, thank you. Okay, good morning, Chair Henderson and members on the committee.
on Health. Thank you for the opportunity to testify today. My name is Masha Yakovlevich, and I live and attend school in Ward 3. I'm a sophomore at Jackson Reed High School. Since I was 12, I've aspired to become a psychologist to understand people's thoughts and feelings better. I plan to study psychology and am currently enrolled in advanced placement psychology course in Biomed Academy at school. I joined the Youth Justice Program because students need greater access to mental health services to know exactly where to turn to when facing an internal conflict. Mental health and wellness are important issues for me because only when adolescents achieve peace with conflicts in their minds and learn to overcome mental challenges in a healthy way can they succeed in school and later in life. I feel as if there are many obstacles when it comes to entering a building every day full of adolescents who are the same age as me and also going through rapid mental and physical development. On top of that, the education system with constant testing demands you always do your best. By the end of the school day, I feel tired and overstimulated due to the workload and peer judgment from classmates. I also watch my friends being peer pressured into things and asking questions like, do you think they dislike me for what I did? In addition, there are social media platforms where everyone always tries to present their best selves to ensure their peers think highly of them. Jackson Reed High School is like a small town with over 2,100 students. However, the student website does not contain a direct link to mental health services, and students don't know who to contact to receive them. For example, the academic counselors serve too many students. Since the beginning of the year, I haven't been able to reach my counselor even to get my mandatory yearly meeting. Every week, as a mental health advocate, I learn about new mental health issues that affect adolescents my age, such as social anxiety, creating better sleep habits, toxic relationship, and time management. Then I discover how to work through these obstacles constructively. I use the information and resources I've gathered to create PowerPoint presentations or group chat messages that spread awareness about how to handle such conflicts and challenges. Our jobs as advocates is to promote good mental wellness among students at school, whether they are seeking that information or not. DCPS schools have neglected the growing need for more mental health services for students. Schools can't demand that students take on a huge workload and overlook the mental toll that this may have on students. We have school counselors, but scheduling meetings with them often takes days or weeks. When students experience mental breakdowns and feel unable to cope at school, they often have no one to turn to. If the school psychologist is busy, they might tell them to go back to class. 2 weeks ago, I faced a mental issue that made me feel like I had reached my breaking point and couldn't bear standing at school for the rest of the day. The first thought that should have come to my mind was to talk to a teacher or a school counselor, but instead I called my mom and told her I needed to leave. When students experience a problem at school, often social, they tend to leave because the environment feels toxic. Schools should create safe spaces where students can go whether they feel stressed or need someone to talk to. The 2024 to 2025 mental health survey distributed to all DCPS schools state that 89% of DCPS students claim that they don't know the name of their mental health counselor, and 68% claim that they have never received mental health support in their school. Many students strive to make their students have a higher GPA by continuing to discuss different education topics and how to learn more in a shorter period, having good time management, and challenging themselves. Maybe it never came to mind that students might not have a high GPA because their mental health is unwell or distressed. Let's take a moment to question why school altercations happen. They occur when two students are overwhelmed with anger and feel that physical violence is the only way to express themselves. That conflict that resulted in bruises and school suspensions could have been resolved if those two students had a chance to sit down with a trusted adult and discuss their issues. My school is well prepared for damage control after a physical fight, but not at all equipped to prevent it in the first place. I have many recommendations that I can name off the top of my head, but due to the circumstance, I will only state one. It would be great to have a room in DCPS schools where students who are having a really tough day can go and spend an hour in thought instead of leaving the school as I did. A person could be available to talk to in the room, or if preferred, you could just sit by yourself. The room might include items like fidgets, coloring books, and games. Thank you for your time and attention, and I hope you will consider this suggestion.
Thank you. Ayana?
Hello. um, Good morning, council members. I'm Ayana Fadero, a Ward 5 resident and junior at School Without Walls High School. Since 2023, I've advocated for mental health and youth justice with the Young Women's Project. We appreciate your support for the DBH school-based peer-to-peer program. Today, I urge the council to increase funding for accessible mental health resources in schools. Mental health and wellness are important to me because I've seen how stress affects students like me. Balancing schoolwork and expectations often causes burnout. Personally, I've had sleepless nights and trouble focusing in class due to stress. According to a recent survey, 40% of students reported struggling to fall asleep or waking up during the night, while 22% described their sleep patterns as chaotic, often staying up late for schoolwork and getting 6 or fewer hours of sleep. Some of my friends don't know where to turn for help. At school, the mental health staff project, I've learned how to advocate for better mental health support and share resources with others. My friend and I are also working on a project to create a monthly wellness newsletter for schools. This newsletter will provide students with resources, highlight available services, and encourage them to take action to support their mental health. We plan to collaborate with school counselors to include tips on managing stress, improving sleep habits, and accessing mental health support. The newsletter will be distributed in both digital and print formats, ensuring accessibility for all students, and we aim to expand it to other schools in the district over time. While my school attempts to address mental health, there is much to improve. Teachers see stress but may not provide adequate support. For instance, students needing help are referred to counselors, but follow-up is lacking. After-school programs like mindfulness workshops are poorly advertised, leaving students unsupported. A recent survey indicates gaps in resources. 71% receive minimal instruction on mental health, and 89% don't know their school's mental health counselor. Students want more one-on-one check-ins and regular talks, emphasizing the need for accessible and integrated services. One major problem is school mental health teams' lack of adequate staffing. Counselors have a lot of responsibilities and often don't have the time to do mental health counseling with students, which is what many students really need. More than 30% of youth surveyed by Young Women's Project said that they are sad and depressed, so much so that they stopped doing regular activities. This counselor shortage means students can't access timely support when they need it most. The COVID-19 pandemic worsened this issue by increasing student anxiety and depression while also stretching school resources even thinner. The Department of Behavioral Health plays a critical role in addressing this crisis, but is not allocated enough funding to meet the growing demand for mental health services in schools. I recommend hiring more mental health professionals in schools to meet the ideal student-to-counselor ratio, including social workers and psychologists. Funds should train teachers to recognize and support students with mental health challenges. Schools must also conduct workshops to educate students about mental health resources. Monthly wellness newsletters can help keep students informed. Mandatory check-ins and anonymous help-seeking methods should be established. The council can aid these efforts by increasing DBH's budget for school-based mental health programs. Immediate action is essential for student success. I urge you to prioritize funding for mental health support in schools to ensure every student has the resources to thrive. Thank you for your time and attention to this critical issue. I hope you'll consider these recommendations and prioritize funding for mental health support in schools. Together, we can ensure every student has the resources they need to thrive.
Thank you. Hillary?
Good morning, good afternoon. Can you guys hear me?
Yes.
Okay. The lighting is a bit off, but I'm gonna just. Good afternoon, Councilmember Henderson and the Committee of Health. Thank you for the opportunity to testify today. My name is Hillary Reyes Rubio. I'm a resident of Ward 7, and I am currently a junior at DC International School. I am a member of HOSA and have been a peer educator with the Young Women's Project since October 2022. Today, I'd like to touch on the lack of mental health education in schools. Mental health and wellness is a crucial concern for me because as students, we face considerable stress from academics, extracurricular activities, and starting to look at colleges. With the current political climate, it's even more important for us to understand how to take care of our mental well-being because we grapple with the uncertainty of our future and what that looks like and if we will even have one. And my own experience with stress and anxiety from academic workload and demands of extracurricular activities and the need to spend time with friends often leads me to feeling overwhelmed. And more than 35% of youth survey takers in YWUP's mental health and wellness survey said that the stress in their lives was overwhelming. Finding time for everything can result in neglecting your responsibilities, and the lack of mental health information and access to resources leads many people to overlook essential coping strategies, finding ways to cope in ways that are harmful to them physically. At my schools, there's pros and cons in accessing mental health support. On the positive side, we do have wellness center dedicated to providing students a space to relax and a space for students to go when they feel overwhelmed, but it's not always open. And some of the staff, when students aren't in there, kick them out because there's because the room's busy and they need to be in class knowing that they need a time to think and to gather their thoughts instead of leaving school. And on the negative side, while my school does have counselors, the students don't have access to them and don't have access to the information they need to talk to the counselors. And I'm a junior at my school now, and I've been at that school since middle school, since the 6th grade. And not once has a counselor reached out to me to see how I was doing. It's the student's job to reach out to them. And it's hard when you don't know. Sorry.
Okay, Hillary, take your time.
It's hard when you don't have the information you need. And when you do, they don't respond to you.
Hillary, do you need some time?
Yes.
Okay. All right. We're going to go on to one of your classmates. I think I see Sinai Brown.
Hi.
Okay. Hi.
Good afternoon, committee. Thank you for providing me with the opportunity to testify today. My name is Sine Brown, and I live in Ward 7 of the district. I'm a sophomore at School Without Walls High School, and I'm a member of our school's Black Student Union and Penguin Minds Matter Club, as well as a varsity cheerleader. As a student with plans for a psychology-focused higher education and career path, I strive to seize opportunities that will educate me more on the topic and guide me on how to make a positive impact in my community. This being said, I was naturally drawn to the Young Women's Project, or YWP, an organization that builds leadership skills in students and equips them with vital information to serve their communities. Many students have reported about lack of proper sexual or mental health education, and YWP works with the youth to combat these issues in a variety of ways. The purpose of my testimony is to underscore the urgently relevant mission of YWP and request that the organization continue to receive your support. One's mental state influences every aspect of their life, and it's often not addressed with the seriousness it deserves. So I find it important that there's adequate education and discussion around the topic to achieve healthier individuals and thus a healthier society. Personally, the stress of my academic workload has resulted in me facing burnout and depressive states. Consequently, I felt drained and unmotivated, like I was going through the motions without any real drive, and I wasn't able to pour enough energy as I would have wanted into my relationships and personal life, which dulled some of my most important connections. As a mental health advocate, I've taken and distributed surveys about mental health, which has helped me learn about how to reach out to my community to work toward a common goal. In response to the increasing mental health needs of students at Walls, the school has prepared mindfulness moments and/or presentations concerning mental health weekly during advisory. The teacher's response to this issue varies per teacher. Overall, WALS is very academically rigorous, and teachers follow the curriculum and often give out heavy assignments in line with it. Although this is to be expected, it's very taxing on teenage students' mental state, and some teachers do not permit study periods or other sessions of mindfulness to try and help. Penguin Minds Matter is a mental health program that takes place bi-weekly before school, and confidential surveys are distributed periodically throughout the year during advisory to collect information on student stress and trauma. In a recent YWP survey across a variety of schools, nearly half of the respondents reported their experienced stress to be too much or consistently high. And these high levels of stress in DC high schoolers causes them to feel overwhelmed and thus not live a well-rounded, satisfactory life. They may feel helpless and unmotivated, which affects their performance in academic and personal aspects of life. One system that would contribute to solving this issue is youth development. Organizations like YWP should reach out to the teenage youth via workshops and meetings to build knowledge and awareness on key issues that shape life well-being. They should be especially mindful to underserved communities that don't already have resources like these in place. Students will benefit by learning more about important topics like health, conflict resolution, community involvement, employment, etc., and becoming more comfortable sharing these ideas out. This agency and DC Council should provide adequate funding and resources to these types of organizations to ensure they can carry out their objectives effectively. I hope these ideas stick with you when planning for community improvements. Thank you so much for your time and attention.
Thank you. All right. And Ms. Evans, who's here in person.
Good afternoon, Chairwoman Henderson and members of the Committee on Health. Thank you so much for the opportunity to speak to you all today. My name is Sanat Evans. I'm 16 and live in Ward 7. I'm currently in 11th grade and attend Washington Land Public Charter School. At school, I'm the leader of the Red Hearts Community Service Club and I'm also a student ambassador. Upon graduation, I plan to attend college studying nursing to become a pediatric psychiatric nurse practitioner. This year, I decided to join the Young Women's Project as a mental health leader, specifically because of my interest in mental health. Today, I'm testifying before you all to talk about mental health support in schools. This issue is particularly important to me because out of most people, teens in general go through a great deal of stress during this time in their lives. A lot of my peers deal with stress in a variety of areas, such as academic, social, or even anxiety-related stress. Because of these issues, it is very important to me to be able to advocate for myself and other teens who are going through some of these things. During the Youth Women's Project sessions on Mondays, we do exercises around sharing and presenting on different topics such as trauma, stress, and ways to calm your stress. Another thing we do is send out messages on topic we learned about. We send them to a group chat we make every week. We do this to educate peers around us on things we learned to make sure they know about mental health related topics. We also educate our peers using classroom presentations. These presentations can be shared at a club, during lunch, or even in class. We create these presentations specifically about mental health because some of these topics are not taught in schools. All the projects that we do in our program are important, especially to teens because some teens our age don't even know that they're struggling with a mental health issue until these presentations and messages are received. Some students would rather hear this type of information from students their own age rather than a teacher because they are more comfortable and realize that other people their age are going through the same thing. Results from our recent survey show that there's clearly not enough mental health support within schools. Before reaching the high school level, no one warned me that high school would be so stressful. Clearly, other students agree based on the survey. When asked the question, how often do you worry about the outcome of your grades? 30% of students said always, 27% said often, and 25% said sometimes. That means 82% of students said they're often, always, or sometimes worried about their grades. That number should never be that high. When students were asked about their sleeping patterns this month, 40% said that falling and staying asleep was challenging. However, 22% said that their sleep schedule was chaotic. Staying up late to do schoolwork, which results in getting 6 hours or less of sleep, is very unhealthy. I can shamefully say that I am one of those people. I usually stay up to 11 or 12 sometimes doing homework. Then I have to wake up at 5:45 to get to school. In the mornings, I'm also very tired, and it makes me tired at the end of the day, making an endless cycle so many high school students are stuck in. There are so many ways this problem can be solved, but today I will just name one. Students should have more time during the day to finish their homework, whether it's time during the end of class or in a study hall. which not all students have access to. This will allow students to be able to spend less time rushing to do their homework at 11 p.m. because they got home late from sports and doing what they need to get done. So by the time the student gets home, they can eat dinner, shower, and get to bed at a decent time. One positive classroom strategy that schools can use is that, one example, my math teacher takes notes during the first part of the class. Then, after, we go straight to our homework. She grades the classwork based on if we are paying attention on class during the notes. This method helps me so much because by the time I get home, I only have one assignment to do for homework, allowing me to get a better night's sleep. Thank you so much for your time and being able to listen to my recommendations today.
Thank you. And thank you to this panel of witnesses. We lost some folks, but I know you guys are busy with class. And so, but we appreciate you all taking the time. Ms. Evans, I wanted to ask, there are often times where we've heard, oh, hang on. You're at a charter school, correct?
Yes.
Okay, all right. So that is not a question for you. It is a question for Ms. Brown, who left, looking for another DCPS student. That is okay. What would you say is probably the biggest suggestion in terms of how we can improve your peers and classmates knowing, what supports or services are available to them?
I think being able to have a time during the day where students can at least be able to do their work, because at my school specifically, not everybody is able to have a study hall, and I can see them around the day like struggling and being stressed and having to take all the work home and staying up super late to finish the work, and then the next day it's just like a endless cycle, like I said.
Okay, all right. Well, I don't have any further questions. Ms. Reyes Rubio, I hope you're okay. And again, if you need some additional support, I hope that you can reach out to a trusted adult around you. But thank you so much. We're going to go to our final group. All right. Robert Paris, Rohia DeCuro, David Armando, Jonathan Jeffcoat, Sophia, Amarutu Kamara, Amanita Sissoko, Janice Speaks McNeil, Arsima Giarima, and Nadia Goldmaritz. All right, I see Robert. Go ahead, Robert.
Good afternoon, Charlie Henderson and members of the Committee of Health. I appreciate the chance of letting me testify today. My name is Robert Perez, and I'm a Ward 8 resident. I am a junior and I attend Coolidge Senior High School in Washington, D.C. I currently play basketball as a hobby. I also work in my family shop while trying to maintain being a student athlete. During the summer, I will be attending a summer high school program at Georgetown University because it will provide me with the feeling of being in a college atmosphere and already having a feeling of what it's like being in college. I have been a mental health advocate with the Young Women's Project since last fall. The YWP is an organization that gives the youth an example to help solve community problems. I thank you for supporting this program. And one issue that I am dealing with is that schools are not given the right for students to speak and to support their mental health. This issue is important to me because as a teenager, I struggled on my own with my mental health and sometimes feel like I can't talk about certain things. I know I'm not the only one. There are many kids or even younger my age going through the same thing. As a mental health advocate, I care about this because a lot of people have been through difficult experience growing up. That kind of trauma doesn't go that kind of trauma doesn't just goes away. It builds up. And when people don't have the support they need, it can lead them to hurting themselves or even considering suicide. That's why it's important to make sure young people have a safe place to talk about their mental problems and get help if they need it. At YWP, I work as a mental health advocate. We learn about mental health and we share the information with our peers through group chats, class presentations, and other resources. This information I share is important because sometimes people are struggling but don't feel comfortable talking about it. If they aren't ready to open up, they can use these resources that I provide them to find ways to they can use these resources I provide to find ways to cope and manage their stress. The Young Women's Project has made a big impact by giving students a chance to talk to people their own age instead of just adults, which makes it easier to open up. I don't think schools really understand the importance of students' mental health. They focus on what they want us to learn, but don't check up on like how we actually doing. They don't prepare us for mental and emotional challenges we'll face after high school. Some teachers might check in on us if they notice something is wrong, but a lot of them don't. Instead of trying to understand what we're going through, they just pile on more work, adding even more pressure. I believe schools should have mental health surveys and meetings to teach students how to manage stress. There aren't enough programs dedicated to supporting students' mental health. Personally, I've learned that doing something relaxing or finding an outlet helps take my mind off of things. But all students know how to do that, and schools don't do enough to help. Many schools don't even often offer mental health classes and counselors that always provide the support that we need. The real issue is that we spend all day learning about information we may never use in the real life. But mental health is something we deal with every day. DCPS needs to start polarizing. Hold on. For oh shit. Needs to start prizing students' mental health instead of just loading us with work. If students aren't okay mentally, how can they be expecting to be successful in schools? One situation I have is that once a week, every grade level should have a meeting and have like a mental checkup or break up to 15 to 30 minutes. This will help high school students or even middle school or younger grade levels by giving them time to catch up and to take a break if they need to. I feel like they should already know how to handle students' mental health instead of just handing out work and expecting them to come back to school every day with their mental problems or problems at home. But I do thank you for having me and letting me get the chance to share this with you. And I hope you take these recommendations into consideration.
Thank you. Rokia?
Hello, can you hear me and see me?
Yes.
Okay. Hello, good afternoon, Chair Henderson and members of the Committee on Health. Thank you for the opportunity to testify today. My name is Rakia Ducour and I'm 16 years old and I have went to school in Ward 4 for my whole life. I'm a student at DC International School and I am also a member of HOSA, which stands for Health Occupations Students of America, which is a national-wide club for high school students and college students interested in healthcare. I'm also in Yearbook, Poetry Club, and Student Government. I will be attending college in the fall of 2027, and I aspire to major in nursing. I have been a peer educator with the Young Women's Project since August of 2024, and the Young Women's Project is an organization that builds the leadership of youth to solve community problems and that is why it caught my interest. Excuse me. We really appreciate your support for this program. And one issue that I'm dealing with is the lack of mental health encouragement and education in schools. This issue is important to me because this generation has suffered through the most obvious traumas that the previous generations choose to ignore about themselves. Plenty of people in my generation, including myself, have been impacted by depression, anxiety, and PTSD. The workloads in school are overwhelming. People feel like they have to do everything and be the top of their class and still live a teenage life, especially with trying to go to college. And I can speak from experience from the pressure of wanting to be successful and to make our parents proud and to make ourselves proud. That youth usually turn to temporary solutions that don't really help but hurt them instead. And for example, like social media, substance abuse, and toxic relationships that push and don't help solve youth's mental health. At the Young Women's Project, I work as a mental health advocate, and we learned about mental health issues like stress, sleep, and relationships and then we share this information with our peers through text messages and classroom presentations. The information that we share is important because a lot of it is not covered in health class. Students need quick solutions like breathing, for example, to respond to the high levels of stress that they are dealing with. Students don't understand that stress is normal, and this project helps normalize stress and mental health issues so they are not stigmatized as much. Peer education is important because youth would rather hear it from peers who understand them than people who don't and who are experiencing it. Schools aren't really understanding or deal with mental health mental health needs. School is a significant cause for stress for most students in my generation, because how do schools expect to distribute endless information and assignments in our brain for years and then not really mention a lot of mental health, and to go on with their lives when we're being pressured consistently from internal and external forces? We don't really get any advice to manage stress um, in our mental health, especially towards school. We have school counselors, but in my school, you have to approach the counselor, of course. And there's not a lot of mental health support coming from them unless you're a regular student or you go to them yourself. Because I have gone through school thinking that seeing my counselor is for people who have more severe mental health issues than me, and I don't need them. And that can be very harmful because there would be so many times where I would struggle with my mental health, but I didn't reach out because I thought my problems were very minimal. But I do have amazing counselors. I just feel like interaction with all different types of students can really help youth like me open up to somebody about their mental health and get success towards that.
Thank
And
you.
oh, sorry. Thank you.
No, it's okay. Be a little over your time. We let you go a little bit longer, but thank you. David? David, you're on mute. David, are you speaking right now? Okay, we can't hear you. All right, David, while you work out the sound issues, we're going to go to the next person and we'll come back. All right, Amanita?
Hi, can you hear me?
Yes.
Okay. Good morning, council members. Thank you for this opportunity to testify. My name is Aminata Sissoko, and I'm a Ward 4 DC resident. I am a junior at School Without Walls High School. I am a youth advocate with the Young Women's Project, a nonprofit that develops youth leaders and works to increase awareness and understanding of mental health in schools around DC. We appreciate your support for this program and are glad to be a part of the DBA school-based peer-to-peer program. I am testifying about the lack of mental health awareness in schools around DC. Mental health is important to me because knowing how to help yourself and where to get help is crucial. Attending a school with a heavy workload can take a tremendous toll on your mental health, and being able to balance school and your personal life can contribute a lot to your mental health wellness. The amount of stress school brings to students, including myself, is harmful to our well-being. It can make you lose focus, feel overstimulated, or make you feel like you have no free time. More than 35% of youth survey takers in YWP's Mental Health and Wellness Survey said that stress in their lives was overwhelming. This is an issue that has impacted my friends and I as we face similar mental health issues. Majority of the time, it is from the amount of work we are given in school and how overwhelming it is. 58% of students surveyed by YWP say that they always or often worry about their grades. Accessing mental health resources has been easier as our mental health team takes more effort to be known to students around the school. As a mental advocate, I'm currently working on a mental health newsletter that will be published in my school and schools around DC. It would include mental health resources, information about the mental health team, and provide self-care strategies and additional resources for students to use at home. With the newsletter, I am hoping to reach a larger population and actually have people be engaged with it and learn more about the resources in their school and the importance of mental health overall. At my school, there has been a better response to raising mental health awareness, and the mental health team has actually been making themselves known. We have a mental health club that meets twice a month. They began doing more outreach, posting flyers around the school, and bringing up mental health clubs during the morning announcements. Teachers don't really direct the issue of the lack of mental health awareness in schools. They mainly just bring up the topic of how much stress is put on our students and how we need to take care of ourselves more. To solve this issue, I suggest the mental health team do more outreach, such as visiting classes to introduce themselves, especially to the new students of the school. This can be doing class-to-class visits, make it a video that can be shared around the school, or take a time out of advisory to do activities around the school that everyone can participate in and learn more about the mental health and where to get help to address their needs. Implementing these solutions will help ensure that students know where to get mental health support and feel encouraged to seek help when needed. Prioritizing mental health in school is necessary for supporting students' well-being and academic achievement. Thank you so much for taking the time to listen, and I hope you take my solutions into consideration. Thank you.
Thank you. Um, all right. David did not come back. Okay, so he must still be having some challenges. All right. Nadia.
Good afternoon, Chair Henderson. I'm Nadia Goldmoretz, and I'm the Executive Director of the Young Women's Project. Thank you so much for this opportunity to testify and also for your patience in getting all of our young people on the call. It's always an adventure to try to get everybody through, but luckily you were able to hear from a lot of people today and to get a sense of the work they've been doing. I'm here today mostly to testify about our work as the grantee of the peer educator pilot that we were awarded by DBH last year and a continuation this year. The purpose of this work is to engage a cohort of youth leaders, train them intensively on resilience building and other mental health issues, and then have them engage their peers through in-person, one-on-one training and education, social media, text message, and virtual education, and then also to work side by side with counselors and the DBH clinicians in order to really connect young people with those folks. We have been implementing this grant in 30 charter and DC public schools. We have been grateful to work alongside Dr. Barbara Bazron and her team. We're especially grateful to Sharnita Scott and Marcy Thurston for their support. And the grant really involves 4 main strategies. I included a lot of information in this testimony, more than you probably need or want. But as I said, it's the in-person training, it's the social media, it's working with the counselors, but then it's also compiling all of this information in order to make it available to the public through a dashboard, which is something we'll be working on in the spring. There are a couple of challenges I do want to flag that we are having with implementing the grant. Like I said, we've met all of our outcomes. We've reached more than 11,000 young people in the past 2 years, and we met our outcomes in terms of education, but we are still working to try to figure out the best way to work with counselors and DBH clinicians. As you know, there isn't really an infrastructure in place. As a lot of young people have mentioned, there is no consistent infrastructure that young people could connect to so that they can sign up for counseling or they can join a support group. And that's one of our primary recommendations. It would go a long way in terms of helping to connect young people to mental health support, but also just the need for more collaboration. And everyone pretty much right now is kind of staying in their lanes in terms of DBH, DCPS, Our Minds Matter is the nonprofit DCPS works. with. And there is a real need to bring those folks together at the high school level so that we can identify some common goals and strategies to pursue. So we look forward to that work, and I'm happy to answer any questions you have about the work. Thanks so much again for this opportunity.
Thank you. And our last one is Rosalina Burgos Gill, Jubilee Heads Jumpstart. Okay. All right.
Good
There she
afternoon.
is. Good afternoon.
Thank you for the opportunity to testify. I have to say first that I am impressed by the students that have been here. And I think that our call to support all these services is to make sure that we continue to create and develop those kind of citizens for the present and the future. Good afternoon, Chair Henderson and members of the committee. My name is Dr. Rosalina Burgos Gil, and I am the Executive Director of Jubilee Jumpstart, a high-quality early childhood education program in Ward 1. I'm here today to emphasize the importance of healthy futures and the urgent need to expand access to this critical mental health support program for all young children in the district. Jubilee Jumpstart has partnered with Healthy Futures since 2017, receiving invaluable support from our dedicated clinician, Dr. Anais Lugo-Axman. Her weekly visits provide direct classroom support, equip teachers with effective strategies, and help us create a nurturing environment for children navigating big emotions. This collaboration has been particularly essential in addressing the lingering social emotional challenges children face post-pandemic. Young children express emotions through behavior. They often lack the words to say they're sad, anxious, or overwhelmed. Without guidance, these emotions manifest as hyperactivity, withdrawal, or aggression. Healthy Futures bridges this gap. Dr. Anais helps teachers interpret behavior as communication, identify triggers, and respond with understanding instead of discipline. In one case, a child who began acting out unexpectedly was struggling with the birth of a new sibling. Thanks to her support, we helped the family understand and address the child's needs, improving both classroom behavior and family dynamics. The benefits extend beyond the children. Our teachers feel supported, not judged. They trust her as a resource who strengthens their ability to manage challenging behaviors, reducing stress and burnout. Her work has also fostered a stronger collaboration in our bilingual program, helping staff build confidence in bridging language barriers. This kind of professional and emotional support is essential in a field where burnout is high and expectations are ever growing. Healthy Future is a lifeline for our children, families, and educators, yet access to this program is limited. Every early childhood center in the district should have the opportunity to benefit from this level of mental health support. The need is clear and the impact is undeniable. I urge the council to prioritize funding to expand Healthy Futures, ensuring every child has the support they need to thrive. Thank you for your time and commitment to the well-being of our youngest residents. I welcome any questions you may have.
Thank you. And thank you to the panel of witnesses who testified. I know some of the young people had to go, but I want to ask some questions. For Nadia, if you're with us still, I want to ask, the training that you all do, who is leading that training for the young people?
Yeah, so we have a staff of 6 adults, and we work in teams. The young people are organized into teams of 20 to 25 that are school-based. We meet in libraries. We have 7 teams that meet every week for the mental health work, and it's led by adult staff trainers.
Okay. And how is this different than the work that you all do on sexual health education?
It's pretty much the same model. The training format is the same, but the content is very different. And the work that the young people do in the schools is different for the sexual health team. They do condom distribution. They still do classroom presentations. They still do social media and VPSA messages, but they are connecting young people to the clinic network in their case. Whereas I think with the mental health group, they're trying to connect young people to the counselors and the clinicians.
Okay.
So it's
And I know that
it's very much parallel.
Okay. I know there was some delay in getting up and running on this particular grant. So how many months would you say that the students have actually, after post-training, have been, actively doing the work, if you will?
Yeah, so we got the grant in the first year, last March. We were up in April educating young people. And the reason is because we were already on the ground doing the work, and we were able to pivot, recruit peer pilot educators from our existing group of young people. And then so we had 30 last year, hit the ground in April, educated close to 4,000 young people in the schools before the end of school. And then this year, we brought on a new group in September. And so we have 121 young people right now on the ground working as part of the peer-to-peer pilot. So yeah, we're over the number we have. I think it'll drop down a little bit in the spring, but we've already almost met the objectives, and it's only February. So
I think as we go into the budget process, it's going to be important for us to understand, impact, especially since, right, I have one LEA who's telling me, well, we already do this. This is duplicative. We don't need this additional piece.
Yeah, there's another group I mentioned in my testimony called Our Minds Matter, and they're they're a national nonprofit. They work with DCPS, and they also work with OSSI. They're, I think, also contracted with OSSI. They have a model, and the models are very complementary, but their model is, they recruit adult facilitators, usually counselors, in the schools who receive a stipend, and they do monthly or sometimes bi-monthly groups with the young people that are more activities based. I included a link in my testimony, but it's like creating vision boards, doing school affirmations, so it's, I think about cultivating kindness. I think whereas our work is really focused on a very intensive resilience building curricula that includes, relationship building, problem solving, mindfulness, meditation, breathing, and it really trains a group of leaders who then train their peers. So it's much more intensive. Our young people spend 4 hours a week with us, 2.5 in person, another hour and a half virtually, and then they work in the schools for an hour to 2 hours every week. So it's a lot of hours of training. It's a lot of hours of intervention. I think,
I mean, and I'm going to leave you out of the drama piece, but I've had conversations with the chancellor. I've also talked to the director of the Department of Behavioral Health, because I feel like what has been happening with this particular grant in some ways is petty. Frankly, if one program was hitting all of the need, I wouldn't have, this is my 3rd year chairing the committee, I would not have, lists of young people who are coming year after year to talk about how they need additional support. So something is not working, but I feel like there can also be compliments as well, as opposed to pushing one out to silence voices. And so I've had that conversation with those agencies, and I hope that we can see a resolution soon on some of that. Ms. Burgos, Gil, thank you for your testimony. We've heard a lot of people who testified today about the Healthy Futures program, and we'll be sure to ask some questions about that on Wednesday. But I don't have any further questions, and I don't have any additional witnesses who are here, so I want to thank you all for being here. I want to thank all of the public witnesses who spoke today. We made it. What time is it? Woo, it's 4 o'clock. All right, 10 to 4. We've been here. Your testimony is critical to ensuring that the committee understands how the Department of Behavioral Health is serving residents. I know some folks dipped into comments about the budget today. That's a separate hearing. This is about performance, right? And trying to understand, did the agency do what it said it was going to do? Did it provide the oversight that it said it was going to provide, the grants, et cetera? And so, frankly, the testimony that we heard today, I thought was very illuminating. And I certainly want to express again my sincere gratitude to those who shared personal stories here. I know how difficult that can be in some cases to relive trauma and to relive trauma in public and share it with other people. So thank you so much. The record will remain open until 5 p.m. on Wednesday, February 19th. So if you were unable to attend, but you still want to submit testimony or you want to submit additional testimony, you can do so for the record via the council's hearing management system website at dccouncil.gov/hearings. Our next oversight hearing, next oversight hearing, we're recessing this hearing. Part 2 will pick up on Wednesday, February 5th at 9:30. We'll have Dr. Barbara Bazaran and her team here. Oh, I'm so sorry. It is not at 9 o'clock. It is not at 9:30. It is at 2 p.m. Again, Wednesday, February 5th at 2 p.m. There being no further business before the committee at the time, we are recessed until Wednesday. Have a good one. Thank you. I'm glad